Manis, are you there? Hello. Manis? नहीं हम क्या रहे हैं बस
नहीं बोल रहा हूँ माइक से
हाँ hello Manis, are you there?
And I request our editors to join in. Dr. Banambar Dey, Dr. Krishna Bhajan, Dr. Prashant Naka, Dr. T.P. Samadha, Dr. Abhijit Raha, and Dr. Vedant Kusuras. Their untiring and relentless efforts have made this update book
Dr. Bande, namaste sir, myself Manas.
Yes, Manas, good morning.
Good morning, sir. Sir, just in Hall A, the inauguration program is going on. Just it will take another 5 minutes, 5 to 7 minutes. After
I think it's over. I was also logged in. It's almost done. Yeah.
okay. After that, we will start immediately.
Right.
Hello, Manas. Should we start with the session?
Please stay on. Let the organizer give us and reply, please.
Good morning to all the respected delegates and faculties. I welcome you all to our first session of the day, the debate session. I would now like to introduce our moderator for this debate session, Dr. Rajesh Bhachandani, who is a critical care consultant, Apex Hospital and Research Center, Bhopal, Madhya Pradesh. Sir, I would now like you to introduce our speakers for the day. Our speakers for the day are Dr. Sushruta Bandyopadhyay, who is the Director, Critical Care, AMRI Hospital, Salt Lake, Kolkata, and he'll be speaking in favor of the antibiotics have no role in COVID patient until he is intubated. And Dr. B.D. Bande is our other speaker. He'll be speaking against the topic, antibiotics have no role in COVID patient until he is intubated. Dr. B.D. Bande is a senior consultant, medicine, anesthesiology, and critical care in Noble Hospital, Pune. So, sir, we'll start with our session now. So, Dr. Bande, you can start.
We have a recorded session, right?
Yes, sir. You have recorded session. You'll just be playing it. Just a second.
Yeah.
So very warm welcomes to all the delegates. Now we are starting with the debate, and the topic of today's debate is that antibiotics, that is prophylactic antibiotics, have no role in COVID patient until he is intubated. I repeat, until he is intubated. I mean the patient, he is intubated. So for this, in favor, we are inviting Dr. Sushruta Bandyopadhyay, who hardly needs any introduction. He is a very renowned figure in critical care. He is national teacher in critical care, and right now he is director and head of critical care MRI Hospital, Salt Lake, Kolkata. So I'll invite Dr. Sushruta Bandyopadhyay to start his presentation.
Thank you, Chairman, sir, and thank you again for the kind introduction. COVID pandemic hit us like a sledgehammer. Before we could prepare ourselves, we were facing a terrible pandemic. And before we could gather evidences, we were asked to treat patients in a war footing. So many of our decisions were taken then and there. Initially, we were scared that these patients might be having all sorts of bacterial infections, and therefore we had given lots of antibiotics. But maybe later on we rationalized our approach a bit. Today, instead of calling it this a debate, we can say that we, myself and Dr. Bande is an old friend, we are trying to find light at the end of the tunnel. Actually, what should be our stance in using antibiotics in the COVID patients. So I'll share my slides. It will be a short talk in the favor of the motion. So here we start. So first, let us demarcate the territory. I mean, what we are going to actually debate upon, or what we are trying to debate upon. So prophylactic antibiotics are given to prevent infections. Usually these are given before surgeries and clinical procedures. Sometimes they can be given in very immunocompromised patients, maybe bone marrow transplant patients. Otherwise, in clinical settings, prophylactic antibiotics are not given. They are not known to prevent sepsis or whatever, secondary infections, anything of that sort. So we'd rather talk about prophylactic and empiric antibiotic in this situation, whereas bacterial infection has been suspected along with COVID, but has not been proven. And we want to cover that. Before we can prove, we cover that. And our debate involves the patients before the intubation, that is mostly the patients with mild to moderate disease. Some of the patients might be even serious with non-invasive ventilation, but then mainly our territory would be mild to moderate disease. The problem of collateral of antibiotic usage is the collateral damage. It would have been very good that we give a good antibiotic in the first time before patient has got anything or any serious sepsis, and we prevent everything. It's not possible. Whenever the best antibiotics we give, if given for some time, that will give rise to resistant strain, and the patient will have a secondary infection. So that is our knowledge about use of antibiotics. Now, our question definitely comes: do the COVID patients present with a community-acquired pneumonia? So basically, are they admitted with a coexistent bacterial infection? That is our question. So definitely, we are going to antibiotic. We start our patients on antibiotic and treat those infections before we can get a culture or whatever it is. So this is a landmark trial. Basically, this is called. This has been marked as a major article in Infectious Disease Society of America journal, Clinical Infectious Diseases. This looked into a cohort of 1,705 patients with COVID-19 infections across some 38 hospitals in USA. And each early empiric antibiotic therapy, it was presented in 27% to 84% of the patients. So the doctors, they thought the patient might be having an infection and started empiric antibiotics, but subsequently, proven bacterial infection on presentation, I'm not talking about secondary infection, that was found only in 3.5%. So you understand that 96.5% of COVID-19 patients do not come with a community-acquired bacterial infection. It is not there. The methods where patients were admitted first to the hospital with RT-PCR positive were included. Concomitant bacterial and viral infections were looked into using cultures, serology, and PCR, all possible modes. Then the infections were considered community-acquired if they were diagnosed within the first 3 days, because after that it would be secondary infections. At that point of time, people receiving azithromycin were excluded, because azithromycin at that point of time, people thought it has got an immunomodulating action, and it was given to many COVID patients. I'll have one slide to prove that this is not true, basically. The result, an average 56% patients receive empiric antibiotics. Only 3.5%, as I've told you, have been proven to have a associated concomitant community-acquired infection. 54% of the patients who were put on empiric antibiotic had their antibiotics stopped after day 1. So they did the test and they didn't find anything, they stopped. The use of empiric antibiotic declined over time as the study was progressing over a few months. The people were getting aware and they were antibiotic stewardship, they understood what is it, and they actually stopped using the antibiotics as frequently. So basically, we understand that before the intubation, that is early COVID with mild to moderate infection, 96.5% chance that they won't have any concomitant bacterial infection. So you can use only in suspected infection bacteria. So the messages are community-acquired infections were rare in COVID patients, less early in the disease. The risk for associated bacterial infections were increased with if the patient has an advanced age, low BMI, coming from nursing homes. That is, in US, nursing homes means there's a long-term treatment centers where they have been exposed to other patients, maybe immunocompromised state, and those who require ICU admissions and low SpO2 and presentation. That is the serious patients. They had higher incidence of bacterial infection concomitant. Otherwise, the mild to moderate people, they didn't have any concomitant bacterial infection. They also used procalcitonin. It was not very good in predicting an infection. Its positive predictive value with 0.5 microgram per ml cutoff was only 9.8. But the negative predictive value, if the serum procalcitonin is less than 0.1, was 98.3%. So that if you had a procalcitonin less than 0.1, so you can be very certain, almost certain, that there is no concomitant bacterial infection. Then there's a working party for antibiotic therapy in adults with COVID-19. This was a Dutch group. They actually went through the literature, they went through the studies, and they came with their recommendations. So they also said that the incidence of concomitant community-acquired infection were low in the COVID-19 patients, particularly patients with mild to moderate disease. This is definitely there. There is very low incidence of atypical pneumonia in patients. So covering a COVID patient that I'm not getting a bacterial culture, possibly this is an atypical pneumonia, and we covered that with azithromycin or doxycycline or whatever it is not required, basically. Across several studies, the use of unnecessary empiric or prophylactic antibiotic was very high. In spite of this, as I told you, COVID hit us like a sledgehammer, and we are trying to deal with a disease which is unpredictable, would suddenly turn bad and kill patients, and patients were otherwise not so ill. So people, they reacted, doctors, they reacted and they started giving antibiotics, but possibly they were not required. Continued recommendations, none of the laboratory testing nor severity scores were better than usual clinical methods to diagnose the infection in COVID-19 patients. So use your clinical acumen to see whether the patient, you feel like the patient might be having a bacterial infection or not, and then decide. There is a high incidence of secondary infections in the patients, of course, it is 20%, particularly in those who are serious and with life supports. That's a different issue. I'm not talking of that. That is the patients who are basically have come, have spent some days, and then they are getting life supports, intubation, etc. They are be getting secondary infections. You need to treat them. That's fine. And this is another trial, as I told you. This is an open trial of azithromycin versus standard care of patients with moderate COVID-19. So this azithromycin was given both ways, as an immunomodulator and as an associated atypical pneumonia coverage empiric in open label trial. And you can see the graph. I don't need to go into the details. 292 patients with mild to moderate COVID were studies and given azithromycin, and 147 were controls. And there are absolutely no difference in the outcome or hospital stay or mortality in this two group of patients. So possibly this also does not work. So what do the various guidelines say? They went through this, and WHO specific, no antibiotic therapy or prophylaxis or patients with mild to moderate COVID unless signs and symptoms of bacterial infection exist, period. UK NICE, do not use antibiotics for preventing infections in COVID. It doesn't help. Only use antibiotics if there is a strong suspicion of additional bacterial infection. Period. Dutch Working Party on antibiotic policy, avoid antibiotic use in suspected COVID, unnecessary antibiotic use in suspected COVID-19 patients. So our recommendations, avoid using empiric prophylactic antibiotics in COVID-19 patients, particularly in those with mild to moderate disease. No use routinely prescribe antibiotics for atypical pathogens. Routinely send cultures, that is very important because you pick up the infections, rare but definite infection. Use serology and PCR-based tests to confirm or say exclude bacterial infections. Use antibiotics as per local trends or culture, that is of course there, and de-escalate antibiotics if bacterial. If you don't find bacterial infection, be bold enough to stop the antibiotic. Do not linger. Then my patient is serious. Let us continue. What's the harm? It does cause harm. Thank you.
Thank you, sir. Nice presentation, Dr. Bandyopadhyay. Now, trials, and but if we go reverse, if we go from benchmark to bench, that means the real COVID warriors which they were facing, and they have used the antibiotics. So I'm inviting to against the forum Dr. Bande, who is a senior consultant in Novel Hospital, Pune, and he has been a member of training the trainer programs, and he has so many awards. It will be a very short time to describe all the achievements for Dr. Bande. Overall, he is a very nice person, but now he'll be going against the forum. Until we discuss, we won't reach a conclusion. So, Dr. Bande, please.
Thank you so much, Dr. Bhakchandani, and thank you, Sushrut, for elaborating that and just trying to justify the point, which obviously I don't agree with you at all, and I will try to prove myself why I don't agree with you. Now, antibiotics which are prophylactically given have no role in COVID patient until is intubated sounds a very ridiculous statement. It's like saying wearing helmet has no role unless the one drives a bike more than 120 kilometers. And at slow speed, obviously there could be accidents. So saying this kind of thing can be a very blank statement, which is not acceptable that way. Now, is intubation the only risk factor? That too in COVID, where immunity is impaired by various mechanisms in COVID patients, is obviously not the only risk factor. There are many other risk factors. So relating antibiotics only to intubation will obviously very, very unjustifiable state. There will be obviously infections in terms of pulmonary as well as non-pulmonary. And We know that there are so many risk factors. We'll be elaborating it. And still we don't want to give antibiotic, which is, I think, going to be a huge risk for the patients who are likely to get infections everywhere in the body. And surely, if I had a count to be made, and I'm sure 100% people will raise the hand that they have been using the antibiotics, if not prophylactic, at least empirically. And so did try to give some papers where they used empirical antibiotics, like IDSA paper, which was most of the part talking on. They did give about 74% patients where they did de-escalate later on, but initially they did give it. After they found that there is only 3.5% of incidence of infection, probably they de-escalated. But the point remains, you do not know what risk who is going to have and whom to choose to give and not to give, and that is the real issue here. So prophylactic and empirical, we all know the definitions. I will not go into this. The reason to mention here is there's a very thin boundary between thinking of prophylactic and empirical, because empirical will obviously give in a way patient very strongly suspected. But if there is a failure to suspect and failure to diagnose, then we'll obviously be labeling it as a prophylactic. And so it either goes prophylactically or empirically, because there is a difficulty in differentiation. Now, you can look at this particular data. In this paper, 506 patients with COVID-19 were evaluated, and they probably gave antibiotic in 74.5% patients initially, only to realize that I think they are overdoing things. But maybe, as I said, they could not realize what to choose, whom to give, etc. But they did try to find out that some intervention guideline where they could limit the antibiotic, and that is, I think, a rational step which we all practice. Presence of leukocytosis, fever, chest imaging suggesting bacterial process of infection, respiratory bacterial and viral panel isolation, etc. After that intervention, they found that 42% patients only needed the antibiotic, and that's a very big quantum according to me. Now, to exclude the remaining 58% patient, what criteria are you going to think of? It's very, very difficult to think about, and that's the reason most of the people end up in giving majority patients. Now, VAP load is something very high in our country, and this is a paper from Dr. Dhruv Chaudhary and team, where he has documented VAP of 57%, and with that to mortality of 48%. In this paper of 105 patients studied, he has tried to elaborate on why there is a high mortality. We'll not go into those details, but the quantum of VAP is very high, and that itself will say that if you are going to have these kind of patients, this is in the patient where there is no COVID probably, and there are probably lesser risk factors. In COVID, we have so many risk factors. I will be coming to that in a short time. It is not essential that infection in the lungs will occur only after intubation. And we all know, besides intubation, there are other interventions which also can predispose to infection. Lines are there, Foley's is there, and nutrition is also going through sometimes parenterally and all those things. But in this patient, hospital-acquired pneumonia, even in non-ventilated patient, was in 26%. So the patients who are not intubated also have a bigger quantum of infection possibility of HAP, hospital-acquired pneumonia. So you can imagine what risk we are going to face if we don't give antibiotic to the patients, provided we exactly know whom to give and whom not to give, but that is often not possible. Now, our own guidelines from Indian Society of Critical Care Medicine came 2 years back, and they tried to find out which antibiotics and which kind of a spectrum of bacteria is causing the problem. And they tried to find out that Acinetobacter and Pseudomonas were the main organisms. But I think last 5 years, Acinetobacter is getting replaced by Klebsiella. And that's why I put out the question mark there, because they probably had data which was a little older of this decade. But Pseudomonas and Klebsiella now are causing problems which are essentially MDR. And we have hardly any antibiotic besides colistin and polymyxin B, which can be effective against these organisms. And of course, there are many pathogens that can change depending on the ICU. It can depend on many other factors. Now, they also elaborated or emphasized the risk factors which are likely to cause these infections. Now, look at these 7 factors: age, duration of ventilation, antibiotic use which was there before, and presence of severe sepsis, ARDS, RRT, and of course steroid therapy. You tell me now, which factors are not there in COVID patients? Practically all the factors are going to be there in these patients, and this they have labeled as a risk factor which is predisposing to VAP. Now, it is almost certain that there will be a superadded bacterial infection in all these patients which we are looking at, that is moderate and severe category, those who are going to head to the intubation. Now, the risk factors which can be further elaborated on, and as I said, use of immunomodulators has been very, very common. And basically, just like intubation came in many patients electively or later on, practically immunomodulators came in all the patients where the storm was seen, which we diagnosed by increased markers in most of the patients and presence of hypoxemic, which was worsening kind of thing. Hyperglycemic tendency, we saw absolutely a problem in controlling blood sugars. And if hyperglycemia is going to be there, there is an invitation for infection for sure. And I'm sure there are all these factors of prolonged ventilator support. We have ventilated patient for 2 months. Okay, prolonged ICU stay, multiple intervention, nutritional depletion was very commonly seen in all these patients. And of course, we restricted diagnostic procedures. We did not do BAL, we did not do bronchoscopy. So it was further difficult to know which patient actually has the infection. Okay, this is a historical data. In a century back, we had this epidemic, influenza pandemic rather to say, and most of the deaths were attributable to secondary bacterial infections. That time, of course, there were antibiotics, etc., were limited. But now this is a historical predisposing evidence that there is a problem which is quite severe. So coming in a recent times, 10 years back, we had H1N1 pandemic, and 1 out of 4 cases had severe presentation complicated by secondary bacterial infection. That is a very big quantum again, and up to 55% deaths were linked to secondary infections. Now, we cannot ignore these statistics, which is historically with us. Okay, coming in a recent times, in the first phase of last year, that is 2020, first phase of SARS epidemic, look at the quantum of antibiotic people were given. 75% in severe as well as equal quantum in the mild to moderate cases. So people were just probably not sure where not to give. And this kind of, look at this recent is a study which is at the same time, January 20 to May 20, and it's from Hong Kong, 147 patients studied, and 42% showed clinically suspect infection. I'm sure the most least suspicion, and then you'll give most possibly an antibiotic, that is 42% patients. So it nears almost near 50% or more patients are likely to get antibiotic. Going internationally, 166 participants responded across 23 countries and 82 hospitals where they used CAP guidelines, and 70% people used antibiotics either empirically or prophylactically with the duration of 7 days. That's a very high quantum. Okay, this paper was, I think, shown by him also, and the other paper probably. This paper particularly shows a review of 19 clinical studies, again showing the antibiotic quantum use of 74%. That's a very huge kind of a use people have been using. This is a paper from my own institution. And we are actually had a policy to give antibiotic to all the patients who were going on tocilizumab. So this is the total study of 515 patients of the first wave, where we had 550 patients who received tocilizumab, and you can see in the majority patients who received antibiotic, practically 100% patients as a protocol received antibiotics, and the infection complications obviously were documented, but there are not too many, and we didn't have too many deaths due to infection subsequently, indirectly justifying that probably antibiotics kind of prevented the infection in the patient, because all received tocilizumab and steroids, of course, combination. It's a good paper. You can go to later. The antibiotic prophylaxis. Any further evidence now? They tried to find out whether CRP or PCT can be useful to choose the patient. But the problem with PCT, Dr. Shushruth also told us, PCT has been of least use because PCT concentrations have really been modified by giving steroids as well as immunomodulators, and they have not, it has not been a very proper guide which we often try to use in non-COVID conditions. So this particular parameter was obviously not useful. Now this particular paper supports that dexamethasone and tocilizumab treatment considerably reduces the value of C-reactive protein, and obviously there was a rebound rise of PCT subsequently when there is probably no infection. So it goes without saying that PCT really cannot help us, and CRP is rather for the non-specific. Are there any guidelines? We are talking that antibiotics are given by the other people. So what guideline we should follow? Just the paper are not enough. Whether guidelines, WHO came with a guideline in an early period of COVID wave last year. This just said that to be based on clinical judgment and patient-hood factors, it was absolutely a imprecise guideline given by WHO, and we couldn't get much information from this. This is a Dutch group, and Shushruth did mention this particular paper, and they tried to say that it is difficult to distinguish, and that's what I am harping on, because if you cannot distinguish, it is very difficult to withhold the antibiotic. We recommend to start empirical treatment after obtaining cultures. So practically all the patients will get by this recommendation. And again, they said ki procalcitonin levels to be used as a guide, which IDS is already disposed because, and even the previous paper said PCT cannot be used. So we cannot. Now, this is the most recent guideline coming from UK, NICE guidelines. Look at the what advice they have given. They said that these are the risk factors, and in this situation, consider specialist advice. Now, what do you think advice from specialist will come? In bottom line, it will come as please give antibiotic to all these patients. So again, NICE guidelines are not very clear on this. They have tried to classify people who are high risk people, immunocompromised, COVID patients, immunity is impaired by the disease, by steroids, by immunomodulators, by previous antibiotic therapy if at all, or some other comorbid factors like hyperglycemia and hypertension, etc., renal failure, okay, other disorders leading to immunity compromise. So in COVID disease, who have already acquired moderate and severe disease, most of the people are vulnerable to get all kinds of infection. And these guidelines obviously were not, again, not very clear. Last slide, use of antimicrobial prophylaxis only when the benefits outweigh the risk. This is typical government advice from our 2022 guidelines from the FMist. It is left to our wisdom because this guideline does not give anything clearly, and it is left to our own wisdom to go ahead what to do. So to conclude, I will say prophylactic antibiotics have a definite role even before intubation. Okay, risk of bacterial co or secondary infection is high, and I told the reasons why it is very high. There are too many risk factors to predispose. It's not easy to rule out presence of bacterial infection by the available methods, that too we are restricting bronchoscopy, etc. Benefits of giving antibiotics for the COVID patient is likely to outweigh the risk. What are the risks? Risks are antibiotic resistant, but not applicable to that particular patient. It may matter for other patients. For this particular patient, we'll obviously need to outweigh the risk of that kind, and maybe addition of fungal infection, etc. But we do not know. In this patient is going to happen. For this particular patient, if we are going to prevent all the possible infections which I described, it will be a definite benefit for this patient outweighing the risk. Guidelines are not clear, as I said, 3-4 guidelines, but there is nothing clearly mentioned. So decision to give antibiotic is left to wisdom of a treating physician. And I think with our best wisdom, we should not make a mistake of not giving antibiotics with so many risk factors which are described. So we obviously need to look into those factors and decide. So thank you very much for this.
Thank you. Nice presentation, Dr. Bundy. So what we could conclude now is that viral infection is already a ground for invitation for several bacterial and fungal and co-infections, right? And because the immunity to that patient is low, that's why he is in the hospital requiring higher amount of oxygen, and maybe persistent hypoxia would lead to administration of steroids and immune modulators, and so much before the patient is admitted to you. And another very important point which I like, Dr. Bundy said that why intubation only? It's not only the respiratory system which is prone for making the patient ill, because before taking it to your hospital, the patient might have been catheterized, the patient might have been resuscitated, the patient might have been given high flow nasal cannula, the non-invasive mask and whatnot. So, Dr. Bandyopadhyay, do you still agree and have to something in rebuttal, please?
Myself and Dr. Bande have always agreed on every matter. So here too, I think in all of his slides, I'll agree except for two. One is basically what he has been telling. I'm not against it, that COVID makes the patients vulnerable to infections. COVID gives rise to secondary infections. I have showed that 20%. In our country, it might be even more infections. They are often, if you're in ICU, there might be MDR bacteria. But I'm only against two things. One is do not use prophylactic antibiotic to prevent infection. It has not been shown. Had it been so, had been a prophylactic antibiotic good in preventing infection, it would have been made our job very easy. Any man has got money, we start him on 4 antibiotics in the beginning, we cover all possible pathogens and the patient will never have an infection. It never happens. You try this, the patient will have an infection which is resistant to all 4. So please do not prescribe prophylactic antibiotics to prevent infection, except as I have told you in surgical or other procedures, or a very specific situations like solid transplant, organ transplants, etc. Otherwise, it doesn't work. In ICU, to prevent give a big antibiotic to prevent infection is deadly. You give rise to a whole lot of germs which are resistant to that antibiotic. I'm agreeing with this one slide which he feels that from our debate point of view, where it has shown that antibiotics are not necessary in non-intubated patients. He has shown one slide which shows that 26% of hospital-acquired infection occurred in non-intubated patients. I fully agree with that. But that should be an empiric. You think that the patient has got pneumonia, you can definitely treat, but be brave enough to see that if you're not getting cultures, or if you can explain the extracetus next day with a heart failure, please take off. Our problem is that we all start antibiotics when we feel there is a need for empiric antibiotic. But we are not brave enough to stop the antibiotic when we are even certain that the patient does not have any bacteria. So that is when the history will be written and enough data will be collected from India. We would be all guilty of using unnecessary antibiotic or in so many patients, in so many situations where it was not needed. Thank you.
Yeah, I think like every coin has two sides, two aspects. So Dr. Bandyopadhyay is seeing from one aspect and Dr. Bundy is looking from the other aspect. One of the slide of Dr. Bundy, I very much like that wearing a helmet on before you are riding on a bicycle, but that's still the speed of the bicycle.
I'll just make one interruption. Helmet is good for all people, but helmet does not give rise to resistance strains. So if you wear helmet, it is not going to give you extra rise. But mind it, any antibiotic given will give rise to one resistance strain. So you'll have to always balance with that.
One thing, we are talking about this topic about intubation and COVID and antibiotics. Can you classify if you think the same patient is being treated in a primary care small 10 bed, 20, 15 bed nursing home, or the same referred to a 50 bed intensive care where it is tertiary care, and now the same patient has been referred to a quaternary care center like yours. Now, which will be the area where you will first see and start antibiotics, or you will still say no antibiotics?
So I'll say a few words, Dr. Bhakchandani. I do agree with Dr. Shushruth principally, but what he is forgetting is this particular lot of patient is not the usual lot of patient.
Exactly.
We do follow principles everywhere. That thing against, but COVID patients have put us into a difficult situation where we are not able to clearly say whether the infection is there or it's going to worsen or not. And that's why in my institute, I showed the statistics, and this was the first wave. Second wave will come out of the paper in coming few weeks or so, that we made a protocol to give antibiotic to practically all the patients, because all the patients were going to receive immunomodulation of some kind, and all received the antibiotics. Now we'll see whether the infection rate was really less as compared to any historical cohort which might be taken from literature. But again, I'm saying, looking at the risk factors, even IDCCM or ISCCM guidelines which are given, the risk factors they describe, we perfectly fit our COVID patient according to those guidelines. And even if you go by those guidelines, I will be still justified to give antibiotics even before intubation. Thank you.
Dr. Bundy, which antibiotics you will and how you will select the antibiotics?
Because we know the gram-negative organisms are in majority, our gram-positive hospital-acquired infection incidence is coming down drastically. That was another point we recently described in our conclave. But for this Acinetobacter, Pseudomonas and Klebsiella, which are going to form about 70% of the quantum of infection, we obviously start from piperacillin initially and escalate to penems, meropenem most commonly, and of course give a gram-positive cover in the form of teicoplanin, most of the patients. And subsequently, if the duration is too much and if there is any other reason to discontinue, maybe we will add linezolid besides instead of teicoplanin. So this is a typical combination which we used, and we had to often use colistin and polymyxin as we received the reports of isolation, but that was after, once we received the reports. And then accordingly we changed to colistin or polymyxin B, tigecycline if required, and this is typically going on. And the recently added one combination of ceftazidime plus avibactam, somehow, because though the molecules are older, it showed a lot of sensitivity to all these MDR pathogens, and so that was the combination which we used as a third or fourth resort in most of these patients.
Dr. Bande, my question to you is, because we are on a platform where the whole nation is watching us, and most of the aspirants in critical care, they are working in a 10-bed hospital, a 50-bed hospital, and a 100-bed tertiary or quaternary care center. Now, I would like to explain that if you are working in a 10 to 15 bed hospital and the patient is coming directly from home without any history of antibiotic prior to 3 months, what prophylactic antibiotic will use? And then if the patient is referred to stage 2 hospital, a 50-bed hospital ICU, what antibiotic you will use? And the patient has finally come to you without getting any antibiotic, what antibiotic will be of your choice? And what will be the criteria of selecting your antibiotics?
So here I will agree, if it is in the smaller nursing home coming, probably possibility of infection right there, it may be a mild to moderate case because they may not keep severe cases or moderate cases to severe cases going. In that case, most of the patients may not receive antibiotic because depending on the suspicion and the diagnosis possibility. And if at all they want to add, generally we can start with azithromycin combined with ceftriaxone as a basic prophylaxis, or empiric for that matter. This will be the beginning, which can be upgraded if you get a further indication, further isolation, or any further evidence of culture and sensitivity based data.
That's good. Dr. Bandyopadhyay, you have to say anything in rebuttal again.
We are already possibly going beyond the time. I just said that, again, as I've told you, if you feel that patient is an empiric antibiotic, you will see if it's a community acquired, you should cover DSPL, ABSCs. That is, you should possibly use a penem in that case if the patient is very seriously ill. And we also give a gram-positive. You use a lot of ceftriaxone here as a gram-positive. It has got a good gram-positive coverage against MRSA. And if you feel the patient already were exposed to these antibiotics, you'll have to go to higher generation, maybe cholestyramine, polymyxins, and with tigecycline. Sometimes we also used ceftazidime, avibactam with aztreonam.
So, gentlemen, ladies, we have come to the conclusion of this debate that now we see both the stalwarts have agreed that empirical antibiotic, unless not necessary, of course, should not be used, and it should depend upon the physician's discretion who is on over the bench who is treating. If he feels no, he should not use, but if he feels that this antibiotic should be used, they can be used.
So empiric antibiotics, yes, but not prophylactic antibiotics.
Yeah, of course. Now, the message clearly goes that we should practice bundles of sepsis, whether any infection is there. Our nursing staff should be trained enough, because we have seen in most of the 10 and 50 bed hospitals where the same embo bag was used from all the patients, the same vein circuit was used for all the patients. That was the only indication that compelled us to use antibiotics when the patients are referred to the tertiary care and secondary care units. So the message clear cut for the primary care physicians, for the primary hospitals, that they should maintain as much as a sepsis possible. Then the care of catheters, embo bags should be thrown because the cost of one embo bag is equal to one vial of cholestyramine, you can understand. So I would say that before coming to a discussion of antibiotics, comorbidities should be assessed. The patient's prior stage of whether he has taken antibiotic in the prior 3 months should be considered, and we should avoid prophylactic antibiotics, but empirical antibiotics can be taken, because a lot of antibiotics we must have seen, and there is a lot of evidence that when a lot of antibiotics we end up with too many coexisting infections like fungal infections and mucormycosis. So that's a ground, it's a two aspects of a single coin. So with this, I would invite Dr. Bandyopadhyay again to give a last note in a single sentence, followed by Dr. Bundy's remark.
Yeah, I think I've made my position clear that please do not use antibiotics as prophylactic antibiotics. This is not done. But then if you have got a strong suspicion of a subsequent bacterial infection, do use antibiotics, give a broad spectrum coverage, depending on the patient you feel is community acquired infection or hospital acquired. but also be bold enough to stop the antibiotic if you have got enough evidence to show the patient does not have a bacterial infection. Or maybe if the patient has got a gram-positive infection, then stop the PNMs. The patient has got a gram-negative infection, stop the tacrolimus, whatever it is. Be bold to do that. Thank you.
Dr. Bundy, we have seen
Yeah.
doctors using so many antifungals also, empirically, prophylactically also. How about your
Yeah, because even my institute we used fluconazole in very high risk patient where diabetes and possibility of infection was very high due to very many other factors. So I will again say be rational and use your best wisdom in a given situation. And though we do not have clear guidelines, we can make our own guidelines for that particular patient. Thank you.
Thank you, sir. Thank you very much. Thank you to both the participants. I think we have done the justice and have spread the message to all the aspirants. Thank you very much.
Thank you.
Hello. Yeah, good morning, delegates. I think you have heard the message, which is very clear, and the two speakers have put their own aspects, and we have discussed everything that when and how antibiotics should be used. Of course, one side we know that antibiotics can save life, but all the patients in our sepsis guidelines also we know that antibiotics are the cornerstone of saving patients, and most of the patients who are admitted in COVID-19 patients were in sepsis or SARS. So a physician should be very judiciously pick up the antibiotics. The things remain very tricky when the patients are referred from other hospitals and they are having some comorbidities. And hence we have come to a conclusion that no prophylactic antibodies should be used, but empirical, depending upon the patient's comorbidities and patient's condition, using your own hospital's bugs, antibiograms, one is free to use, but not from the higher antibiotics. And upon the SOFA scoring, Apache 2 scoring also should be done to conclude whether antibiotics are necessary. As discussed by our previous speakers, scoring for procalcitonin and CRPs, they may produce a false readings and the reports may be delayed for some or the other reason. So when it is really necessary to save the life of the patients, we can involve. So what is your take, Dr. Bandyopadhyay and Dr. Bundy? And at the same time, we'd like to invite questions from the audience.
I think we had a lively debate last time when we recorded the thing. So again, we have been sticking to our points. I agree with Dr. Bande that these people are liable to have severe infections. They're immunocompromised. There are infective complications. And whenever you feel there is a serious bacterial associated infection, you're free to use empiric antibiotic as per the scenario, as per the patient's conditions, and as per whether your hospital flora and whether you feel it's a community acquired or a hospital acquired infection. I have got nothing to say against that. But my idea is that please do not use prophylactic antibiotics that just a patient has come and I need to give antibiotic anyway. That sounds very attractive, but that should not be done. One slide or one statement of Dr. Bande, I would strongly disagree that all patients with tocilizumab should be given antibiotics. So it's not like that.
Maybe it's an individual experience, but tocilizumab has been a good immune modulator, suppressing the immunity to a large extent. Dr. Bundy, you have to say something.
I will respond to the disagreement which Shashru just mentioned. And I showed a paper from my own institute where 500 plus patients were documented. And as per the protocol, we use antibiotics in all the patients who received tocilizumab. That was in the first wave. And we followed the same thing in the second wave. So I think 500-600 more patient data is with us now. And the infection or sepsis, which was contributing to the death ultimately, was less than 3%. So probably we have been successful to prevent sepsis leading to death or mortality related to sepsis and severe infection to quite a successful situation. So, but the antibiotics use based on guidelines or any other parameters has not been very effective. And that leaves a very much gray area as to where to give and where not to. But as I said, we can always use some parameters, clinical judgment, and of course the guideline available or the subsequent cultures available, etc. And we can proceed with appropriate antibiotic use.
That's nice.
Rajesh, can I come in?
Yeah.
Yes.
I'm Dr. Balla, and I was keenly listening to both the speakers, and sir, we need to remember that the message is going to very many people who are youngsters and who are following and who are not working in tertiary care hospitals or even beyond that. So what happens is that if we say that empiric antibiotics, anyone, any intensivist can justify empiric antibiotic in any patient. It's just like using a Candida score in a patient with ICU. You do that, every patient fits. Every patient fits who's a critically ill patient will fit into the scope of getting antifungals or antibiotics. The message which has to go to the youngsters and the people who are practicing in the areas of need or in the periphery is that if we use our immune modulation, that is steroids, in the prescribed dose for a prescribed duration, we may not need antibiotic coverage for everyone. Only in very severely immunocompromised patients. Plus, you need to know what organisms you are dealing with. In case you don't have that kind of an information, I'm sorry, Dr. Bande, your data cannot be extrapolated to a 10-bedded ICU running in a peripheral center. My data from PGI cannot be extrapolated. They have to generate their own data of hospital-acquired infection, or for that matter, community-acquired infection, which is lacking. And that is why I would not probably say that, I would give antibiotics to everyone who comes with COVID.
Thank you. I agree.
Any other comments from the audience? Manas, is there any question in the chat box?
Not yet, sir.
Okay, so can we conclude the session?
Yes, sir, you can conclude this session.
Thank you. Thank you very much. Thank you
you, sir.
all the participants, and have a nice day. Thank you.
Bye.
Thanks.
Thank you to the speaker and the speakers and the moderator for this very enlightening session. And now we'll conclude the session. Thank you.
Good afternoon, sir.
Hello. Hello. Hello.
Yes, Dr. Kawada and Dr. Dongre will start in another 3-4 minutes.
Yeah, am I audible?
Yes, sir, you are audible, sir.
Okay. Visible. Visible.
Yes, sir, you are visible as well.
Okay. Who is going to start? Can you give me just in short?
Sir, our
Hello.
anchor, Dr. Amrita, will start the proceedings
Right.
to invite you for the introduction of the speaker.
Right. Okay. And about speakers, have you got any? First speaker first, isn't it?
You'll have on the screen, sir. Don't worry, sir. You'll have on the screen.
Okay. So the first speaker first, and then second speaker comes after that. After
Yes,
the
yes,
lecture
sir.
is
Yes,
over,
sir. Yes,
isn't
sir.
it?
Yes, sir.
And in
Yes,
between
sir.
we have and
Yes, sir. Yes, sir.
hello.
Yes, yes, sir. Yes, sir.
Other chairperson who is there? Who is it?
Sir, Dr. Approve is there. Dr. Approve Agarwal. And
Yes,
Dr.
yes.
Arun Bansal sir
Dr.
is here.
Apurva is
Yes, I'm
Dr. Apurva.
pretty much here. Yes,
Yeah.
sir.
Will you introduce the second speaker? I'll go with the first, then second you.
Sir, I don't have received any the
Sir,
introduction of
it will come to your screen, sir. It will come to your
Okay.
screen.
Okay, okay, we'll do
And
that.
third again, is there any third chairperson?
Yes, sir. Yes, sir. Third, fourth chairperson also there.
Okay.
Four
So
person.
can you just divide that? Let me
Yes, yes,
introduce
sir.
the
Yes,
first
sir.
speaker, and then second
Sir,
Apurva, and the third will go
sir,
to the third chairman.
sir, our hall anchor will do. Sir, our
Okay.
hall anchor will instruct what to do, sir.
Okay. Right. Okay.
Good afternoon, sir.
Namaskar.
Namaskar.
आता ते मुंबईचा हाल काय आहे आता?
It's okay.
नाही आहे ना?
There are some few cases here and there, but they are not serious one. These are the just number is.
Nagpur is going zero almost.
Yeah,
Same.
absolutely.
All right. And the thing is, KEIM had the COVID ward itself.
Yeah. It's a center, tertiary care center. Yeah.
And it was 500 beds.
Yeah,
How much?
650.
No, how many beds they have given for COVID?
Sir, we are requested to you. We are at live and we are recording is going on.
Okay.
Are we starting, Manas?
Yes, sir.
Hello. Good afternoon to all the respected doctors and our faculty members. I would like to welcome you all to the first day of our conference. And the session for us is the thematic session first. For this session, the speakers are Dr. Apurva Agarwal, who is the professor, head of the Department of Anesthesiology, Critical Care and Pain, RMC Jalon, Kanpur. Our second chairperson is Dr. Arun Bansal, Professor, Pediatric Critical Care Unit, Advanced Pediatric Center, PGI MER, Chandigarh. Our third chairperson is Dr. Anil Rajan, Senior Consultant, Medicine, Amit Jaggi Memorial Hospital, Agra, UP. And our last chairperson is Dr. Anand Dongre, Senior Consultant, Critical Care, CEO, Swastik Critical Care Hospital, Nagpur. For for this session, first I would like to ask Dr. Anand Dongre to introduce our speaker on the topic available COVID vaccines. Why different vaccines? Dr. Anand Shantaram Kawade. Over to you, sir.
Good afternoon. Should I?
Yes,
Hello.
sir. Yes, sir. Now you should introduce Dr. Anand.
And good afternoon, everyone. First of all, thank you, the organizers, for getting this WC4 en route. And we are into the thematic session. The first, let me introduce our first speaker, Dr. Anand Shantaram Kawade. He is from KEM Mumbai, and he is working as consultant pediatric research and clinical trials, Pune. Currently working at at or with clinical trials of various vaccines, including COVID vaccines. So let us go first for Dr. Anand Kavade for COVID vaccines, different varieties, and how to choose. Over to Dr. Anand.
Good afternoon to all. At the outset, I would like to thank the organizer to give me an opportunity to share my experience of COVID vaccine development with this elite audience. As COVID pandemic enters into its second birthday and everything seems to be normalizing, it is high time to sit back and think about what works for prevention of COVID amidst several contentious things, and surely COVID vaccine is one of them. Despite being proved highly effective, COVID vaccine development is surrounded by debates like number of candidates and approved vaccines, speed and platform with which these vaccines has developed, safety and efficacy of these vaccines, long-term protection and equitable distribution, etc. In today's talk, I would like to take you through the COVID vaccine journey to understand the question why different vaccines and how available vaccines fulfill the same goal despite individual differences. With the rapid spread of pandemic across the globe, an effective vaccine is urgently needed to protect human and to mitigate economic and societal impact of pandemic. Despite standard vaccine development usually requiring an extensive process and taking several years to complete all clinical phases, there are many vaccine candidates in preclinical testing and clinical phases based on different vaccine platforms. Now, if we look at the characteristics of current COVID vaccines and compare it with other routine vaccine, you will find current COVID vaccines are extraordinary, unbelievable, and incredible. Till date, we have 332 candidates vaccine, 113 are in clinical trials, 22 are already in global use, and 7 of them they are by WHO. All of them have demonstrated remarkable safety and more than 95% efficacy against severe and critical illness COVID. If you compare it with the current rotavirus, has just 60 to 70% of efficacy. They are manufactured in record timing of 10 months using all platforms. The mass vaccination has started in December 2020, and within a just period of 10 months, 6 billion doses has been given. If you compare with this, the global birth cohort, it will require almost 2 years to vaccinate them with the 3 doses of pentavalent vaccine. 17.2 billion doses they are already secured, and the global spending on this vaccine is already by 2025 will be around 157 billion. To appreciate this remarkable and historic journey, we need to understand the background. We all know that in Wuhan, China in December 2019, number of unusual pneumonia patients were died. Novel coronavirus SARS-CoV was identified as a cause, and in a couple of weeks its genome sequence was isolated. It spread very rapidly across the globe, and in January 2020, WHO declared public health emergency and pandemic. With no preformed immunity and no drug to treat, in coming month, WHO urged the scientific community to speed up the interventions, like including vaccine development, and in month of March, clinical trial began. Moderna vaccine was first to start its phase 1 on 16th of March. Thus, the war was declared, frontline workers were declared as a corona warriors. Within few months, multiple stakeholder partners were entered into this war game with their own weapons and strength. To speed up the vaccine development, WHO has commissioned a group of vaccine experts and formulated the designs for vaccine trial. The ideal pandemic vaccine should be safe, efficacious, having a single dose schedule, and should prevent the transmission. For an emergency use, minimum 50% efficacy and 2 months of safety data from the trial were expected. Thus, a global quest for safe and effective vaccine has started. Many candidate vaccines are developed in hope of finding at least a couple of them safe and effective for the use. In usual scenario, only 1 to 2% of candidate become successful for use. In case of COVID vaccine, almost 6% of vaccine candidate has already proven their usefulness. This remarkable success is because of active support and contribution of multiple partners and stakeholders who encouraged and participated in this quest. The prominent players for the vaccine front are, community, government, research academia, pharma company, regulators, and other consortia. Each of these players had participated with their own strength. We quickly take a look at their role. Community, we the people. The role of common man was very crucial. With the tremendous fear of COVID-19 disease and its mortality, the need for vaccine was so palpable, everyone was talking about protection, immunity, herd immunity. The demand for vaccine was so high that even few of the known vaccines were trialed for repurpose. Highest demand from public pushed every other partner to move fast. Huge public money was poured for diagnostics, treatment, and vaccine development, in addition to money from NGO and financial institutes. The test like RT-PCR, which was previously done rarely or for only research purpose, was now made available for endpoint care, and hundreds of thousands of tests were done. People made themselves available for massive testing, showing their eagerness to solution. When the clinical trial started, there was a long list or queue of healthy volunteers indicating their zeal despite the fear and anxiety stigma of COVID-19. Thus, the need for vaccine became highest priority. Government for the people. Various government has poured huge amount of money and started all possible collaboration across the globe. They pushed the player for vaccine development even before the end of final stage of human trial or regulatory approvals. Developed countries like UK and US has entered into pre-purchase agreement with the COVID-19 vaccine manufacturers, a development that is known as vaccine nationalism. Saving the life of own countrymen has become top priority. There are fears that such advance agreement will make initial few vaccine unaffordable and inaccessible to everyone. To bring about equitable and broad access, WHO, CEPI, and Gavi has come up with the initiative known as COVAX facility, which aim to procure at least 2 billion doses for deployment and distribution in LMIs. Research, academia, technology, discoverer. Many universities and academic research institutes get involved, like Oxford with Covishield and National Institute of Virology with Covaxin. Their knowledge base is used to push and expand the research further. Isolation of genome sequence helped the scientists to identify the various molecules encoded by viral genome. It gave confidence even though the virus was novel. Institute like Oxford was already working on vector virus and use it in SARS, MERS, and Ebola vaccines, and well convinced about the safety of this platform. Lesson learned from the preclinical and clinical data of the SARS-CoV-1 and MERS vaccine trial provided sufficient experience to design promising COVID vaccine in just few weeks after the emergence of this vaccine, and the clinical trial began in March. Apart from conventional ways, newer modalities like RNA, DNA, protein particle, nano-based particle, they are used. These institutions having technology has been transferred to industries for the manufacturing. For example, the National Institute of Virology, the virus is isolated and transferred to BBIL for the manufacturing of the, for further development into the Covaxin vaccine. Number of collaboration between industries and institute occur. For clinical trial, various consortium were formed like WHO Solidarity Trials, and adaptive clinical trial designs were applied for overlapping and concurrent activities. Industry pharma, the makers. The pharmaceutical industries has driven much of the push. Companies ranging from biotech startup to giant shifted their research and development efforts to focus on COVID. Early research into vaccine candidate typically receive government funding, but bulk of the financing come from the private sources. In current pandemic, however, massive government funding for promising vaccine remove much of the risk for the pharmaceutical companies. Manufacturer collaborated with the institute and academia for the technology and viruses. They executed advanced purchase agreement with various government and non-government bodies. They started manufacturing well before approval on the large scale. They extended their capacities and continue to work with their own R&D and start developing the vaccine with newer technologies. Regulators, ethics committee, and data safety monitors and approvals. Approvals was the most important area where substantial time would have been lost. Before COVID, the regulatory approvals would take around 3 to 4 months, and ethics committee will take another 1 month so after submission. However, during this period, regulatory authorities approved the study within a couple of weeks and ethics committee within a couple of days. This has really fastened the process. Ethics committee and data safety board has geared up for the quick review and data. This has really fast-tracked the vaccine development. Stakeholders, various partnership and facilitators. Various organizations come together for the consortium for the equitable distribution like OWS, Active, COPAN, COVAX, WHO, Gavi, CEPI, World Bank, and Bill Gates Foundation were come together and form the consortium. So now we'll take a look at available vaccines, their differences and similarity in a quick look. These vaccines, they are developed from the different platforms. Some are inactivated, some are used viral vector vaccine, some use RNA vaccines, some use DNA vaccines. These different platforms give them the individual strength and limitations. While inactivated and subunit are established platform, viral vectors are newer one and mRNA and DNA are never used before. The immune response to live viral vectors and mRNA are very robust, while it is somewhat less for the inactivated and subunit vaccine. Viral vectors and mRNA can be produced on massive scale. Live and inactivated vaccine has a modest production due to biosafety requirement. They are quite stable except for the mRNA vaccine, which requires the temperature agreement, and none of them trigger the infection except for the live vaccine. Their phase 3 clinical data demonstrated variables efficacy against symptomatic COVID. Pfizer, Moderna, Sputnik, and Novavax have similar efficacy, while Covishield, Covaxin, and J&J has moderate efficacy, and CoronaVac has the lowest. The rarer side effects, they are different. Thrombotic episodes, they are seen with the viral vector vaccine, while myocarditis is seen with the mRNA vaccine. But today we still don't know whether these are the class effect of this vaccine. However, the solicited reactions, fever, headache, myalgia, etc., they are very similar. They are milder type, and most of them they resolve of its own and doesn't require any medication. Their real world impact of this vaccine is very similar. Post-vaccination breakthrough infection rates are very similar across all the vaccines and drop after use second dose. There is 88% reduction in the illness and 96% reduction in hospitalization and death. Their efficacy against variants are very similar except for very less efficacy of Astra vaccine against beta variant. Their administration dosing schedule is more or less, so 0.5 ml intramuscularly. These are the commonest thing. 2 doses they are given. With this background, it is not justifiable to compare the vaccine. It is like comparing the oranges with apple. So whichever vaccine is available, it is good for you because it is safe, highly immunogenic, tolerable, and prevent the critical COVID illness and death. Therefore, we must take the vaccine, which will prevent you from the COVID-related death and having this safe and tolerable. 2 doses 3 to 4 weeks apart and 0.5 ml in upper arm. There are vaccines available for the children also. Zy-COVID and Covaxin already received the emergency use. Covax in clinical trial, and Pfizer is already approved in the US. The message for is that safe and effective vaccine can be developed in the shortest possible time with hand-holding of aggressive player, especially during epidemics. Preventive public health measures are equally important during pandemic. No reason to believe that scientific rigor was diluted. Public engagement is absolutely necessary. Healthcare professional has very important role to play. Thank you very much for quiet listening. Any question is most welcome. Thank you very much.
Thank you, sir. That was a very nice presentation on the vaccination. And one question, sir, I would like to ask at this point of time is this. Sir, what is the actual use of having so many different vaccines? This was the basic talk. This was the basic subject of the talk. So why do we need actually various? You see,
Yeah. So, am I audible?
Yes, sir. You are audible. Yes.
Okay. Okay. Great. So the question was why so many vaccines? It happens because so many partners and so many manufacturers and so many universities, academia, industry, they come together. This is just because of we want a solution. That's the only thing. So everyone who has think that he had a solution has is put into the race. That is the reason. It was and the pandemic was spreading so high and very quickly and high mortality. That is the reason why everyone who knows something about the virus, who can manufacture the thing, who has developed the things, they try and push the vaccine. So that is the reason why you can see so many vaccines. And the hope is that at least so out of these so many things, at least couple of them could be very useful for the vaccination. And that has happened. And we can see now the real impact of the vaccine that we can now curtail the near in a position to curtail the pandemic.
Right, sir. Right. Thank you. Dr. Kavde, nice
Yeah.
talk
Thank
on
you,
the
sir.
vaccine. But the question remains, given the choice, which vaccine would you prefer and why?
Yeah, exactly. So for a healthy population, healthy person, there could no choice. Every vaccine, because we have seen that the efficacy against the severe illness and death, which is very critical, is very similar despite their individual differences. Now, for the individual, like suppose there is a some immunocompromised patient or some on organ transplant. So based on that, we can choose based because these vaccines they have their inherent characteristics, like some are inactivated, some are viral vectors. So based on that, we can choose the vaccine. But for the healthy in general population, it doesn't matter which vaccine you use because they give exactly very similar public health impact. For individual, based on his clinical history, medical history, or some disease, you can choose the vaccine.
Is there anything that live vaccines are better than others?
No, there are only two live vaccines. They are in the development. They are still in the phase 2 or phase 3. We yet to find their results. But the most recent one, which are never used before, like mRNA vaccine, the Pfizer and Moderna, they have shown such a tremendous efficacy and then tremendous immunogenicity. So I think live vaccine will not beat that.
Considering our situation in India, like everybody has taken Covishield or Covaxin,
Yes.
and if you compare to US, almost they're on mRNA vaccine.
Yes.
Or Moderna.
Yeah.
So still we find that the amount of or the number of patients which are generated till today in US are more, and hospitalization is more than in India. Compared to last year, we could find those who are vaccinated and those who are getting disease. They have got a mild disease, and the hospitalization is less.
Yes.
So is it because of the vaccine or it is because of the change of pattern?
It is not because of the vaccine. It is just because I'm sorry to say that, but US people, they are not following the COVID appropriate behavior. I have taken the feedback from many of my friends. So lot of our administrative people should be congratulated for making the people to follow the COVID appropriate behavior. But that is very poorly followed in USA, and that is the reason why they are getting the infections. And another reason is that there is a very significant acting anti-vaccine lobby in USA rather than India. So these are the two main reasons why they are getting more infection. Even you say yesterday's only, we have already crossed the 100 crore doses, and as compared to USA where there is only 40 crore doses has been given. So that is a difference. So these are the two reasons my mind.
So the take home message from you is that we should take a vaccine, number one. Number two, we should take whatever is available with us, depending on coexisting diseases. We have got two choices only right now. I think Sputnik is also there,
Sputnik is
and
there. Yeah.
yeah. So the main interest of the population should be that they should get vaccinated first.
Yeah. And another most important is the CAB, COVID vaccine. The appropriate behavior is very must, because we are not still in end of pandemic. So during the pandemic, that is a reason, a very important aspect which we usually forget during vaccination during pandemic. Because if you see the large data from UK and Israel, what they have done, they have started the vaccination, and along with the vaccination, there are lockdowns. And that is the reason they got such a fantastic results in the preventing the deaths. So appropriate preventive behavior and the vaccination, these are the main two key in the pandemic. That is very important. So even if you are vaccinated, we have to continue to follow the COVID appropriate behavior until the pandemic over. That is a message, sir.
Anand sir, I just wanted to ask one thing regarding the changing strain of the virus.
Yes,
So these vaccines, they are though effective for, you see, various strains, but as the virus is changing the strain very frequently, you see,
yes,
the third wave of in the US, you see, is due to different strain, and that as compared to India due to Delta wave is different.
Yes,
so what is your take on that regarding the vaccination schedule on these different strains, sir?
Yes, sir. So recently, WHO and USFDA and CDC also reviewed all the data, and what they found that these vaccines have similar protective effect against the variants also, though the neutralizing antibody titers, it is less as compared to the original strain, but still it is protective. That is very important. The amount of neutralizing antibody which is formed against this variant with this vaccine, it is less as compared to the original one, 3 times, 4 times fold. But that vaccine is still protective. That is the important thing. And therefore, all the vaccines, they have a good efficacy against preventing the severe disease of the variant also, except for one trial that shows a South African trial, which shows a very less efficacy of Astra vaccine against the beta variant. Otherwise, for all the variants, the efficacy is same. And all these variants, if you see the mutation, they are in the region where there is a receptor binding domain. And now I think other mutation in other area, they are not that much effective in causing the effect on the virus. And therefore, these mutations, they occur in RBD region. And those vaccines, all of them vaccines, they have shown a similar efficacy against the variant also. So I think we should continue to take the vaccine in the similar schedule, similar dose. There is no reason or there is no trial to indicate that we require a booster or a higher dose or a longer schedule. So still current data shows that they are effective in the same dose, same schedule. Sir, thank you, sir.
Okay, sir. Thanks a lot, sir.
Thank you, Dr. Kawade, for such enlightening words.
Thank you.
Now, I would
My
like
pleasure.
to call upon Dr. Apoorv Agarwal to introduce our next speaker, who is Professor Ashish Bhalla, who will be talking upon the topic post-COVID fibrotic lung diseases, the way forward. Over to you, sir.
Yes, sir. I would like to introduce Professor Ashish Bhalla. He is the Professor of Internal Medicine at Postgraduate Institute of Medical Sciences and Research Center, Chandigarh. And he holds a special interest in the infectious diseases, emergency medicine, and clinical toxicology. And he has more than 200 publications in national and international journals. He is the chairman of the COVID Management Committee at PGIMR, Chandigarh. And he is a Commonwealth Fellow in clinical toxicology in 2014. And he's a Fellow American College of Medical Toxicology, Fellow of the Indian College of the Critical Care Medicine, and FACCE, FICP, and FIMSA. I would request Professor Ashish Bhalla to please start his talk on post-COVID fibrotic lung disease, the way forward. Thank you, sir.
Good morning. Greetings from Chandigarh. I thank the organizers for giving me this opportunity for attending this meeting and being a speaker in this meeting. The topic which has been allocated to me is COVID-19 related pulmonary fibrosis. Now, COVID has been an enigma. The virus, the pathology, the treatment, the complications, everything is an enigma. And the more we learn, we feel that the lesser and lesser we know. Now, if we look at this picture, the diagram which was published in Lancet on 6th of May in 2021, it talks about what is the normal compliance, pulmonary compliance, and what is the normal physiology which happens. So whenever there is an hypoxic vasoconstriction, whenever there is increased ventilatory effort, whenever there is cardiac output, there is an impaired compensatory mechanism, and it all can lead to increased dead space because of the thrombotic events in the vessels which are surrounding the alveoli. There is endothelial inflammation and there is pleural effusion. There is edema which gets collected, which adds on to the barrier between the alveolus and the oxygen carrying vessels, and there is increased right to left shunt because of consolidation or fibrosis, or maybe because of atelectasis, and recently something which has come up as intussusceptive angiogenesis, which leads to hypoxia and loss of compliance in patients with COVID-19. Now, if we look at what we've learned from other viral illnesses, the H1N1 and H7N9, that initially there is a functional impairment, which leads on to residual spirometric and radiological abnormalities, but they are inconsequential clinically, with a little evidence of distortion of pulmonary parenchymal bands, septal lines, some evidence of bronchiectasis. But finally, the pulmonary function inevitably improves over a period of time. There are some diffusion abnormalities also seen which persist, but they normalize over a period of time. This is what is exactly happening with COVID also. And over a period of time, the lung disease, the lung functions improve, and they keep on improving. Is there any evidence to suggest this? This is various studies, almost 3 of them, which have looked at the what are the clinical symptoms which are there at the end of 3 months or so. And if you look at this study from France and China, nearly 15 to 50% patients complain of fatigue, and 15 to 40% complain of exertion dyspnea and congestion. Why is it that? Is there any physiological counterpart of it? And if you look at this column, less than 80% diffusion lung capacity. In a study from China, in 1 month, it was around 84%. In a study from Italy, it was around 52% to begin with, but later on, at the end of 4 months, it's around 52%. In a study from Spain, it's again 25 to 26%, which persists for up to 3 to 6 months. What are the normal abnormalities which we see on HRCT chest? Early, you see ground glass opacity, patchy consolidation. Later on, you have reticulation, traction bronchiectasis. Very, very rarely you find honeycomb. These CT abnormalities, they improve over a period of time between 2 weeks to 1 month and 3 months. There is a significant improvement, and what ground glass opacities come down from 75% to 7%, and the fibrosis also improves. This is what is pictorial representation. The ground glass opacities improve. The consolidation normally resolves, and the reticulation also resolves over a period of time between 2 to 3 weeks. These are classic signs of fibrosis. That is evidence of bronchiectasis, which is seen in very few number of patients. This is another study which is from China, and the highlight in this study is that over a period of time, how the changes happen in moderate, severe, and critically ill COVID patients. You look at this, most of the time it is interlobular septal thickening, linear opacities, ground glass opacities. They significantly improve over a period of time. In critically ill patients, they sometimes persist, but in mild to moderately ill patients, they disappear. Are there any acute inflammatory markers or any acute changes which are related to fibrosis? In this particular study, there are only two things: IL-6 in the acute state and hypoalbuminemia. This shows you, look at this 90-day, 0%. What was there at 30 days was 11%, and at 90 days it is 0%. Reticulation, again, it was nearly 3%. At the end of 90 days, 0%. Bronchiectasis, around 5 to 6%, but at the end of 90 days, 0%. Pathology is histopathology of acute COVID lung is lesser known because very few people have got the biopsies done in acute stage. Most of the pathology is what we have seen in post-mortem biopsies or autopsy studies. Predominantly abnormalities which are seen are on radiology, multifocal consolidation and peripheral consolidation, but pathology mainly suggests organizing pneumonia. This is what is happening. There is alveolar epithelial injury. There is activation of immune cells, changes in vascular permeability, increased apoptosis, activation of fibroblasts, and then there is release of profibrotic cytokines, which again gets deposited in extracellular matrix. So pirfenidone and nintedanib, they are supposed to act on these myofibroblast proliferation and laying down of collagen. This is a paper which very aptly titled, "Let's Stay Focused," because in most of the patients, there is, although intense inflammatory response, which is seen in COVID ARDS, which is very unlike what you see in IPF. So IPF is a kind of pathological hallmark of fibrotic lung disease. The pathology in COVID pneumonia, COVID ARDS, is very different from IPF. So there are less likely chances that COVID pneumonia patients would behave like IPF. What is the holistic management approach? You have to assess breathlessness and fatigue. You assess the oxygen requirement. You provide symptomatic or palliative care whenever it is required. Consider rehabilitation needs. And this is the far more important thing: referral to experts. Whenever we find that a person who's complaining of fatigue or dyspnea on exertion, our focus as a pulmonologist is always on the lungs. Sometimes we end up forgetting the heart because there is residual inflammation in the heart also, which may kind of add on to this fatigue. In addition, sarcopenia and post-traumatic stress disorder, cognitive impairment may also add to post-intensive care unit complication, which may not be directly related to a pathology in the lung. So at this, what is our protocol at PGI? We assess dyspnea at discharge. We do a resting oxygen saturation 6-minute walk test, chest radiograph, and as a routine, we get a high resolution CT of the chest, not at the time of admission, but at the time of discharge to prognosticate. This is what we do. We do this at discharge, and then we call the patient by telephonic consultation within 4 to 6 weeks. We review the symptoms, and if we see that there are new symptoms which are associated, which are indicated of pulmonary involvement, then we call them a face-to-face clinical assessment. Specifically, at 12 weeks after discharge, even if they are not complaining of any definitive symptoms at 4 to 6 weeks. At this time, we do a complete clinical examination, get a chest X-ray, and look for evidence of pulmonary vascular disease. We also get a CT scan of the chest and CTPA, and then we look for any evidence of either a vascular disease or ILD. How do you treat? The most common abnormality, what we've observed in our study, which we've just finished, submitted it for publication, is that there is organizing pneumonia and non-specific interstitial pneumonia. And in these changes, or in this pathology, the agent of choice is steroid. The signs of bronchiectasis are seen in less than 5% of the patients who are symptomatic after 12 weeks of COVID. And in them, there might be some role of antifibrotic. Pirfenidone and nintedanib, pirfenidone, we have a cheaper generic available. We can escalate the dose over a period of time, and its adverse effects are minimal. Nintedanib has significant adverse effect. Patients don't tolerate nintedanib, and it's also very costly. So there is definite evidence of their usefulness in fibrotic lung disease. But the problem with antifibrotics are that they are slow to act. They act when the fibrosis is progressive, whereas in COVID pneumonia, the fibrosis is regressive. It's improving over a period of time on its own. Sometimes it is hastened by steroids. So it may not be very evident that they would work there. There is no stage of exudative inflammation except for diffuse alveolar damage in patients with IPF, which is very common in COVID. So that's where the IPF differs from COVID pneumonia. So that is where there is acute resolving lung disease. It's not persistent. So that is why antifibrotic drugs may or may not have any action. It takes almost 3 to 4 months before any effect of antifibrotics become obvious. And we've seen by various studies that by 3 to 4 months, most of the time, these changes radiologically always revert, plus the clinical improvement also starts happening. Another problem with antifibrotics is the drug interactions. Nintedanib has a significant interaction with anticoagulants, or if you are giving high dose antiplatelets, and there is hepatotoxicity, which might be again potentially shared with remdesivir and tocilizumab. The prevalent practices is people have been using it right, left, and center. This is a review which was published in early 2021, published by a pharmacologist, and he says that antifibrotic drugs have become blockbusters from orphan drugs. But my question is, who's benefiting from these blockbusters? Is it the patients or the pharmaceutical? And I firmly believe that the patients, very few select patients, maybe less than 5%, would actually need antifibrotics and would be benefiting from them. So my take-home message is that several patients require ongoing care, and there has to be a protocol, multidisciplinary team to take care of these patients. Not all pulmonary parenchymal abnormalities, even on radiology, represent fibrosis. Most of the abnormalities, they resolve. Our focus should be at risk patients, those who have only a very severe illness. Steroids, we've just finished our study, as I said. Low dose 10 milligram works as well as 40 milligrams, and the chances of the infection with low dose given for a period of 6 to 8 weeks is quite low. Antifibrotic might be useful in very select number of patients. I leave you with this slide. This is again from the same article. We find ourselves asking, is it worth spending valuable time, resources, and scientific energy studying antifibrotic therapies in acutely ill COVID-19 patients? And the responsible answer is no. We do not have any evidence to suggest that in acute stage we should use these agents. We should keep our focus during the pandemic in management of these acute complications, and we should keep our focus only on those severely ill patients, persistent symptoms after 6 to 12 weeks with significant radiological evidence of fibrosis. They are the ones who might be needing these antifibrotic drugs and may slightly benefit from it. With that, I come to at the end of my talk. Thank you very much for giving me this opportunity.
Thank you, sir. Sir, that was a very lucid talk on the fibrotic stage of the COVID illness. I would just like to ask one question, sir. We are getting many patients of, you see, post-COVID having, you see, respiratory difficulties at present also. Though they are COVID negative, they have come home, but still the fibrosis is still there. So apart from the antifibrotics and the steroids, what else can be advised to them, sir?
I think respiratory therapy, good respiratory physiotherapy, good hygiene, that's what is important. Most of these patients have deconditioning. So appropriate exercise. What is commonly recommended is that you breathe a rectangle. You breathe a short and then you exhale longer. So that probably would improve. Another thing which we have observed is that a lot of patients after COVID have developed a hyperreactive airway, which needs care. We've seen lots of patients developing wheezes, bronchi after recovery from COVID. They are the ones who might need a little bit of bronchodilators or maybe inhaled steroids to take care of this hyperreactive airway. If at all you want to use steroids, I would kind of go with the data which we have generated, that 10 milligrams of Bisolon given over a period of 6 to 8 weeks works wonderfully, helps in reducing the organizing part of pneumonia and what appears radiologically as fibrosis. That should suffice. And in very many patients, I don't think even we need that 10 milligrams of Bisolon. Just don't treat the radiology. If at all the patient is symptomatic and has severe or significant diffusion restriction, that is less than 80% at 6 to 8 weeks, then only you would probably end up needing something like a low-dose steroid. As far as antifibrotics are concerned, I don't think there is a major need of using any antifibrotics upfront or even in the follow-up phase.
Thank you, sir.
Hello. Hello. Hello.
Yes, you are audible.
Yeah, Dr. Bhalla, Professor Bhalla, I must congratulate you that you have taken a lot of pain in explaining the antifibrotic and COVID use. I mean, it has been used left and right over the last second pandemic as well. But that small amount or the small amount of number of patients which require fibrotic therapy, clinically, how do you go about it? And do you advise a repeat CT scan, especially with a Curad score of 15 plus, and start antifibrotic therapy? Are they the candidates?
Good question. I've told you our protocol. Our protocol is not to do, again, I'm repeating, we do not do a CT scan upfront to diagnose ARDS and to diagnose what is happening, because ARDS diagnosis is clinical. All you need is FiO2 and PaO2. That's it. You don't need a chest X-ray or a CT scan to make a diagnosis of ARDS. If the patient is having ARDS, you're going to treat it as ARDS with either supplemental oxygen or steroids upfront. But what we need to do is maybe persons when they are getting discharged, if they have significant hypoxia, either at rest or if they have significant hypoxia on exertion, then you need to look at what is happening to their heart and what is happening to their lung. That's when I would probably do a CT scan and see how much is the residual radiological damage, start them on treatment, and maybe follow them up at 6 to 8 weeks. In case their symptoms are persisting, that's when I would probably do a repeat CT scan and see whether they have gone on to develop some evidence of fibrosis. If it is there, then we might end up giving them some antifibrotics, but upfront antifibrotics, I won't recommend. Yes, if a person who's got if he's got a CT done right up front and his CORADS is something like 22, 23, 24, 25, something like that, then I would probably follow this up, follow this patient even more carefully for development of fibrosis, because I know that critically ill patients who have very severe or very high CORADs right up front may be going on to develop fibrosis, or may take a little longer for the pneumonia or the radiological changes to resolve. So that's what would be my strategy.
Would you in this case, in these patients, would you start both the drugs together, or
No, sir. No.
Fibrodon
What we've seen, I'm talking about what experience we've had. We've given in these patients who were having residual respiratory distress or residual symptoms at the time of discharge. We divided them into two groups. One group we gave 40 milligrams steroid, Visolon, and the other group we gave 10 milligrams, and we found no difference. So probably 10 milligrams given for 6 to 8 weeks in patients who have a residual illness at the time of discharge would work as well in taking care of organizing pneumonia. And if they were very critically ill, required long-term oxygen for 2 to 3 weeks or 4 weeks in an ICU, then probably I'll follow them even more frequently. Otherwise, 4 to 6 weeks follow-up would be more than sufficient. And as soon as I can get diffusion lung capacity, DLCO, I would probably try to get that.
any other questions from chairpersons?
Thank you, Dr. Bhalla, for such.
Thank you so much. Thank you so much.
Such informative session. Now I would like to call Dr. Dongre to introduce our next speaker, who is Dr. Anirban Home Chaudhary, who will be talking on. Who is Dr. Ranjit Chatterjee, who will be talking upon NIV interface helmet versus full face mask. To you, sir.
Hello. Hello. Am I audible?
Yes, sir, you are audible.
Yes, sir. Okay. Thank you, Avinash. Next speaker is our Dr. Ranjit Chatterjee. He is the CMO Senior Administrator Grade in charge, Intensive Care, Swami Dayanand Hospital, Delhi. And the topic is almost a hot topic: NIV interface helmet versus full face mask. To just for the audience that during COVID period, NIV was extensively used, and there was always a problem with a long-term face mask with the patient. You get a scar, patient is uncomfortable, and there is a problem with having a full-filled mask for 24 hours. So it was possible. So to decide on that, let us welcome Dr. Ranjit Chatterjee.
Good afternoon. First of all, my sincere thanks to the organizers to give me a chance to speak in front of this August gathering. And my topic is today NIV interface, helmet versus face mask. Before I start my lecture, I should salute all those heroes who have laid down their life in this fight against COVID, all my friends who have laid down their life, and all those who are fighting, still fighting against this dreaded disease. So there is no disclosures to make, and this is a completely philanthropic exercise. I'll directly go to the interfaces because we don't have much of time here. As we know, that NIV has become a household name nowadays after COVID. Everybody knows what is CPAP, everybody knows what is BiPAP, at least they know the names after oxygen and pulse oximetry. So whenever we start at non-invasive ventilation, two things are very important. One is you have to select the interface and another is a machine. So when we select the interface, the most common interface that we select is a face mask. And the machine that we select either is a BiPAP machine or the ventilator. So, and there is another not so common one, which is not used much in India, but in outside world it is being used. Now in many centers in India we are using it. I am using it for the last 4 or 5 years. This is a helmet. So the problem is why the face mask is failing. See, NIV is the most important machine between the man and the ventilator, between the patient and the ventilator. If this fails, the patient has to be taken on the ventilator. Now, all the faces are of different shape. The face of Amir Khan cannot match the face of Amitabh Bachchan or this identical lady. For all the different shapes all over the world of all the human beings, we have 3 sizes of face mask. So the size cannot complement the shape, and that is the reason you have lot of failure rates up to 18 to 40%. And along with the face mask, you have claustrophobia, skin irritation, sore nose, ear leaks. See the type of claustrophobic expression the lady is giving, the ulcers that has developed. These all problems of the face mask leads to failure of this very successful device that is NIV. So helmet has come as an alternative where you can find in a helmet, we have inspiratory and the expiratory port. We have 2 extra ports, one for the Hallc tube maybe, another for any other interventions you want to do. This circular one, basically you can anytime open this one if the patient, you want to give some water to the patient or the patient feeling asphyxiated, you can take it out. And you have 2 pads which goes below the armpit to support the helmet. And the helmet size is chosen according to the circumference of the neck. So helmet has a better tolerance, used for longer duration, has more patient autonomy. The patient can look around, speak, drink, eat, whatever he wants. But definitely it has certain disadvantages. It may be claustrophobic at times. It causes a bit of neck discomfort, maybe some ulcers also. Greater patient ventilator asynchrony is there. There is CO2 rebreathing, which is a big problem here. I'll come to how we can solve them. And there is a noise problem. But another advantage of the helmet is there. During the COVID times, it is much less contaminating than that of the face mask. I'll come to the studies later. So the first study that came in 2003 showed that helmet has a very high dead space volume, but it is an efficient alternative to the face mask and by using CPAP and even in severe acidosis and hypercapnia. This is way back in 2003. From 2003 and 2013, a lot of studies came in different clinical conditions, and Rodriguez basically assimilated them into a meta-analysis, and he found that more or less the face mask and the helmet are performing similarly, more or less, and the tolerance is much better in the helmets. And they also found that there is a lower hospital mortality and intubation rate and complications with the helmet if compared with that of the face mask. This was till 2013. But now comes the problems. The problem starts arising when we use it more. So the first problem was CO2 rebreathing. Due to this huge internal volume, there's a lot of CO2 accumulation inside. And how to avoid this is pretty simple. Just increase the face gas flow rate to more than 50 liters per minute. Or you give an additional flow rate through that accessory port that I have shown you. Or if you can change your ventilator bias flow, just change from, normally it is around 4 liters, change it up to 10 liters per minute. So that bias flow will automatically give an extra flow to the helmet. Don't go for intentional leaks. Many of the clinicians say, let us give a leak, but that may be counterproductive because the helmet, the efficacy of the helmet will decrease. And measure the PCO2 inside the helmet. It should be less than 5 millimeters of mercury. It is normally measured at a quiet place inside the ventilator, just above the inflated cushion. Noise is a big problem. Up to 100 decibels noise is created, but we are giving earplugs. We are getting earplugs along with this with the helmets, that basically solves the problem. And the most important problem is the patient ventilated asynchrony because of large dead space, then ineffective efforts, double triggering, auto triggering, leg cycling, premature cycling, everything happens. So how to solve this? So there is low pressurization time, low depressurization rates, inspiratory and expiratory trigger delays, asynchronies, unassisted efforts, and auto triggering. So the first paper that came in 2009, it told that increase the PEEP and the pressure support by 50% and most of your problems will be solved. Half of the problems were solved in 2009 by increasing the PEEP and the pressure support and using a ventilator rather than a biped machine and with a double circuit. 2013, this paper more or less solved these problems. Majorly told that start with a high PEEP of 10 centimeter, inflate the cushion. Remember, there are many helmets which comes without a cushion. So those which are coming without a cushion, inflate it up to 120 centimeters to 150 centimeters. Decrease the circuit length from the usual 120 centimeters to about 65 centimeters and use a fast rise time, maybe 0.05 seconds to 0.1 seconds, that is 50 milliseconds to 100 milliseconds. So this will change the whole scenario. The pressurization rate, the depressurization rate, the minute ventilation, leaks, inspiratory delay, unassisted efforts, auto triggering, everything improves. And see the graphs more or less, the dotted graphs are that of the helmet, and the straight line is that of the unbroken line is that of the ventilator, and they more or less they match each other when we do these changes in the ventilator and in the circuit. And following this type of papers that come out from Chicago, B.K. Patel came out with this paper, and it was found that the treatment with helmet NIVs resulted in a significant reduction in the intubation rates. So these are patients of ARDS. And there was also statistically significant reduction in 90-day mortality. And they have to stop the paper prematurely because face mask was basically so harmful for these patients that they basically stopped this paper. And because the helmet's efficacy was proved beyond doubt. So why this happened? Basically, what is the advantage of the helmet, that is a high PEEP, is the disadvantage of the face mask. With a high PEEP of more than 8 to 10, there will be huge leaks, there will be discomfort of the patient, and there will be NIV failure. Whereas we start at a positive insulation pressure of 10 in a helmet because it inflates the helmet well and the helmet succeeds with a high PEEP. So what is advantage for the helmet is a disadvantage for the face mask. And the second thing that we saw with this paper is that the leak is negligible with the helmet when it is used with a double circuit. Filters are used and a good seal around the neck interface. And helmet without a seal gives a dispersion of around 270 millimeters, around 3 feet, whereas a leak of 27 centimeters, 1 feet, whereas a leak of 916 millimeter comes, the spread comes with a face mask if the same setting is given. So that means up to 1 meter, there is a spread of aerosols. So chances of contamination is much more with the help of us with the face mask. And this paper in 2020 in the European Respiratory Review, it found that the NIV with helmet without tight ear cushion, with an IPAP of 20 and EPAP of 10, spreads up to 27 centimeters. And with a tight ear cushion, with this no dispersion. Whereas with more or less in the same setting, so the full face mask, it is 92 centimeters for the face mask. So the level of contamination with the aerosol spread is much higher with the face mask. So helmet is much safer, especially in COVID times. And you can go through this paper when you get time. It is in Pulmonology 2021. They in fact assimilated helmet into an algorithm between oxygen and the ventilation. So I don't have time, due to shortage of time, I can show this one to you. You can go and read it. And this paper in 2016, this meta-analysis, it was quite interesting to see that there are 11 studies, 621 patients was taken, and the failure rate was 0 in helmet rather than 38% in the face mask. And the NIV with face mask, there was 64% had to change the mask. The most common reason was non-adaptation to the mask due to shape of the face. And decrease in mortality in hypoxemic ARF patients, lower intubation rates both in hypercapnic and hypoxic patients, and there are much fewer complications. Whereas in the primary end, we find there is lower hospital mortality in the helmet group. So such an advantage we find in the helmet. And I congratulate the Italian workers to do this heliport study during the COVID times. In 4 ICUs, 109 patients, though there is no difference in the primary outcome of number of days free of respiratory support, but the rate of intubation was significantly lower in the helmet group, and number of days free of invasive mechanical ventilation also was significantly lower in the helmet group. So this study prompted Levanila Munshi to go for certain for editorial in the JAMA, but she was quite defensive in saying that before going to use helmet universally, you should have to do the larger studies, needs time for learning, go for certain performance to see the performance of each modality in each type of diseases, and certain threshold criteria of hypoxic failure has to be set before helmet has to be used universally. So this is one of my patients where you are using helmet. She has a case of hypoxic respiratory failure, and you see that we are using 2 limbs, 2 circuit limbs. My resident is talking, we're giving a flow of around 55 liters, 50% oxygen, 10 p in this patient. We are using a helmet with the help of a ventilator. So if I go for the second one, this is basically helmet CPAP, where you are using only direct flow of oxygen from the wall. No machine is used. This is a case of hypoxic respiratory failure. We give flow through 2 ports here, through the 2 oxygen ports. So the patient is quite comfortable. Sorry for the interruption by my over-enthusiastic residents. So along with them, along with this helmet CPAP, they provide you with this type of chart, so you can decide on the flow that you have to give from the 2 ports. So just certain practical tips before I stop my lecture, that use a proper size of the helmet according to the neck circumference. Use ventilator, preferably turbine based, so that it gives a good amount of flow. Use high flow of more than 50 liters per minute. Bacterial viral filters to be placed both in the inspiratory and the expiratory limb. Use a pressure support peak mode. Keep peak more than 10 centimeter of water, pressure support more than 15 centimeter of water. Keep a inspiratory trigger around 2 liters per minute. Fast rise time about 50 milliseconds. And the TI max should be, maximum inspiratory time should be not exceeding 1.5 seconds. 1.5 seconds. The expiratory sensitivity should be kept at a bit high, around 30 to 50%. Decrease the circuit length. Maybe 65 centimeter is a over-enthusiastic type of proposition. Keep it around 80 centimeter. But 65 is the lowest mark that you can go. Inflate the cushion, very important, inflate the cushion of the helmet. And the most important part is reassure the patient, stand by his side. Sometimes you have to wear the helmet yourself and show that, see, there is no claustrophobia, no problem. Just tolerate it for some few minutes and you will really become better and better with times to come as the helmet treatment goes on. So these are the points. If you remember them, practice them regularly. You can use a helmet very, very easily, usefully. If you have any questions, I am ready to answer them. Thank you so much again to give me this opportunity to talk to you and to interact. Thank you so much.
Excellent overview, Dr. Chatterjee. That was helmet versus usually used face masks BiPAP. But there are certain queries which comes to mind that do you use helmet as intermittent for intermittent ventilation as well?
For intermittent, I don't get you exactly. You want to mean that
most of the COVID patients in pandemic, you find that they are hypoxic for some time, and then you put them on BiPAP, usual face mask BiPAP, and then give them on day 2 to day 5. You start giving them intermittent BiPAP therapy, so that they are free of BiPAP ventilation for some time and get their natural or spontaneous breathing. If such is the case, how about in helmet? Whether it is possible to go for intermittent ventilation?
it's not a contraindication if we go for, because hardly we have used intermittent ventilation in the time. most of the patients coming in my ICU, they either have failed the oxygen therapy and the HNFCO, and they are coming to me for the final retrieval, whether I have to go for a ventilation or I can save the patient with the help of a NIV. So when I give these patients, I have used helmet continuously, and many of these patients have come out of the helmet quite well. Intermittent helmet, yes. When I'm weaning the patient of your NIV, then definitely it is been, for example, I give it for 16 hours. Then the next day I give it for 12 hours. Next day I give it for 8 hours, 4 hours. In this way, I take out the patient off the NIV. So intermittent helmet can be used and is used as like any NIV when I'm weaning the patient out of the non-invasive. They're very used.
Yeah, while weaning, do you change over from helmet to face mask and HFNSO or direct?
Hardly I have found any patients, sir, who have accepted the helmet once and they are going to accept the face mask. They don't accept it. They are very comfortable in the helmet, but what I tell everybody, wear it yourself, show it to them that you are not facing that problem. So they will also not face it. The only problem is a bit of claustrophobia.
What do you do for claustrophobia? I mean,
if they are really claustrophobic, I have no other choice but to take the helmet out. That is the only thing that I can do. But sometimes I remove that the smoker port and ask them, so everything is fine, have some water, relax, and try it again.
Have you tried any antidepressant or claustrophobia?
Never. Nothing I have. Nothing I have. I actually I try not to use any sedative. Yes, sir. Yeah.
There's one more question comes to mind, that how do you feed them while they are on helmet?
That I'm telling you, that if you can open that, if you have used helmet, you will see that the circular opening that has been given, if you open that, the patient can drink water, can eat also through that. It's very easier than the face mask. And if the patient is on a Ralph tube, we have an accessory port, the Ralph tube can come out through that port. Whereas in a face mask, if you have a Ralph tube, it basically comes below the face mask and causes a lot of leak, which is not present in helmet. The advantage of helmet is that what I told, that it has to start with the high peak. You see, in ARDS, we need a positive respiratory pressure more. Whereas in the face mask, if you give a PEEP of around 10, that is the EPAP of around 10, the patient is invariably not going to tolerate it. Whereas it starts with a PEEP of 10 in helmet. You can go up. That is the reason why Dr. Patel found it so reassuring in cases of ARDS, where he needed an respiratory pressure more to inflate the alveoli. And that is why in COVID patients also, this was quite successful. Quite successful.
That's an excellent overview. Any more questions from audience or?
Sir, I wanted to ask one question. As you have, I've gathered from your talk regarding the use of helmet and the face mask, the usage of oxygen with the helmet is very high, pretty high, as compared to the face mask.
Yes.
So, as in the second wave, we have seen that there was a severe shortage of oxygen. So, what is your take on this, sir?
That will always be there. That is the reason why you are, first of all, I congratulate you. You are doing the whole thing from your ICU itself, I suppose. And
yes.
And that is the problem always there. If you have, because you have a lot of oxygen extra, you need the helmet also, because you need a lot of extra flows also. And it's more or less sometimes reaches the high flow nasal capsule oxygenation level. So definitely it's a problem that I definitely have.
Yes, sir. That is the reason, sir. We, in fact, HFNC, if we compare HFNC with BiPAP, HFNC has a very good role in this. But owing to the shortage of oxygen in the second wave, the usage of HFNC was very limited as compared to the BiPAP, and BiPAP definitely has shown very good results in all these COVID patients.
Yes, you're right. But when you don't have any problem, you can go on using it. You are right.
Right.
Dr. Anand, can I have a question for Dr. Ranjit?
Yes, why not, please? Dr. Gautam, you are always welcome.
Rajesh, so I have one question is about the interface helmet. There are two types of helmet coming up with the Star company. One is a two-piece, one is single piece. And do you have an experience using a both, or you use just a two-piece? Because I've seen you are using only two-piece. But my experience, although not many cases, but I tried in a case with the single piece also, but it's really very uncomfortable. It's very difficult to take it out also if the emergency comes. And what your take on two-piece and one-piece helmet mask?
Yes, sir. I started using it accidentally from 2014-15. I got that helmet. That time it was coming without a neck cushion and a one-piece. But when it came out to a two-piece, that is when you're using the ventilator, definitely the advantages started coming. Now I am not using that the older one that you were speaking of. I am using that one with the neck cushion with the two opening. And what you are talking about is that where you can use the P bulb in one of the ports, and you are giving a single lens of it to the helmet. That is difficult to use, and sometimes that also fails because you don't have the neck cushion also. And the third one, the second video that I showed is basically that of a venti helmet or a helmet with CPAP, where I give, that is a single port from which I am giving it, if you see that. And there I have to give a lot of pour of oxygen to the patient. My take is, yes, you are right. The newer ones are much more easier to use, much more comfortable to the patient, and much more successful than the older.
Thank you.
Thank you, sir. Again, to meet you virtually.
Sorry to interrupt you, Chairperson. Sir, we are running late to move forward for the next talk.
Right. Thank you so much.
Thank you, Dr. Chatterjee, for the very enlightening talk. Now I'd like Dr. Apurva Agarwal to introduce our fourth speaker, Dr. Purushottam Lal Gautam, who shall speak on COVID and team science. Over to you, sir.
Yes. Dr. Purushottam Lal Gautam is the professor in head department of critical care medicine at Dayanand Medical College and Hospital. And he is a member of ISCCM elect in 2018 and 19. He is the chairman of the Punjab chapter, Society of Critical Care Medicine from 2017 to 19. He is the general secretary and chairman of ISCCM, City Branch, Ludhiana, member of the Academic College of Council, vice president 2005 to 2006, and treasurer in 1999 to 2001 for ISA North Zone. And he has been the examiner for PG examination, MD and DNB, and delivered more than 100 guest lectures in the national and regional conferences. The topic which he'll be presenting is COVID and team science. So I would request Dr. Purushottam Lal to please continue with this talk. Thank you, sir.
Good morning. First of all, I am very thankful to the organizers, particularly Dr. Runta and Dr. Titimala and Dr. Tyagi, for giving this opportunity to speak in the World Conference on COVID and critical care on the team science. COVID and team science, the successful outcome of any team or any project is product of technical and non-technical skills of each member and the component. We are often taught technical parts, but a little emphasis is given on the non-technical part. So what is the teamwork and the attitude and the passion and the respect of team members. But in this COVID time, we have understood our limitation in the system and the individual and the leadership. So this, COVID has given us to get better understanding of the teamwork also. Normally, we learn these non-technical skills from our seniors, grasp gradually, day by day, doing the duties and over the time, passively. So team science is we are going to cover on the understanding the critical ill patient, the problem in the critical team, the team performance pillars, and learning from other fields. We have a very good cover page on the Time magazine, which highlighted the spotlight coronavirus frontline workers from cafeterias employees to the paramedics. Everything is explained in this. Each and every component is important whatsoever. It's a level. It's not the doctors only, it's nurses only. Each and every component, the ward boys are equally important. The gas plant people are very important. So each and every person is important. There was a very good article and editorial in the Lancet in the last month only that selling as an independent word, but I would say it's a working as an interdependent word, which we have seen the sharing the information, then collaborations for vaccinations, for the equipments, and helping each other. Critically ill patient is a pathology. It's a complex disease. It may affect any system. We don't understand the systems over the time. In the last 2 years, we have no understanding the COVID disease only. It is a complex management that is decision making as procedural skills, which are really difficult handling the area in these patients. So it's expert handling to these patients. And the fragility of the critical ill patient leaves hardly any margin of safety. So complex environment and then working with the risky and the PP, then emergent situation like making prone to errors and the accidents. The time factor also very important. These patients deteriorate certainly need a very solid rescue system also. It has come with the unique problems and issues also, like the science and the politics alignment was very important in the vaccination drive. And for the consumables, for arranging the equipment, for the resources. And resource exhaustion has been witnessed in a number of places, like bed capacity, then human resources, then consumables, oxygen. So world were working in a one team. We have the WHO and other bodies giving the guidelines, and the national level we have the ICM and other groups giving us the policy resources. Then states working with the different hospitals, like controlling the oxygen. No one can stock for more than 12 hours in Punjab. We had very good, Punjab did very well in oxygen management, I would say the government. So in the hospital also, we have a number of units working together for one goal, and that was COVID control. That's the control rooms, ICU charges, the nurses, the OR, then because we have some patients who are undergoing surgeries also at the same time raising the beds for the ICU. See the team, the whole team, what are the performance pillars? There are 7 performance pillars. One is the psychological safety. Very important when you're working in a tough environment. And the transactive memory, the leadership, the communication, mutual trust, and the coordination. I'll taking one by one of these all. It's the most important that a supportive environment is the key. There should be freedom to ask questions, seeking help, and reporting mistakes and raising concern or offering suggestions. If the environment is not congenial, it's not supportive, it's unsafe climate, and there is fear of violence, fear of from the attendants, from the patients, or from the your team members also, the lack of from the seniors, the lack of motivation and communication. Then some information may not be transferred just with the risk of that you may not get the backfire. It has been studied also that environment which is abusive of physicians are there, the outcomes, especially in the surgical, they have found it's a very corrosive effect and complication rate is higher. And congenial environment promotes learning, team performance, the lowers the mortality. So if anyone is not the tune, we have to brought that person. There is a different methods has been proposed to get those people who are not unprofessional behavior on a cup of coffee and then going formally with a complete reaction also at times. Law of nature is there that the reproduction of fertility, the best form of the progression which we can witness in the world, it's come only when the environment is favorable. It's a spring, only then flowers come. Otherwise, the whole energy is spent on survival. The second thing is the transactive memory, that's called the orientation. In the critical care teams, we have anesthesia, the medicine, the chest people, but now in the COVID, we have surgical specialty, the non-surgical, non-ICU people also working together. So we have to understand their competence and weaknesses also. Need time for tuning members to develop the complementary behavior. Leadership, we have basically 2 more major types. That's a directive, autocratic or dictator type. One is the democratic type. Each and every has its merits and the demerits. Sometimes the autocratic or the democrat, this directive is very important when you have one person is like a physician is very competent and the rest of the members are junior or the staff nurses or the workers, and he can be directive. But when we have a equivalent competencies, then democrat is better decision making. But third type is the transformation, sometimes switching over between directive and democrat, depending upon like a physician has gone home, then the next person is the directive type, but he can make his own decision seeing the scene. So that promotes team dynamics and the commitment. We need not just doing the time, but necessarily doing the best job also. Communication has been witnessed more than 70% of human errors in the aviation also and the medical profession. And there are two types of communication. One is horizontal, that's like nurses to nurses or resident to nurses giving head off. The other is vertical from the top to down. Communication, when there is called a stairway of communication, when we see think something, then say something, and if it's not said, that means we have not even thought of. It's said, but it's not heard, that means we have not said. He is heard, but it's not understood or it's not completed the task, means he has not heard it. So closed loop communication is the most important part. Another part is the mutual trust and accountability. When we have a performance is accountable to the teams for timely and high quality task, when they trust each other, remember, like giving in the putting the passes, good passes going through the goal, that's a sort of mutual trust and getting the team honor. Another thing is the time factor. When the things are difficult, crisis there, the time is very important. Whether it's aviation or it's sick patient reporting or serious medical report like hyperkalemia, getting to the person who is handling it, it's important. We may lose the time. And once the patient is bleeding, raising the massive transfusion protocol and getting the blood very quickly. And if the patient is sick, getting expert help at that time. So it's coordination, the communication reduces the time factor. Cohesion, decision making, one problem may have many solutions. So once and the merits and demerits of each solution, then calibrating the solution with the problem that needs expertise and the setting cost. Every dimension has to be considered. Like all respiratory patient may be not a COVID. We have seen a couple of patients who are shifted to COVID ICU. They have a pericardial cardiopathy. They may have myocardial infarction, but they are positive COVID. But their treatment may not be exactly the COVID required. Maybe like patient with the different autoimmune patients, they need immunosuppression for different approach rather than like a COVID patient. So another thing is old fable that's bedside stories that taught us, and the story and study wins the race. But it's not always way too. Here is alert and he is aware of the fact and fast and persistent, then he will win. But if the runway includes a river, then what about that? This is something different where rather than argument, the agreement has to come. This situation, that situation is that the toss race is definitely going to win. But suppose, can we have a team race and win the situation for both? Oh yes. So they started off and this time the hare carried the toss till the riverbank. Then a team player changed. The tortoise took over and swam him across the hare on the back, and then the opposite bank, the hare again carried the tortoise. They reached the finishing line together. They both felt a greater sense of satisfaction and felt earlier. Their best performance is when the rivals work. I don't know who is the author of this, but this gives the moral of the story is it's good to be individually brilliant, to have strong core competencies, but unless you are able to work in a team and harness its core competencies, you will always perform low par, because there will be always a situation at which you will do poorly and someone else does well. So we can see the other fields, professions, whether it's aviation or monitoring or sports or aircrafting or music. If you have work in a orientation together in a tuned way, it's melodious and the outcome is good.
Hello. Thank you, Dr. Agrawal, for nice elaboration of teamwork. Yes, COVID this time needed teamwork, a good leadership, communication skills, and more so coordinations. Can you just enumerate any incident with oxygen lag when there was oxygen lag and remdesivir which was out and both were not available? Any incident you can quote?
This was actually, I would say, in, my ICU, because we have upscaling of unit like anything. And when you go on extending and routine pipelines, and at one time in the midnight, around the 12 o'clock, one of the resident, they had a low pressure in the system, because every ventilator wants, it works on the high pressures only. If the pressure is a little low, it will stop. So at that time, like it's very crisis situation. So at that time, what happened? The resident or the changeover, so it was good for we people also. The resident immediately started working with the patients and then gave me a call. Then I worked to a gas plant and they raise the pressure temporarily, like movies. They do something out of the limits, raise the pressures, then went there. I mean, working together with the nurses and all this thing. Even our set system, Punjab, I would say, appreciate the CM at that time, because they have a very good administration. They have a full control of oxygen in the Punjab, in one unit, sitting in the Chandigarh and looking at what are the availability, what are the consumption of each and every hospital. They even want we people also that your consumption is higher than the rest of the hospital. Then we started working on reducing the consumption also, like moving the patient if that's on the 3 ports, going on. So working in a team in these situations, even we have myocardial infarction patients also, even patients, something difficult patients where we need a lot of multidisciplinary approach. We work like that.
And this was the period when first wave and second wave both are taken into account. You find that there was a fear psychosis among staff.
Yes.
Who many of them were reluctant to do a COVID duty. So have you faced any such problems?
Yes, there was a lot of fear factor in our hospital also. So, but we decided, the whole team of anesthesia and critical, that was unique in rest of, I would say. We consultant took the lead that first all intubations will be done by the consultants, not the residents. Because we thought if we are doing the things, we are going to be a little more safe rather than getting the residents infected with the things and then getting back again infection. That will be risky. So gradually, everyone's fear was gone. If like a senior people are doing the duty, they are safe. The rest of it is also safe. That was, I mean, very interesting in our hospital. That being the senior most among our hospital, the first intubation I did, then all my consultants, NSC and critical, we divided our duties. Round the clock, we did in-house duty. All consultants. One consultant was sitting in the house in the hospital, whether it's an SA or critical care specialist. So then we gradually the all residents, and then the fear factor was almost gone for everyone later on in the second wave. So we were going almost the routine wearing kit and going for tracheostomies and all procedures as early required without any concern. So fear factor is initially the first person. Once that performance anxiety is gone, then later on the things are quite easy, I would say. We have to set the leadership as a role setting for the others. Maybe initially difficult at the back of your heart, mind, but if you overcome that difficulty, the later things become quite easy for the rest of the team. They take over the charge completely. Then you can sit, even take rest also easily.
And there were also quite a big amount of problems with the relatives, that relatives were not physically present. So any counseling done to them, and how do you manage all this?
So we had issues of violence also, to be very honest, because patient suddenly you put on the ventilator, you lose the patient, and how the communication goes. What we did in the first way, we learned that it's difficult to manage. They used to give the time to the attendants that gather at this time. So we'll address each and every patient's data, take a round, then convey directly, because once you are giving, although people prefer the individual, but we used to give, let the people come together. So give each and every patient the status briefing. So that helps a lot to the family, because they are waiting for that. They get the information, and they get this information also, that the trust also, that your person who is looking after, he has gone inside, he has seen the patient and is giving the true information. And we use the video, this thing also for communication from the ICU. We use laptops and phones with Androids, giving the patient's call. The patient is sick, then it's difficult, but every patient's attendant cannot stay in the hospital in a difficult environment, the COVID environment.
That was one bar. But at the same time, some attendants who are VIPs at times have the links also critical, and they are difficult to manage at times. But we face those problems also. But if you are together and the management is supportive, and then the things can be controlled that also. You need to have show the strength also at times, I would say. Security and other things to see that we are not that, we can then speak loudly with them also. But very important is if some person is creating problem, then you used to go together, or maybe the counseling, isolate that person and do the counseling. You have to be a good listener, because there are classes for the grief counseling also, because you are giving the news, it's not going to digest easily. So giving them time to speak and good listener, then show the confidence also that nothing can go wrong. But if something goes wrong, be transparent also. That's the way we used these techniques. But security person use of we people at times.
That's excellent, Dr. Gautam. I must congratulate you that teamwork in Punjab has worked very well and you saved many. Thank you, Dr. Gautam. Any questions from the audience or the chairperson? Or otherwise, we can conclude the session. Vinay, Avinash.
So there is no question.
No questions?
We can
Thank you, sir.
Okay.
We can conclude the session, please.
Thank you to the chairpersons and the speakers. It was a very informative session. I'm sure everyone enjoyed. We shall now conclude the first thematic session. Thank you.
Dr. Amrita.
Good afternoon to all the delegates and the faculties. We shall now commence with our second thematic session for today. Our eminent chairpersons for this session are Dr. Nilesh Bansal, Senior Consultant, Surgery, Usha Mission Hospital, Bathinda, Punjab. And our second chairperson is Dr. Tamanna Bajracharya, who is the Associate Professor, Department of Anesthesia and Critical Care, KIST Medical College, Lalitpur, in charge and consultant intensivist, PNB Hospital, Guarco, Nepal. Now I would like Dr. Nilesh Bansal to introduce our first speaker for the day, Professor MC Mishra. Over to you, sir.
I would first of all like to thank the organizers for inviting me as a chairperson for this wonderful conference in this post-COVID era, and still waiting for the, we are now very well prepared for the third wave. And not taking too much of the time, I will introduce Professor MC Mishra, who is formerly the Director of All India Institute of Medical Sciences from 2013 to 2017 in New Delhi, and he is the ex-AIMS head of the Department of General Surgery. He is also the founder and chief of JPN Apex Trauma Center at AIMS. And he is Dr. B.C. Roy National Award recipient from Medical Council of India, awarded to him by the President of India in 1996. He was also presented the Scroll of Honor by Chief Minister of Delhi, Srimati Sheila Dikshit, in recognition of service rendered in Chief JPN Apex Trauma Center, AIMS. And moreover, this introduction is very less. We all know him very well. We usually know him by lots of interviews and lots of work done. We have already seen him during many TV interviews and TV shows already. And I will not taking much time. I will proceed further for his talk.
Anil, thank you very much, Dr. Narendra Rongta, for organizing this conference, World Conference on Basics to Advance, Prevention to Cure, World Conference on COVID and Critical Care. It's a very important, pertinent topic today. And I am going to cover the role of yoga and nutrition in post-COVID healthy living. So if we look at the whole trajectory of COVID, we have defined COVID into two categories on the basis of post-COVID symptoms, conditions, sequelae, syndrome, short COVID, which somebody recovers within 4 weeks, and long COVID when somebody has symptoms beyond 4 weeks. Now, if we look at the societal impact of pandemic, any pandemic for that matter, it has 3 dimensions. The first dimension obviously is medical and healthcare dimensions. The second is very extremely important dimension is psychosocial impact of these pandemics, which we have witnessed over last 18 months. And then naturally, even further more important is the financial and economic impact and effects of any healthcare disaster like this pandemic, which is, we are saying COVID-19 pandemic. Now, types of post-COVID conditions, if we look at, could be tiredness or fatigue, which a lot of people complain, difficulty in thinking or concentrating, what we also call brain fog, headaches, loss of smell and taste was very common, but that was a good news because most people who had this problem had mild COVID disease. Now, dizziness on standing, heart palpitations were also known. Some people had chest pain, difficulty in breathing, cough, joint or muscle pain, depression and anxiety of COVID before happening and after happening, whether I'll survive or I'll not, fever, symptoms that get worse after physical or mental activities. Now, if you look at multi-organ effects of COVID-19, basically any viral illness, even if any other viral illness, including COVID, affects most body systems, heart, lung, kidney, skin, brain functions, etc. Multi-organ effects include conditions that occur after COVID-19, like multi-system inflammatory syndromes in children, what we see. Autoimmune conditions get worse, and multi-system inflammatory syndromes, a condition where different body parts become swollen. Autoimmune conditions happen when our immune system is attack our healthy body cells. But not yet we know how long multi-organ system effects might last and whether these effects could lead to chronic health conditions. But we have seen that happening now after 18 months. And further follow-up is needed for defining various definitions of long COVID. Then also those people who were admitted in the hospital, also admitted to ICU, had post-intensive care syndromes, health effects, severe weakness and post-traumatic stress disorder, which is very stressful when people have gone through very stressful conditions. Now, if we look at post-COVID conditions, we can have some treatment, but more people needed counseling to get better with time. That is the message they needed from their doctors. Anybody with post-COVID sequelae or condition basically needs to talk to his doctor or healthcare provider. And there have been now post-COVID clinics established in most hospitals to deal with these problems in most individuals. So what can be the best? Best is to prevent COVID from happening, or for that matter, any viral illness or bacterial illness, and take measures like maintaining distance, using masks. And later on, when Delta variant came in April and May, we said double mask, physical and social distancing, hand hygiene. And also now, more than 94 doses of COVID vaccine have been received by people in India. So we are reaching almost covering 50% coverage of vaccine all across India. And this is the largest number in the whole world. So get COVID vaccine. I think that's the message we want to give to everyone. Now we look at specific organs. Brain, for example, problems with memory and concentration, what we also call brain fog, difficulty in sleeping, insomnia, dizziness, depression, and anxiety, as I already explained, tinnitus, earaches, headaches, changes to smell or sense of taste, high temperature can also be prolonged in some people. We all know that COVID-19 is a respiratory virus and it affects both our lungs. Those who have comorbidities like diabetes, hypertension, or bronchial asthma, or they have pre-existing lung problems, will develop these problems much more than anybody else. So shortness of breath may continue for a longer period. Various kinds of chest pain or tightness, chronic cough, sore throat takes quite long time. I witnessed that it took quite a long time in some people to get better. It can lead to chronic interstitial fibrosis, leading to requirement of oxygen for a longer period. And then oxygen dependence we saw in some individuals. For heart, the palpitation, as I explained, viral myocarditis, myopathies, leading to poor left ventricular ejection fraction, increased risk of MI we saw because hypercoagulability, the clotting mechanisms getting disturbed, and sudden cardiac deaths were noted in some pre-existing cardiac illness. Gastrointestinal system, somebody will feel sick, have loose motions, have abdominal pain, loss of appetite, and also people lost weight. Some people lost minimal weight, but some people lost as many as 16 kgs of weight. And although we considered those who had GI symptoms had mild COVID, skin rashes were seen in some individuals. Then good news is that most post-COVID symptoms are amenable to nature cure by diet, improving your diet, fresh fruits, fresh vegetables, and also yoga and meditation. It can handle, yoga and meditation can take care of brain problems, chest problems, pranayama, breathing exercises, also cardiac problems, musculoskeletal pain, etc. And also if you add modern medications, it can be handled in most individuals. Psychosocial impacts of COVID, basically various yogic asanas, breathing like pranayama, already I told, anulom vilom, Bhramris, prone breathing came very handy in our ICUs, in our high dependency units for in recovery of these patients who had lung pneumonia of moderate severity and even very severe pneumonias. Patients with severe pneumonia also recovered. Actually, most yogic asanas involve breathing. Psychological counseling was extremely important. Reassurance to everyone that you will be okay. Building positive attitude, confidence, and also maintaining your nasopharyngeal hygiene. Jal neti, what we call, to clear your sinuses. Our thoughts and emotions affect immune system. That is called psychoneuroimmunology. Stress, anxiety, fear, negative emotions, they are known to weaken our immune system, including meditation, mindfulness, positive attitude and emotions, and relaxation can strengthen our immune system. So basically what we need to do, we must unlock ourselves, our healing potential. Each one of us have our healing potential by doing these yogic exercise, including pranayama, taking more oxygen inside, and that has helped tremendously. I know a lot of people who got depressed with just by the news of COVID. So what I would recommend, there is a greater importance in our ancient wisdom, that is our achar, that is physical activity and exercise, our vichar, right thoughts and attitude towards life is vital for well-being. Ahar vihar, what we call our ahar vihar, vichar, achar, healthy nourishing diet with adequate intake of fresh water, balanced intake of fresh food, green salads, sprouts, unrefined cereals, 4 to 5 servings of fresh fruits, sattvic bhojan, what we call, home prepared, and also vihar, proper recreational activities to relax body and mind, essential for holistic health. Vyavhar, our own vyavhar, healthy interpersonal relationship. Be happy in your relationships. Don't fight. And enhance psychosocial health. That is extremely important and has helped tremendously large number of people who have gone for these basically interventions. So stay safe, stay safe and healthy. Stay healthy through yogic secrets of self-care. We can stand as one humanity to fight the enemy within ourselves and also outside. May humanity prevail. So I again thank Dr. Narendra Rungta for giving me this opportunity to talk about our ancient wisdom, that is yoga and meditation and all pranayam and breathing methodology for recovery from COVID. And if one does this during our routine practice, those people recovered without any problem at any age when they contracted COVID illness. So again, I thank for a great success of this conference, and thank you so much for giving me this opportunity. Thank you.
Thank you, Dr. Mishra sir. There has been huge importance of yoga and meditation in our daily life, and you have nicely highlighted its role in post-COVID sequelae. There has been overwhelming news and medias which are spreading rumors and myths regarding COVID, and I think meditation and yoga, to some extent, it can soothe this kind of rumor, this kind of chaos in our daily life. So I think it's very important for everyone, for not only for the patients, for the doctors, for the family members, that they should understand the role of yoga and meditation in this situation. I would like to thank Mr. Mishra sir. Any questions from the floor?
I would only add, madam, that all of us medical professionals need it much more than anybody else, because we all worked in a very stressful environment, and a lot of even younger doctors were scared to care for the patients of COVID for the fear of contracting the illness. So I think that is something which if we inculcate in our daily routine, these measures, we can be much more healthier, because we have lost a lot of young doctors also who contracted COVID illness. And I have seen that if you inculcate this pranayam, breathing exercises, improve your lung reserve, improve your immunity as a routine, because it does not happen in a capsule during the illness. It has to be before the illness. And that is what we also mentioned when there were a lot of promotion of a lot of immune boosters marketed, commercially available. And so they just don't do any magic at that point of time. So what we need to do, we build a culture of healthy living amongst ourselves, teach everyone. So I think that will go a long way in building up a healthy society in India. And that is much more needed. It is much more cost effective in long run for any society, for any family for that matter. And those people who had strong will to recover, they recovered. They needed to do this. And that was the thing which we told, that from end of first week, when this lung problem starts, the pneumonia, COVID pneumonia, that is where they use the first week of illness in improving their lung capacity. so that they don't go into the lung failure and its consequences. Because what we have seen that those patients who went to ICU, most of them did not return. This is across board in most hospitals, outcomes were like that. When
Yes.
people who either did not require oxygen or minimal oxygen, they recovered. Most of them, they recovered. So, and even today, if we look at 98% recovery in India, 98.5% or 9% recovery, only 2% deaths overall, all across the globe. So I think this is what the message I want to give to our own fraternity, to embrace our ancient wisdom into our practice.
Thank you, sir. Thank you. Thank you for your, yes. So our next, Dr.
Thank you,
Amrita,
Dr.
Yes.
Thank you, Dr. Mishra, for the very enlightening talk. Now I'd like to request Dr. Tamanna Bajracharya to introduce our next speaker, Dr. Ramakant Deshpande. Over to you, ma'am.
Thank you. Thank you, Amrita. And our next speaker is Dr. Ramakant Pandey. He's Executive Chairman, Asian Cancer Institute, Senior Surgical Oncologist, Breach Candy Hospital Trust, Mumbai. His special mention is he has credited over 50 publications, books, and articles published in national and international journals. He has also written chapters in a book, Textbook of Cancers, published by the National Book Trust. He was the first person to introduce thoracoscopic surgery at the Tata Memorial Hospital, Mumbai. He was awarded Game Changer Award. He has received Game Changer Award by the HR Club on 7 February 2015. The Government of India honored him in 2014 with the award of Padma Shri, the fourth highest civilian award for his contribution to the field of medicine. I would like to welcome Dr. Ramakant Krishnaji Deshpande for his talk on oncosurgery in the midst of pandemic, your challenges and solution. Welcome, sir.
The COVID SARS-2 affliction, which came in a pandemic kind of a form, does affect a lot of treatment for malignancy patients. Cancer patients, due to their presumed low immune status, have a higher incidence of COVID by themselves. Not only higher incidence, but the chances that they will get hospitalized with a higher and stronger kind of a COVID infection, or even marginally higher mortality than normal individuals is often seen. Normally, in a given population of about 100,000 people, 400 people will have suffered from cancer earlier, all will be the first time diagnosis of cancer. Whereas in case of cancer patients, about 3,000 to 4,000 out of 100,000 patients could suffer from COVID, indicating that the multiplicity could be anything from 5 to 10 times that of a normal kind of a patient. The WHO declared COVID-19 a pandemic on 11th of March. India's first lockdown came on 23rd March 2020, and that threw a big spanner in the smooth process of diagnostic investigations, management approach, treatment methods, overall outlook of patients and doctors, need of vaccination and universal care, post-operative course of patients, and even their relatives within and outside the hospital. And we'll look at how exactly this happened. Several testing methods were used to diagnose the disease, out of which RT-PCR is the most commonly used investigation, as everybody knows. Due to various issues, the HRCT thorax started being used as an adjunct to RT-PCR by many, many institutions, leading to an increase in the number of scans done. And lo and behold, it actually led to an incidental diagnosis of various thoracic malignancies in patients who would not have really gone to the hospital for a scan because they had no symptoms altogether. Though the low dose CT scan thorax is recommended in advanced countries for screening, it is not possible in our country due to multifactorial reasons. So what are the changes due to the first wave of COVID, which came from March to almost about January of 2021? The waiting period for investigations, diagnosis, and surgery went up from 8% to almost about 33 to 40% for all patients. Patients would not like to go to a hospital for fear of COVID. They were not able to travel to specialized centers, so on and so forth. There was a definite increased diagnosis in thoracic malignancies, as what I mentioned. Even lymphomas due to identification of mediastinal lymph nodes was seen. Aerosol producing surgeries like the laparoscopy surgery, the robotic surgeries came to a grinding halt from March 2020 to January 2021, except in case of emergencies, depriving patients of the benefit of these kind of surgeries, even if they had not suffered from COVID. Additional precautions which were not followed earlier, like the smoke evacuators, split air conditioning, solitary air conditioning for separate operation theaters, COVID protocol gowning, which is quite oppressive at times, disposal of waste, sterilizations, etc., had to be employed and which continue till date. No attendance or only one attendant allowed policy came in, which is very unusual in case of India, where hordes of relatives will normally come in for the sake of the patient. Recent negative RT-PCR test report became mandatory for patients and attendants till June 2021, till the availability of the vaccination. Now, this is changed now into both doses of vaccination at least till 14 days before getting admitted and is mandatory for patient and relative. Alternate lines of treatment were deployed rather than subjecting patients to morbid surgeries like massive resections, reconstructions, etc. Even radiotherapy protocols changed from multiple sessions over 5 to 6 weeks to intense 5 to 10 sessions over 2 to 3 weeks. And so even the chemotherapy started changing. You can see here that this is a smoke evacuator, which was hardly ever seen earlier, but this became a routine kind of a thing. So in certain malignancies like the pancreatic malignancy, cancer lung with chest wall invasion, up to 40% of patients found that their choice of treatment had changed in favor of less aggressive modality like radiation therapy or chemotherapy. And in spite of that, marginally higher complications were noted in supramajor surgeries. You can see here that pancreatic surgery, which is a very supramajor surgery, or even a lung surgery, would actually change because people did not want to operate and subject these patients for prolonged ventilator therapy and hospitalization or intensive care therapy. We did a study for a small batch of patients for thoracic malignancies. Total number of patients which are operated at a single center were 51 over a period of 18 months, as compared to the normal about 150 to 160 cases were normally operated. And incidentally, 12 of these were diagnosed purely because they had undergone HRCT chest CT scan. So there, the COVID investigations actually came as a blessing for them. You can see here that 12 out of 51, and incidental diagnosis of thoracic malignancies in CT thorax, which was done, is in almost about when you take the entire thoracic surgery patient, including the one who were not operated, 19% were diagnosed purely because of incidental like that. So you can see here that the mortality rate in these incidental diagnostic patients was definitely more than what we normally have. Average mortality in case of thoracic cancer surgeries is below 2% at our center. However, this mortality was due to unusual complications like pulmonary embolism and acute myocardial infarction, which is rarely ever seen after you evaluate a patient very well. So how does COVID affect cancer diagnosis, misdirecting the very surgical treatment? Due to COVID or even vaccinations, patients may develop lymphadenopathy, which may take time to resolve. And this can be interpreted as progression of malignancy, particularly in lymphomas, breast cancer, when you have axillary lymph nodes, etc. And that's why before any mammogram, this information that the patient has been vaccinated or suffered from COVID must be relayed to the diagnostician by either the referring physician or the patient itself. Certain diseases like lymphoma, leukemia, treatments like chemotherapy, radiation therapy, stem cell, bone marrow transplants, immunotherapy may suppress immunity. That's why their response to vaccination itself may be inadequate. So these people will still retain their susceptibility to COVID. Secondly, patients treated for breast cancer should avoid the same side arm for COVID vaccination. Otherwise, they can get lymphedema on that particular side. Vaccination sometimes, rarely, maybe 1 in 10,000 or so, can result in thromboembolic phenomena. It's not absolutely unknown. It does happen, particularly in women 18 to 59 years old. Inflammation of heart may be seen in young adults. Rarely a Guillain-Barré syndrome could be seen. These factors should be looked for evaluation while patient is being considered for surgery, because these things happening later on can cause a lot of problem. How has COVID changed the ways of follow-up? Post-operative visits have definitely come down. There was a time when patients used to come in cancer clinics every 3 monthly or 4 monthly for a follow-up, but this has been minimized unless and until an absolutely must. Video consultations, which were abhorred earlier, an Indian patient would never, they would say that, no, I would like to see my patient. I would like myself to be personally examined. Now they accept this very, very routinely, like what happens abroad. Internet transfer of reports, pathology reports, histopathology, tumor markers, everything, and advice is routine now. So whereas COVID really left us, universal precautions are routinely being employed in the hospital, in the operation theater. Though the fear is less, the care is definitely more. We ensure that every patient coming for definite surgery is vaccinated at least 14 days earlier with the second dose. But there are people who exercise the option of no vaccination, then a negative RT-PCR is an absolute must, which should be less than 1 week old as far as our hospital is concerned. OT precautions of dressing, smoke evacuation is become a routine thing. Waste disposal is doubly cared for. So where does that leave with us as far as COVID and cancer is concerned? One is vaccination is ideal. There are various different types of vaccinations. No particular vaccine is really better than the other. 2 doses seem to be enough for taking care of our patients in cancer, except in low immune status, where the 3rd dose nowadays is being advised after 6 months. Vaccination may not eliminate infection, but definitely helps prevent the seriousness and a possible mortality in most. Today, the surgery, its indications, types of surgeries, magnitude are slowly reverting back to the pre-2020 status, but there is approach of cautious optimism. One must be aware while doing all major surgeries of state of hypercoagulability status after COVID or even during vaccinations. So these are the things which are very, very important to remember. Thank you very much.
Are there any questions? If there are no questions,
I think we can continue.
Yes, ma'am.
The next, yes.
So thank you. Now I'd like Dr. Nilesh to introduce our next speaker, Dr. Anirban Chaudhary. Over to you, sir.
It is my honor to introduce Dr. Anirban Chaudhary, our next speaker. He is a director, professor, and critical care expert at G.B. Pant Institute of Postgraduate Medical Education and Research, JIPMER, And without taking much time, we will. I will directly take you to the speaker. Thank you.
At the very onset, I wish to thank the organizers for giving me this prized opportunity to share my thoughts, views, and perspectives on this important subject. So the subject is dilution of quality care during COVID, how to set standards or limits. COVID has brought with it many unforeseen challenges, and we have all witnessed, be it in terms of resource limitations, be it in terms of controlling the infection, be it in terms of protection of the healthcare workers, or be it in terms of adaptation of the services that showed a paradigm shift too often. But probably the most testing time was the duel between quantity and quality, because when there is a fight between quantity and quality, only one can win. The silver lining, of course, has been that it has taught us some lessons which we will never forget in our lifetime. So the dilution of quality of care during COVID can be best corroborated under this pyramid of 4S: space, staff, supplies, and standards. First thing that we need is a space. Unless we have space, we can't move forward. Once we have space, we need staff. If we have both space and staff, but we don't have supplies, all our care goes out of the drain. And most importantly, if we have space, staff, and supplies, but yet we don't follow the norms or standards, then again, the result is not visible. So first, let us talk about the space. The space comes with designating an isolation space with negative pressure ventilation. Now, sometimes negative pressure ventilation may not be available. So in that case, we have to maximize the isolation with strict infection control practices and maintain air exchange at 6 to 12 air exchanges per hour. So that is one way. Secondly, we have to rapid identification and isolation of suspected cases. So there should be an effective or an efficient triaging protocol, which again should have a rapid access to the diagnostic testing. So these three facilities, that is an isolated location, a rapid identification through triaging, and access to rapid diagnostic testing, forms the important aspects of the space. There are several ways of triaging, but I will just go through the important ones. The Baron, Dominic, Jean, Larry. So this method of triaging relies on treating the most urgent or the sickest patients and deferring less sick or the likely fatal cases. So this is how this system operates in most parts of the developed world. The other important is the first come, first serve method, where treatment is based on arrival or presentation, regardless of the severity of illness, rank, or any other criteria. So here the prioritizing factor is order of arrival. And this is how the system works in most part of the world, including developing, developed, or underdeveloped parts. Now, a lot of focus is drawn towards less severity first treatment, or the LSFT, where prioritized healthier patients that can be treated quickly to allow them to return to the society, the labor force, etc. So the patients who are less sick are prioritizing factor, and many emergency departments have a fast track section, particularly for the patients. So whatever possible ways of triaging we are choosing is all dependent on us, but they should be based on some clearly driven rationale. The next important planning is for surge capacity of the ICU. Under normal circumstances, the ICU should have a surge capacity of 20%. That is 1.2 times of its capacity. The beds should be able to increase anytime. Once that is fulfilled, we have to utilize our normal pressure ICU beds or existing monitored beds, which are available in the operating room
in the post-anesthesia care unit, high dependency unit, so on and so forth. Once these are exhausted, we have to look for the cohort beds with physical barriers like curtains in between patients, maintaining a distance of 2 meters. Next, we have to ensure timely step down of the stable patients with de-isolation protocol, because once those patients are shifted out, again, we will get space to accommodate new patients. But over and above, we have to remember that wherever we plan ICU bed, we should take into consideration the availability of all the things that are necessary, like oxygen ports, compressed air supply, clean water, drainage, etc. Otherwise, it is not serving any purpose. The second S belongs to staff. Staff should be segregated into frontline teams, the second team, the third team, like that. The frontline sheet should mainly consist of workers who are well versed and well experienced in ICU, with some semi-trained workers, so who can work under the guidance of the fully trained workers. And then the second line, we have more of semi-trained, and the third line, we have more of the least trained staff. We have to implement strict infection control, prevention of the infection control measures, education of the healthcare workers on infection control, and also in N95 fit testing, which was very important during the first wave. People experienced a lot of difficulties in this N95 fit testing. Periodic training of the remaining workers, staff surveillance and temperature monitoring, etc. in the clinics, and also initiate hands-on training for the non-critical care nurses and healthcare workers using online materials and instructional videos. Why this is important? Because it has been seen that if in an ICU in which infection control procedures are rigorously applied, the risk of staff of contracting SARS from patients is low, despite long staff exposure times and a substandard physical environment. So it is very important to give maximum attention to this aspect. The importance of imparting training using simulator is also very important, because it has been seen that when a group of staff, under lesser trained staff were imparted training using simulator versus actor patient, then patient actors underestimate the resource utilization in drills, because all the time identifying respiratory compromise, identifying circulatory compromise, providing definitive airway, initiating vasopressors, disposition, all took longer time in simulated patients. So simulator patient technique was more effective, and therefore integration of high fidelity simulator patients in institutions can create more realistic challenges and better preparedness. Next comes is the supplies, the third S. So we have to ensure adequate supply and stockpiles of PPE, essential consumables, medications, and equipments, because if we have some equipment malfunction, we need to replace them. So we need to have a careful collection of equipments that can be used when something goes defunct due to prolonged use. Source for alternative supplies for channels for supplies of equipment should be identified a priori. We should have to segregate the equipments when required, like ultrasound machines which are using for the purpose should be segregated. And we have to harmonize item purchase within hospital and clusters so that we can available on time and purchase can be made conveniently. The last S stands for standards. So it is important to realize that maintaining clinical standards is very difficult, but it is of utmost importance, particularly principles of ARDS like lung protective ventilation, prone ventilation when appropriate, considering early intubation, when not to consider NIV, how to adapt to the resuscitation and emergency procedural workflows. All of these are very important. But we also have to remember that patients who are on prolonged ICU, they might require ECMO. So identifying ECMO referral center, establish transport workflows with those centers are very important to maintain the quality. Moreover, inter and intra-hospital teleconferencing to share experience and knowledge can not only be of importance of enlightening, but also very encouraging and morally boosting. Now, this is the CHEST consensus statement on the surge capacity principle based on whether the situation is conventional, contingency, or crisis, depending upon the spectrum from normal to the extreme situations of the phase of the pandemic. And like I said, other than 4S, they included ICU expansion goals and resources. So ICU expansion goals was 1.2 times conventionally, into 2 times or 100% in contingency, and up to 3 times, that is 200% in crisis. The resources utilization pertaining to the conventional were mainly local, in contingency from the region or the state, and in crisis at the national level. So it is important for intensivists to consider that when we are assessing the resource commitments, we should know these 4 T's. Treater, what is the amount of staff expertise required to provide critical care in that particular scenario? Time, the amount of staff time required to manage the patients. Treatment, the amount of resources required to manage the patients. And last T is threat, that whether there are any risks to the provider or the patient generated by the situation due to any of the reasons. The ABCDEF bundle in critical care is known to all of us, but we often tend to forget F or family engagement, because we have to remember that in such situations where the family is not able to meet the patient, somehow doctors, the nurses, and other healthcare workers have to put in some extra effort to bridge the gap and try to give them the confidence and boost. There are definite recommendations about intubation and transport of suspected known COVID patients, and this have to be followed in order to maintain the quality and prepare and prevent any disaster. And this pertains to both preparation, intubation, post-intubation, and transport. We all know that the timeline of influenza outbreaks in the last century has been getting widest publicity after COVID. And based on that, we are also making prediction of and prevention of the and means to prevent the next pandemic zoonosis. That is also available in the net. But what we should remember that the need of the hour is to develop more robust research and monitoring programs, because trust is undermined when scientists make overblown promises about disease prevention. So this is very important that this lesson pandemic has taught us. So finally, my take-home message would be that extraordinary situations put sustained demands on critical care services, as were witnessed during COVID times. Critical care physicians must take the lead in planning and implementing measures to ensure continuity of services. 4S, that is space, staff, supplies, and standards, is of paramount importance to ensure quality and prevent its dilution. Nonetheless, it is also important to maintain services for other patients, protect the healthcare workers, and adhere to the ethical and social implications of the triaging that is adopted during a crisis. Thank you for your patient hearing.
Thank you, Dr. Aniban Home Chaudhary. Actually, this situation, you have done a very nice presentation on the dilution in quality care, and this happens, I think, in almost all institutions, all hospitals, big or small. Rather than like saying the problem, the problem was like how to solve it. Like we don't have a space, how to create it. We don't have staff, how to
I have narrated the 4S, and these 4S are the ways to solve it. It is clearly known that it is not possible to solve this problem in entirety, because certain amount of lapses are dynamic, because the entire situation or the fluctuations that evolve during the course of pandemic vary along a spectrum like a wave. It is like a sinusoidal wave. So probably overcoming all the challenges in producing 100% improvement in the quality is not possible. But if we focus on this 4S, then probably we will be space, supply. So as you know the standards, so as staff, and so as and accordingly we in that particular order, then at least 80 to 90% of the quality can be still be preserved and retained. Any other question, madam?
From the floor, anyone?
How do we deal with the political pressure and the other pressure from the government resources? How do we handle that?
Political pressures are cause of different pressures, because political pressure is both subjective and objective. Nobody can measure how much pressure one is experiencing, and yet they can feel that there is some pressure which they're beyond the ability to tolerate. So if the pressure is like, don't disclose, don't reveal the actual numbers, continue to admit patient even if RT-PCR is negative, it all depends upon what one can, how much our own conscience permits us to to afford to, or rather I say to bear with such kind of pressures, if in tune with our moral and ethical obligations, which are larger than expectations of others.
Okay. Thank you.
I think you got my answer.
Yes, I got.
Are there any more questions?
Thank you very much. It was my great pleasure to understand and describe my feelings on this particular subject.
Thank you, Dr. Chaudhary. Now I'd like Dr. Tamanna Bajracharya to introduce our next speaker, Dr. Saurabh Kole. Over to you, ma'am.
Welcome, Dr. Saurabh Kaul, and now he will be talking on experience of COVID warrior getting himself knocked on this topic. Dr. Saurabh Kaul is in charge ITU and Department of Emergency Medicine at Bellevue Clinic, Kolkata, West Bengal. He has published a book named Ventilation Med EG. Many stalwarts of critical care from our country and abroad have contributed to increase the content of this book. He had worked on earthquake affected victims of Gujarat and published, and it was published in the World Federation of Critical Care Journal in the year 2001. He is conducting many teaching and training programs, as well as arranging seminars to create constant awareness among people on subjects like CPR, disaster preparedness, primary management of accident where no doctors is available, and abstract. And he had more than 10 abstract and scientific publication in different international forums. Welcome, Dr. Saurabh Kaul.
Hello. Good evening, everybody. Good afternoon, everybody. Today, I am going to discuss my own experience when I was working in the intensive care unit, in the flu clinic, and the Department of Emergency Medicine in our clinic during the pandemic. As the COVID pandemic has brought our normal life to a standstill, we have become more and more dependent on our health workers and medical services. Our frontline workers are working day in, day out, even today, pulling off 30-hour shift without any sleep or rest, cut off from their loved ones, only to make sure that the spread of the virus is contained and the fatality number as low as possible. Actually, the pandemic has brought an unprecedented challenge before the global community. It can be labeled as one of the most severe pandemics, which has already affected 210 countries, including India. So you can see this was the COVID numbers in India cities from the April 1 to 24. You can see that how much severe it was during those days. And you all know that in the initial stage, the first step, diagnosing COVID-19 patients was a challenge in itself, as symptoms are similar to other diseases. The second worry was where to quarantine patients. Then to top this, research on the use of medicines like hydroxychloroquine was on nascent stage. And the many other drugs are also on nascent stage. Lack of manpower, especially the paramedical staff, infrastructure like ventilators, high oxygen equipment availability of medicines, all these were really a problem at the time. An excruciating level of work stress and increased risk of contracting infection to the family members, dual burden of facing the workspace and the brunt of social stigma compelling some of them even leave the neighborhood, denied access to their own houses, and to top it all, a constant sense of impending doom and a constant fear to losing our near ones made the pandemic more about the mental fight. So we have treated in our ITU more than thousands of COVID patients in the last few months. From the month of March 2020, the fight against COVID-19 started, and I was also involved in giving all kinds of treatment to the patients with our juniors and seniors, and we have used PPE and following all other safety precautions as per guidelines in the emergency flu clinic critical care unit. And at the time, huge emphasis was given on the screening of the patients before they were admitted in any department to prevent the spread of the infection within those departments. Proper history taking and mandatory travel history was very much important at the time. Junior doctors and healthcare workers played a very crucial role in the fight against COVID-19 pandemic for the last 1.5 years. Actually, their enthusiasm encouraged me to push my limits further. I felt it was very much necessary for me to be the side as they were toiling day and night in managing the humongous patient load. But in spite of taking all kinds of protection last year, actually I had developed fever, dry cough, headache with malaise and severe weakness. Thereafter, I had done the CT thorax and also the nasopharyngeal swab for the COVID-19 artificial test, and the test report came positive. And I was also admitted in our clinic, and I recovered and returned home after 12 days of stay, even though at the time my artificial report was still positive. All this time I was thinking that the worst days were finally over. But 3 days after, my father started showing the initial symptoms of COVID. Initially, oxygen saturation was maintained and symptomatic treatment was being given. But later on, he developed sudden respiratory distress, for which he was immediately admitted to the intensive care unit on 4th August. Even though the CT report showed considerable involvement of the lower lobes of the lungs, he started responding to the drugs. But on 8th August 2020, his condition, however, started worsening and was put on ventilator. After putting up a strong fight for the last 5 days, he left us on 9th August. So life didn't even give me the time to accept and to grieve. 15 days later, my mother, who was suffering from the chronic disease, she was suffering from the rheumatoid arthritis, she was suffering from the ischemic heart disease for a long period of time, also passed away. Within even less than a month, everything changed forever. The silence of that empty house was even more deafening than the helpless cries and screams of the world outside. And I had to join work the very next day after completion of the memorial service of my mother. And in fact, I didn't have the strength to sit at home and processing the pain. So I decided the best way to deal with the pain was by helping those who are going through the same trauma and were in dire need of help. It's by saving others, in fact, we can save ourselves. The second wave COVID-19 infections took India by storm, with a fourfold increase in daily new cases and deaths from the first wave. Hospitals, testing laboratories, crematoriums, and local governments reeled under the explosion in cases and fatigue. With a massive surge of the cases, we also had to deal with the more unfamiliar complications. The second wave actually washed away a huge population. Almost every household had lost someone. With the advent of mucormycosis, post-COVID complications, and the massive surge of cases within a very short period of time, accomplished by the dearth of oxygen cylinders and scarcity of the available hospital beds, the second wave became a whole new challenge. And India has been reporting a record rise in daily cases. You can see that during the period of August, November, the the tremendous increase of COVID patients in our country. So it was just not a COVID-19 wave, it was a tsunami. It was a devastating wave sudden from the epicenter of China and was almost half of the global population. It took away everything. We were never ready to lose or even got the time to say goodbye. But it did bring us together. The entire humanity got united to fight together against this deadly virus. The fight for survival. During the lockdown, while the entire world was locked in their respective homes, we came up with the new ideas to communicate, to reach out for people even in the remotest part of the country. So came the idea and also the practice of telemedicine, by which we could reach out to the patients all over the country while staying in the safe boundaries at home. Telemedicine, this was the first time it was accepted by the government and accepted by the medical council also, and the practice has been started. Telemedicine practice has been started all over the country. So global disasters such as pandemic or even that cause a major disruption of health and social care, industry and economy, and community and education. Disaster healthcare provision requires a collaborative approach that uses the expertise and skills of as many people as possible. The current medical student curriculum already covers a wide range of specialties, and many argue if it is stretched. We know that nowadays disaster preparedness has been included in our medical curriculum in preventive and preventive medicine. However, the rising incidence of worldwide disasters and the impact of the current coronavirus pandemic has justified the need for disaster preparation training in the medical students, and also who are also for us who are practicing daily clinical medicine and the critical care. In fact, we have to learn the preventive care as well. You can imagine for the last 30 years, when this critical care was started, it was started only with the ICCU, intensive cardiac care unit. Now intensive therapy unit, now neurocritical care unit, now gastrocritical care unit, now surgical critical care unit, cardiac critical care unit. So we are gradually realizing the importance of the specific units also. But at the same time, we who are already practicing critical care, the time has come. We should equally know about the preventive care also. In future, probably the preventive care will be included as an important part of the critical care. So this is a disaster preparedness, and it is when there is a pandemic phase, and if there will be a transitional phase, there will be a post-pandemic phase, and pandemic phase. And all these phases, we have to know the risk assessment, recovery, prevention, mitigation, and we'll have to practice preparedness, and also so that we can respond in a proper way. We know that this COVID-19 was quite unprecedented, and we don't have any preparation earlier for that. But this event actually shows the importance of disaster preparedness, and in future we should be prepared for any disaster if it strikes in our country or also in the world as a whole. So the conclusion, actually, the pandemic took so much from us. It took away our loved ones, our mental peace. It turned our life upside down. So many doctors lost their lives while fighting the pandemic. So many families got completely destroyed. But the loss taught us the value of what we have. It's when we lose someone, do we understand the true value of having that person in our lives. And also how unpredictable life is. It was a wake-up call for the entire humanity, who had spent their entire lives in war, in hatred, and in pulling each other down. One thing I had learned from this pandemic, it's not how many years we have survived in this world which matters. What truly matters are the memories you leave behind. So instead of grieving over the we have lost, we should rather concentrate in living our lives the way we want others to remember us. When we started our unequal fight against this deadly virus back in March 2020, as in charge of an ITU, I never thought that one day I would be given the opportunity and the platform to share my journey during one of the toughest phases of our lives. I would like to take this opportunity to thank you for the invitation and the excellently organized conference. Thank you.
Thank you, Dr. Saurabh Kaul, for a nice presentation. It is rather, this pandemic is rather a disaster, and we faced it, we have faced it, and we are also facing it. Now there has been decline in the numbers, so there's positive signs. So we are all happy, and we are eagerly awaiting for our normal life. The times heals. Time is a very strong what do you call healer. So with time, I think everything will be all right. So any questions to our speaker?
There are no questions.
Sir.
So shall we conclude our session?
Yes, ma'am. Thank you to all the chairpersons and the speakers. It was a very informative session. We shall now conclude with our second thematic session. And thank you, everyone.
Thank you, everyone.
Thank you.
Dr. Amrita, please start.
Hello, good afternoon to all the respected doctors and the delegates. I welcome you all to the international session of the day one. The chairpersons for this session are Dr. Jhuma Shankar, Assistant Professor, Department of Pediatrics, All India Institute of Medical Sciences, Delhi. Second chairperson is Dr. Neeru Gaur, Senior Consultant, Department of Anesthesia and Critical Care, Medipulse Hospital, Jodhpur. Our third chairperson is Dr. Bikram Gupta, Head Critical Care Medicine, Heritage Institute of Medical Sciences, Varanasi. Now, I would like to call Dr. Jhuma Shankar to introduce our first speaker for the session, who is Professor Dr. Jos M. Latour. He will be speaking on the topic, the UK nursing experience. Over to you, ma'am.
Thank you. Can I have the CV slide? Yeah, so good afternoon, everyone. So we are very fortunate to have Professor Josh Latour for this session and to be starting this session. He is a very well-known researcher, clinician, and he is the professor in clinical nursing and associate head of research school of nursing and midwifery, and he has extensive research experience and has very important contributions to the field of pediatric critical care. He is also the visiting professor of Harvard Medical School, Boston Children's Hospital, adjunct professor in nursing, Curtin University of Technology, governor of Somerset NHS Foundation Trust, and associate head of school research, School of Nursing and Midwifery. Apart from these, I have seen Dr. Josh Latour over the last 1 decade, and he has immense contribution to the field of pediatric critical care and especially in clinical nursing. And we are really fortunate to have you, sir, and over to you.
Dear colleagues, dear friends, welcome to the international session, Challenges Faced and Strategies Practiced During Pandemic. Our experiences from a nursing perspective and then mainly in the UK, but I'll take that forward to a wider world perspective as well. I'm Josh Latour. I'm a professor in clinical nursing at the University of Plymouth. I'm also a professor in pediatric nursing at Hunan Children's Hospital in Changsha, China. For this presentation, I have no conflict of interest. I like to sort of have 4 topics discussed within the next 12 minutes. COVID-19, the start in China, our experiences in Wuhan, were we prepared, and the reality in practice. Now let's start with COVID-19, and it all started, as we know, in China, where our experiences where I worked part-time at Hunan Children's Hospital, but also in Shanghai at the Zhongshan Hospital of Fudan University, where I work closely together with Professor Zhang Nuxia, who is the director of nursing there, but also a professor at Fudan University. Well, since I was there just before COVID hit, end of 2019, we thought we need to inform the world what the strategies was in how we dealt with the early stages of COVID, so the experiences in Shanghai. And as you can see, 20th January, the first COVID cases came. The 12th of March, 344 COVID patients were admitted in one hospital in Shanghai, one specially assigned hospital where all COVID infected patients were actually admitted, while the other hospitals could go continue work as usual. And I think it's important to share this, which we published in the Journal of Advanced Nurses, where you could see that it was a 4-step procedure for all patients as well as visitors coming into the hospitals before actually going into treatment rooms with consultants and doctors. So how was the experiences then in Wuhan early days? We in Shanghai deployed 107 nurses to Wuhan, which was a fairly young group. 66% was below 30 years of age with a limited experience in intensive care, caring for severe and critical ill COVID patients. They were, because Wuhan was having shortage of nurses. And all nurses who were then involved in a study, we actually tried to identify the stress, burnout, and coping strategies, were working at least 1 month in the COVID units. We used 2 surveys in our study, a stress, coping, and support questionnaire, which was adapted from the SARS epidemic, as well as the Maslach burnout inventory. So the perceived stresses from the early onward nurses who were the first one working with COVID patients in Wuhan was the uncertainty how long the current working states will last. Then 84% said that worrying to get infected, and 76% of the nurses provided discomfort caused by PPE. While nurses younger age, less working experience and longer working time in COVID units had higher burnout levels. So far, this was the first wave experiencing. And if you look at after half a year of the first wave, now recently I look at it and there were 415 papers are all about related to the experiences of nurses and staff and doctors, and mainly in intensive care areas and or emergency areas, about the first wave, about their well-being. But there is also now a second wave going on, and the very recent paper that came out by Elie Azoulay here in Europe, particularly in France, where he performed another survey among 1,200 healthcare professionals. Of them, 845 responded, mostly nursing staff and medical staff, as well as a number of other professionals. Most of them, so 57%, had treated more than 10 new patients with COVID in the second wave. And again, not surprisingly, is that the symptoms of anxiety, depression, as well as post-traumatic stress symptoms were the major issues among all respondents. But as you can see, there's hardly any difference between all respondents, so nurses, doctors, and allied health professionals as compared to nurses alone. Because the figures between the nurses here in this box and the all respondents are consistently high and almost a similar figure. The question is, were we prepared when COVID hit us? And I'd just like briefly to touch down on these two papers. So the Ethics of Outbreak Position Statement Part 1, Therapies, Treatment, Limitation and Duty to Treat, as well as Part 2 about Family-Centered Care, published in Critical Care Medicine in 2018. So these papers were actually giving us the guidance. We didn't need to invent a new wheel when COVID hit. Basically, if I pick part 2 about family-centered care, that we closed our units, no family allowed again in, it has been already written down back in 2018, and 9 recommendations were provided here. So disclosure the unknown, decision processes, patient-family communication, all the guidance where we have been working here in Europe very hard to set the recommendations up, already published in 2018. So back to reality and practice. What happened with us here in the UK, here in Europe? And I think I'd like to share with you the work I've been involved with Emilio Rodriguez Ruiz, who is a young, enthusiastic intensive care doctor. Now, we started back in 2019 to develop the empowerment of patients in the intensive care family questionnaire to measure actually the family satisfaction and experiences in the adult intensive care unit. COVID hit, we continued, and actually what you can see, so this last paper we published recently in the intensive care medicine, looking at the impact of different visiting policies, because we did have different visiting policies before COVID and after or during COVID. And particularly the family participation domain in our family satisfaction survey showed significant differences in all aspects, because the mean scores before the COVID hit was 580, and the mean scores during COVID was 567, which was a significant difference. Now, Obviously, the sample size of our study was small, but we closed our study during COVID. However, we think that meanwhile, during the second wave, and we have a lot of information coming in, how we deal with parents, family members, relatives, next of kin, friends of our ICU patients, we should revisit our family-centered care practices to ensure that temporary changes implemented during the pandemic do not undermine the role that families play in the patient recovery. Right. So the impact, if I look at the UK system, obviously we were having lots of appreciations by the public in the UK. However, the first wave, the second wave, the third wave, meanwhile, here are a few of the figures we have. The government is planning to give a 1% salary increase. Now, is that enough or is that a big laugh? It created some anger among staff that it was just a little bonus, far too little. But also very worrying is that 11.4% of the nurses are off sick. And of these, 7.5% are related to coronavirus. Then we also know worldwide that 115 healthcare workers died. So that's a major impact. And 25% of the ICU nurses currently are planning to leave the ICU. So this is a major impact here, what we experience. Now, in summary, I do believe, and you can see this graph, what happened with the COVID infection worldwide. It exploded back in March 2020. April, it went into the Americas. It became less in the Asian countries. However, if you look at the graph, moving forward in June last year, then suddenly August came and an explosion again of infections in India becoming bigger. As well as later on, by the end of the year, you can see that Europe is coming bigger again on the map. So I think whatever we have and whatever we experience for the next few months ahead of us, we carefully need to look at the well-being of ICU staff during COVID and even after COVID. And that's important to consider, and we need to identify effective interventions to support our staff. Teamwork is the driver for surviving the COVID-19 pandemic. Teamwork optimizes patient outcomes, family satisfaction, and staff well-being. So thank you very much for listening. Thank you for supporting me. Thank you for supporting your team. And it's okay not to be okay. Please support your team. Thank you very much.
Thank you. Thank you to Professor Jos Latour for that very important and overview of how the nurses dealt with the pandemic and what happened to the family-centered care. I think we can take up the questions at the end of this session.
Okay, ma'am. So now we move on to our next speaker for today, Dr. Nihat Shirvai. I would like Dr. Neeru Gaur to introduce her. Over to you. Ma'am, your mic is off. Please unmute.
Okay. Hello. Hello, I welcome Dr. Nihad Nabil, and she is a consultant intensive care at Al-Kami Hospital, Sharjah, UAE, with a membership of Royal College of Physicians, UK. She is having a EDIC also with Saudi fellowships in ICU and various diploma in healthcare administration, and she is working as a consultant intensive care. So with this, she is going to, Dr. Nihad will share her experience in this COVID pandemic, what experience she had, what difficulties she faced, and how they cope up with these things and how they manage. So I would like to welcome Dr. Nehad. Thanks.
Technical team, please stop the sharing and share again. Sound was not coming.
Conference. Hello, everyone. It's my pleasure to be in this conference to talk about Dubai experience in dealing with COVID-19. I would like to thank the organizing committee for inviting me to talk in this very important conference. As you all know, that coronavirus was confirmed first cases in Wuhan in late 2019 in December, and the first case in UAE was confirmed in late January 2020. And since then, all authorities in UAE collaborated together with including the governmental, the private, to fight this pandemic. So there were so many changes during COVID that happened in the healthcare system, starting with staffing, bed capacity, supplies, protocols and guidelines, the need for electronic medical record changes to help in entry of patient data, and the very important aspect, which is infection control, the need to educate healthcare workers who never dealt with such pandemic before, and the great need for research to test medications and to test also for vaccine, and the communication between different health authorities and governments and research bodies throughout the world, and finally also caring for each other to fight the psychological effect of COVID-19. So the daily new cases in the UAE, starting from the pandemic beginning, which is late January, there were in the beginning very sporadic cases, and then we had the first wave and second wave, and then probably the third wave started in late December 2020 and continued till May. And as you see, in May, we started to have a very great decline in cases thanks to all efforts and also to the national vaccination program. These are the active cases, and as you see also, we have a great decrease in September and October 2021. So everybody was planning for the COVID, and really we didn't know what we were dealing with, because this is totally new for us. And this pandemic raised so many questions regarding the testing, the healthcare worker availabilities, whether to wear or to adopt universal masking, and which patient to treat, and which patient to admit to the hospital, whether we adopt a lockdown or curfew, and whether the PPEs are available in the in the case of lockdown, and also what are the travel guidelines that all countries should adopt. So this pandemic was totally new for all countries, and we had to ask this question and find not only an answer, an urgent answer to these questions. So UAE initiatives to fight COVID-19 consisted of 5 main main points, which are listed here, and we will talk about each point separately. Regarding surveillance and contact tracing, there are many efforts that also started across the country, and electronic applications also helped in this task, which is, for example, we had the stay home application to trace the people who are advised for self-quarantine. The Directorate of Health in Abu Dhabi also launched a remote care application, which helped in telemedicine because clinics were closed. And then the famous Al-Husn mobile application, which also used for contact tracing, for surveillance, also for test results. Any person across the UAE will do any test, it will appear in Al-Husn mobile. And then recently also, after the vaccination, the type of vaccine and the date of vaccination will be there in Al-Husn mobile. So the Ministry of Health and Prevention also in its site has launched this virtual doctor, and any person who would like to have an advice, an online advice from doctor, they will log on into this virtual doctor application. Also, the Directorate of Health in Abu Dhabi also has the same idea with a remote healthcare platform where service. So regarding containment, UAE had to contain and limit the spread of the COVID, and this was through closing of almost all activities, including schools, universities, parks, also mosques, temples, churches, and applying remote learning and remote working for government employees. And regarding also the restaurants and cafes, only food delivery was allowed. And then a widespread national disinfection program was applied throughout UAE. Then in March and April last year, there was a 24-hour curfew and only residents were allowed to go home, out of home for necessary needs like going to the pharmacy or emergency and so on. Universal masking also was applied with a large fine in case anybody is abiding this rule. So there is a United Arab Emirates governmental board, which has several guidelines related to COVID, and this is available for all UAE residents. And as you see, there are many guidelines regarding social behavior during prayers, operating schools, and also regarding travel. So just by one click, you can read these guidelines, which are very helpful. As you all know that COVID did not only affect the health or healthcare or the health of the individual, it affected also the mental health. And this also was taken care by the authorities of UAE, where they had a support health, a mental health service, which is called Hayat, and also another program, which is Employees Assistance Program for government employees, and a happiness and well-being hotline, which will help in the mental health support. And this national campaign for mental health support with the participation of more than 50 professionals and experts, and consisted of 3 key components. So the first component was Let's Support Together with a virtual sessions, and then Let's Reassure Together with a videos by an experts, and then Let Us Talk Together with virtual support groups. Then treatment and testing. So really we had a mass testing with more than 5,000 tests per day, and mass production of N95 respirator, and many places like Dubai Exhibition Center were turned into hospitals, and some also hotels were turned into isolation facilities. Then we had the screening program all over UAE, including Abu Dhabi, Dubai, and other Emirates. The treatment guidelines were available, and they were updated every now and then to keep with the changes and research of COVID. So as you see, this COVID tests per 1,000 people, and the dark green represents the areas of highest testing. And as you see, UAE, I will show you a close-up here, and you see UAE is among the highest areas, or if not the highest country in Asia that did tests per 1,000 population. And if we compare it to United Kingdom and United States, United Arab Emirates ranked the highest in number of tests performed per 1,000 people of population. All the health authorities have joined together to provide the national guidelines for management and treatment of COVID, that not only include the management, but include also the infection control guidelines. And the first version was launched in March 2020. And it was, as I said, updated with some, some of the medication were dropped off and some medication are added according to the most recent research. Field hospitals really were a very great help for us who are working in the hospital. And this was a result of collaboration of the governmental, semi-governmental, and the private sector. And there were a lot of volunteers in these hospitals. The first field hospital was opened in April 2020 in Dubai World Trade Center, and then followed by field hospitals in all Emirates from Sharjah to Ras Al Khaimah, and increasing the bed capacity to more than 5,000 beds. We have also in Abu Dhabi, and as I said, this field hospital really added and decreased the load on hospitals. To come to governmental support, it was really a great effort and a great help for all UAE residents, from healthcare workers to laypersons. And the government has announced an extensive packages to help people facing the economy, or changes in economy resulted by COVID. And this actually was almost 126 billion dirhams. And it also, all the people who were admitted for COVID or treated in the health centers were treated for free, regardless their nationalities. And this figure has shown how much the UAE governmental support and response to COVID-19, from the national disinfection program to the food and beverages that was provided, and to the medical and food supplies, and so on. Regarding the vaccination, this is a really great success story, where more than 95% of the population received one dose of the vaccination, and more than 85% received 2 doses. And this has resulted in a great decrease in the number of active cases and in new cases in UAE. Also, because of the great number of critical care patients, the ICU was redesigned, where separate COVID and non-COVID ICUs, with also a separate healthcare workers. They were not also merged together, and to avoid spreading of the infection. And donning and doffing rooms also were designed and equipped with all the necessary PPEs. And education. So education was given and provided to volunteers, to healthcare workers who were deployed from other areas than the intensive care units, like emergency, internal medicine, and they were working under the supervision of a certified intensivist. So the organizational approach was started by cancellation of elective surgeries, and closing clinics, and deploying intensivists and ICU nurses, telemedicine, and a program of home deliveries of medication to patients with the chronic diseases. And now, with the decrease in the number of cases, we are starting to open clinics and OR for elective surgeries, and return back the staff, like, for example, the emergency staff or the internal medicine, to their original departments. The end result of all these efforts is to fight corona and decrease a huge decrease in the number of active cases. These are the number of confirmed cases, and as you see, it started to decline in July. And now we have less than 200 cases per active cases per day, and this is the positive rate, which is only 0.8%. And you see this also reflected on the decrease of COVID-related death. And as you see now, we have very low death. And actually, I'm working in the ICU, and for the past maybe more than 6 weeks, I haven't admitted any active cases or critically ill cases with COVID. So I come to my last slide. The key points that happened or the changes that happened during COVID in fighting this pandemic. In the staffing, we have the frontline heroes who devoted their time to fight COVID. The bed capacity, as I said, was increased by the field hospital and by canceling elective surgeries and closing clinics. PPE supply was never deficient, and mass testing and provision of equipments on an emergency basis. Guidelines were provided very early and updated regularly. In the medical records, we had an order set that helped physician entering the data of COVID patients, infection control, and thanks to all infection preventionists who really were working day and night in fighting COVID. Education was provided regarding infection control practices and ICU-related training for non-intensivists. Mass testing and clinical research in testing and the clinical treatment were conducted in collaboration with national, international, and regional authorities. Communication, a very good communication happened at global level, both in clinical and non-clinical issues related to COVID. And finally, we didn't forget the psychological and the mental health, with also dealing with burnout, support group, and also financial support. So UAE efforts in fighting COVID really is a success story. It's a great success story, thanks to everybody, starting from the government down to all residents of UAE who really were collaborating together to fight COVID. And by this, I would like to thank everybody for listening to my presentation.
Thanks, Dr. Nihad. It was an excellent presentation. You have covered each and every aspect you dealt with, and you had all the healthcare challenges and you fight with them, and you brought them at a good level and a very good rate. And the best was the national campaign for mental support, which was very good for the family as well as the patient. It was a very well explained.
Thank you very much. It's my pleasure to be here with you.
Thank you, ma'am. Now we would like to move on to our next presentation from Dr. Carlos Sanchez. I would like Dr. Niru Gaur to introduce Dr. Carlos, who would be talking on the topic of the Equator experience.
Dr. Carlos Sanzi is the head of critical care services at Hospital General IESS, and he's a president of Project Sepsis Latin America, with a member of Latin America Sepsis Institution, and a president of World Sepsis Meeting in 2020, and member of various societies, and also the active member of Society of Critical Care Medicine. I welcome Dr. Carlos for presenting us the very good topic and his experience in this pandemic era. Thank you.
Everyone, my name is Carlos Sanchez. I'm a critical care specialist from Ecuador. I want to thank the organizing committee for the invitation to talk about COVID-19 in Ecuador and our experiences. I declare that I have no conflict of interest. Ecuador is a small country located in South America. It has an approximate population of 17.5 million inhabitants, in addition to a high migration mainly of Venezuelans. The literacy rate is approximately 93%. The official currency is the US dollar. The first case of a patient with COVID-19 was confirmed on February 29, 2020, shortly after the reports in China. The patient was an Ecuadorian woman who lived in Spain and arrived in Ecuador on February 13th. Of course, she did not know that she was infected, but a few days later, she started with the respiratory symptoms that worsened rapidly, and she was admitted to a hospital as a typical pneumonia. On March 13th, the Ministry of Public Health reported that the patient had died from COVID-19. At that time, another 23 positive cases had already been reported, mainly in Los Rios province, which is where my hospital is located. On March 14th, the National Committee for Emergencies and Disaster prohibits gatherings and events with crowds of people. On March 15th, the president announced mobility restrictions to prevent the spread of the virus. On March 16th, the president decrees a state of exception, and only health workers, armed forces, and the police can live using an official document. You remember this kind of images, totally empty cities, ghost towns. So what did we do? First, we met with the leaders of the different departments and services to coordinate the work in our hospital. We restrict access to the hospital, limiting the number of family members and companions. We organize respiratory triages, mainly with mobile tents outdoors. We sanitize the facilities. Of course, later we learned that this did not provide an improvement in care. We had to improvise many things. One of the most worrying was the personal protective equipment. Remember these boxes and how uncomfortable they are. We had to create protocols for hospital mobility, patient flow, suspend external consultations, organize cleaning schedules, improve the admission system by minimizing the stationary to be used. We had to strategize for the use of ambulances and repair all the mechanical ventilators in the ambulance that were defective. One day in March 2020, our first patient with a high suspicion of COVID arrived, a pregnant woman. When we thought we were organized, everything was a total chaos. We had to convert regular inpatient rooms into isolated rooms and create more complex and effective organizational process. Positive results were seen soon, but of course, not everyone succeeded in the learning process. Many people died. At that time, Guayaquil, the biggest city in Ecuador, and Milan in Italy were the worst hit cities in the world by COVID at the same time. What was happening in Guayaquil made headlines around the world. In the main hospitals of Guayaquil, they were collapsed. There was no were to keep corpses. Every day, there were hundreds of deaths. There was even a need to place cold containers on the outskirts of the hospital to store the corpses. There were long lines to take the deceased to the cemeteries. The number of corpses exceeded the capacity of the state to handle them properly. Such was the number of deaths that many of them were in the street everywhere, reaching the point where families burned their bodies in the street. This first wave in our country was over, and it left us very beaten. So we were forced to better prepare ourselves for the great challenge that was coming our way, the second wave. This is one of the rooms of my intensive care unit. We optimize all the spaces. We improve the capacity. We use absolutely all the oxygen intakes in the hospital. We had to install larger central oxygen tanks in the hospital, since all the oxygen we consumed in 20 hours. We put beds in every place we could, even in the hallways. In our intensive care unit, this was what we had to improve the most. New ICU admission criteria, new update, evidence-based management protocol, optimization of oxygen therapy, early protective mechanical ventilation. We kept the patients in the prone position for longer, corticosteroids, dexamethasone, 8 milligrams per day during 10 days, anticoagulation and enoxaparin 1 milligram per kilogram every 12 hours until ICU discharge, optimization of sedation, analgesia, and neuromuscular blockade, physiotherapy, and rehabilitation. Optimizing the use of oxygen was something we had to work on a lot, since outside the ICU, oxygen was only used at 15 liters per minute. So what partly explained reality was not different from that of many countries in which the mechanical ventilators that we had were not known. Therefore, we had to create our own ventilators and advanced oxygenation devices, such as handmade Mapleson devices. These devices help us a lot in the management of the patients, and was our last line before reaching invasive mechanical ventilation. So this is a mechanical ventilator designed by engineers in Ecuador. It worked with basic parameters, and we use it compassionately. At the end of 2020, we began to use high-flow nasal cannulas. This provided the patient with very comfort, so we could use them as advanced oxygen support in the prone position, either with the patient lying down or sitting down. Although there were drug crises worldwide, for patient sedation, our proper management allowed us to have everything we need during most of the pandemic. It is true that there were times when we had to take unusual combinations of drugs as morphine, ketamine, lidocaine, magnesium sulfate to be able to reach a certain degree of depth in analgesia and continue the pronation. Our sedation protocol is called SEDASI. It is a protocol developed in our country here in Ecuador, and that allows us to handle drug with a certain preparation according to the desired level of sedation and the patient's weight. The drug is infused according to tables for each drug. This saves time and preparation and achieves goals more quickly without over-sedating patients. So we do chest CT for all our patients admitted to the ICU, although the daily follow-up tool is lung ultrasound. We use chest X-ray only for some cases, mainly when the patient wanted to see the tip of the chest tube. 90% of all patients were pronated, and approximately 98% of those who went to mechanical ventilation. We use this extreme position and rotation for the most difficult cases with very good results. Of course, we did a high fidelity simulation with our colleagues to improve all the pronation technique until we did it without eventualities, which could be performed only by women or up to 2 people only. Yeah. Ventilation strategies without sedation have always been an important point in our unit. In accordance with international recommendations, we performed tracheostomy in our patients who were about 2 weeks on mechanical ventilation, either by classical technique, open sky, or minimally invasive tracheostomy. In January 2021, vaccination with Pfizer begins throughout the country for frontline and police personnel. 100% of our staff were vaccinated in 2 days. Only 2 of our doctors in the ICU developed COVID and 7 nurses. No one of them died. At all times, even when the work was harder, we made sure that our patients received the best possible care, making the stay in the hospital easier. In short, we humanize healthcare at all times. At this time, and according to official data, we have approximately 33,000 deaths from COVID. We know that there really are more. Mortality rate in our ICU is less than 20%. Ecuador is currently one of the countries with the greatest progress in vaccination in the world, and we have managed to vaccinate around 57% of the population. We have already started vaccination children older than 5 years old. We can feel the impact of vaccination. We have few cases and COVID. We hope not to have a third wave. Thank you and shukriya.
Thank you, sir, for such an informative session. Now we will move on to our next speaker. I'd like to call upon Dr. Jhuma Shankar to introduce our next speaker, who is Dr. Supradeep Ghosh, who will be talking on the topic, the antibiotic protocol in COVID ICU, my recommendations. Over to you, ma'am.
So we warmly welcome Dr. Supradeep Ghosh, founder chairman of Fluid Academy of India and director and head department of critical care medicine from Fortis Escorts Hospital, to deliver this very important topic on antibiotic protocol in COVID ICU. Over to you, sir.
Good afternoon, dear friends. At the outset, I would like to contribute maximally for a long term is the overzealous prescription of antibiotics to these patients. Hopefully this pandemic is over, but doesn't mean that we'll not see COVID-19 patients. I believe the COVID-19 will be now restricted as a endemic infection, and we'll be seeing COVID-19 patients on and off in our ICU, just like what we see H1N1 pneumonia. But for all these respiratory infections and severe acute respiratory infections or any other infections, I believe the principles of antibiotic prescription remains same. And we all know the prescription of antibiotics has got pros and cons. So we need to weigh the balance between these pros and cons. So what are the pros? We know if we can hit the bacteria early, we can treat these specific infections. But the cons are, when we prescribe empirically any antibiotic, there is a possibility that this patient may not have any infection at all. Or maybe this patient is suffering from some resistant infection. That means the bacteria is resistant to the antibiotics we are prescribing. In both these cases, we'll be treating the patients with unnecessary antibiotics, resulting in a selection of resistant pathogens. There is a risk of superinfections, including fungal infection and pseudomembranous colitis, and that is proportional with the duration of antibiotic prescription. We know that antibiotic prescriptions are not without adverse consequences. Patients may develop renal failure, hepatic failure, seizure, many other consequences. And we must not forget, in today's scenario, the overall cost of treatment. So let me start with a case. A 53-year-old male, a known case of bronchial asthma, who was on a regular inhaled steroid plus long-acting beta agonist therapy, presented to us with 7 days history of fever, sore throat, and increasing breathlessness. He was initially treated with in home isolation with nebulized bronchodilator, some prednisolone for 30 milligram per day, and on and off paracetamol. He was febrile, hemodynamically stable, but he had tachycardia and he was hypoxic. He had a PaO2 of 52 millimeter of mercury and SpO2 of 86% on room air. His lactates were normal. This was the X-ray findings, and HRCT chest also revealed the bilateral asymmetrical ground glass opacities, particularly restricted to the subsegmental distribution in the periphery and mostly in the lower zones. His COVID-19 RT-PCR was positive. The question is, shall we start the antibiotics at this juncture? It's not easy to answer. So tendency is to start antibiotics. But as we have discussed, there are cons of antibiotic prescription. So the decision to start antibiotics should be based on 3 things. If it is a therapeutic emergencies like septic shock, or the patient is previously immunocompromised, the clinical radiological picture or the pattern, and biomarker guidance. Today, I'll be emphasizing more on the biomarker guidance, especially procalcitonin guidance. So we all know in patients with septic shock, early initiation of antibiotic is beneficial, as we have seen by this landmark study by Anand Kumar and his team from US and Canada, where they showed very clearly that if the antibiotic is prescribed within 1 hour of septic shock onset, the mortality remains only 18% compared to overall mortality of 58%. And surprisingly, they also found that with every 1 hour of delay subsequently, the mortality increases by 7.5%. This same finding, except that 7.5% business, was replicated by multiple studies, meaning thereby in patients with septic shock, we must not delay antibiotic prescription. But this Anand Kumar finding of every 1 hour delay increase in mortality by 7.5% has never been substantiated by in subsequent study. So we need to start antibiotic if our patients with suspected or confirmed COVID-19 pneumonia is in septic shock. And I'll extend it to patients who has got immunocompromised status. Now, coming to the clinical radiological pictures. If our patient of COVID-19 pneumonia, or be it any other pneumonia, presents with increased sputum production, thick, purulent, it's a yellowish color and copious in amount, then there is a chance or higher propensity that our patient is also having either a bacterial pneumonia or a coexisting bacterial pneumonia. If we have background purulent sputum producing infections like bronchiectasis or cystic fibrosis, there also we have a higher chance that this patient has got a coexistent bacterial pneumonia or a bacterial pneumonia itself. Similarly, if in the radiology, if we see lobar or focal consolidation, it's likely to be more bacterial. In the lab results, if we see high CRP or neutrophil, then there is a tendency, but should not consider only one point. If all the things or a large majority of the things are present, clinical presentation, radiological presentation, rise in the TLC or rise in CRP, consider that it is probably a bacterial pneumonia. Then give the patient antibiotics. But if it is not so, then what do we do? If there is no typical clinical radiological picture, if the patient is on septic shock. So if you see the recently, not very recently, in 2018 publication from the US, the PRO-ACT investigators have clearly documented that if we follow a strategy in this unsure, in those patients where we are unsure about antibiotic prescription, if we do not prescribe antibiotic, if the procalcitonin value is less than 0.25 nanogram per ml, initial procalcitonin value, then we do not see any increase in death or intubation or lung abscess or readmission or any organ failure. Meaning thereby, we can actually limit our prescription of antibiotic in patients who has got less than 0.25 nanogram per ml of procalcitonin. In fact, this is from US and this is relatively new study, 2018. Similar study was published a few years ago in 2004 from Switzerland, a single center study, where they could find by following this strategy in those patients where we are not sure about antibiotic prescription, following this strategy of not prescribing antibiotic if the PCT is less than 0.25, decreases the antibiotic exposure. And in fact, the relative risk of antibiotic exposure decreased by more than 50% in those patients who are in the procalcitonin guided group. So meaning thereby, overall, in general, in patients where we are not sure in the presence of a viral pneumonia, suspected or confirmed viral pneumonia, whether our patient has got bacterial infection or whether our patient has got additional bacterial infection, you can safely follow a strategy of not prescribing antibiotic if the PCT is less than 0.25 nanogram per ml. And do we have the similar data in patients with COVID-19 pneumonia? So in COVID-19 pneumonia, we don't have large randomized trial data. We have data from retrospective studies. So this was one of the retrospective studies from 2 large US hospitals where they could find that 2,000 out of 2,443 patients presenting to the emergency department with SARS CoV-2 RT-PCR positivity, out of these 2,500 patients, around 150 odd patients, 148 patients had confirmed community acquired infection. So not very high. Okay. So, and they also found the negative predictive value of procalcitonin less than 0.25 nanogram per ml in ruling out community acquired infection at the time of presentation to the emergency department is 95%. That's very, very reassuring. Wow. And if we follow this strategy, we can also reduce the defined daily dose of antibiotics, especially high-end antibiotics like meropenem. This was shown in this British study, UK study, again a retrospective analysis of 368 COVID-19 pneumonia patients, where they believe that the patients who had a PCT of less than 0.25, they did not have any bacterial infection, and more than 0.25, they have a bacterial infection. And if with this dichotomous value, the patients who had a PCT value of less than 0.25, they had lower antibiotic treatment compared to those who had a higher PCT value of more than 0.25 nanogram per ml. Also, by following this strategy, as you can see from this bar diagram, there was a clear reduction of defined daily dose of antibiotics in all age groups. So, ladies and gentlemen, maybe I strongly believe we should be able to reduce our overall antibiotic prescription safely by not prescribing antibiotic in those patients of viral pneumonia suspected or confirmed who has a procalcitonin value of less than 0.25 nanogram per ml. Now coming to another case, a 64-year-old male was admitted to the COVID ICU of our hospital with pneumonia. He was intubated after an unsuccessful NIV trial. We can talk about this in some other presentation. How long shall we prolong the NIV treatment? In day 3, he was treated with methylprednisolone and empirical some antibiotics, and of course this wonder drug called remdesivir and this wonderful drug called tocilizumab. So all these things were given, and he was finally shifted to non-COVID ICU on day 13 on ventilator. 2 days later, in the non-COVID ICU, he was found to be febrile. He had thick purulent tracheal secretion. On ventilator, 60% FiO2 and PEEP of 8 centimeter of water. He was hypoxic. We performed a BAL, and BAL grew Cyanobacter baumannii, and which was carbapenemase positive. We got a carba-R detection, and we found that this was NDM, New Delhi metallobetalactamase. So he was treated with polymyxin B 5 lakh unit IV 8 hourly, along with nebulized colistin 5 million unit every 8 hourly through vibrating mesh nebulizer, following the standard protocol in our ICU. On day 3 of antibiotic therapy, he was clinically better. Now, question is, when shall we stop antibiotics? So we all know this old story by John Chester et al., where they found that in ventilator-associated pneumonia, a short course of chemotherapy for 8 days is as good as a longer course of 14 days, except in patients who had Pseudomonas aeruginosa, where they found that a short course chemotherapy had a higher risk of relapse. And if we can extrapolate the data for Acinetobacter, we expect that if we follow a short course of therapy, the overall mortality may remain same, but there is a higher chance of relapse. But these are all presumptions. We can actually use more personalized therapy. So this landmark ProData trial from 6 French ICUs, they found that we can actually stop the antibiotic guided by procalcitonin value. So if the procalcitonin value decreases by more than or equal to 80% from the peak concentration. So by following this strategy, they did not find any increase in 28-day mortality in the PCT group. That's reassuring. They also found the PCT group had higher antibiotic-free days and the lower days on antibiotics. There was no increase in relapse. There was no increase in relapse of bacterial infection in the procalcitonin group, and very happily that there was a trend towards lower superinfection in the PCT group as expected. Now, is it only limited to this particular study? No. We also found in the more recent Dutch study called the SEPS trial, a similar result could be replicated. They have found that following the same strategy, the procalcitonin guided prescription group had a lower 28 days defined daily dose as expected. And apart from that, there was a lower antibiotic duration and antibiotic free days, higher antibiotic free days, along with lower 28-day mortality in PCT guided group. And to reassure us, there was no difference in reinfection or relapse rate or repeat antibiotic course in the PCT guided group. So ladies and gentlemen, if at all we need to start antibiotic treatment for any of our patients in ICU, for hospital-acquired infection, then there is a good rationale to believe that if your if your procalcitonin, serial procalcitonin value should show a drop of procalcitonin level more than 80%, we can safely stop our antibiotic without causing much relapse or without causing any adverse consequences. So, ladies and gentlemen, just to conclude, I believe in this short principle to antibiotic prescription, be it for COVID-19 pneumonia or for anyone in the intensive care unit. So we need to start antibiotics immediately in patients with any therapeutic emergencies like septic shock or patients who are immunocompromised very early. If we have a clinical radiological evidence of coexisting bacterial pneumonia, as we have discussed in the presentation, we again need to start antibiotics early, but should not forget to make our maximum attempt to send some cultures, specifically the respiratory sample and blood for cultures. And if the cost permits, send PCR-based assays before antibiotic prescription. But in patients who has mild to moderate COVID-19 pneumonia and a PCT value of less than 0.25 nanogram per ml, in all probability, we can watch these patients carefully. If we still have a doubt, maybe we can repeat the PCT after 12 hours. And if there is not much of change, or if the PCT value does not go beyond 0.5 nanogram per ml, we can still hold on to our nerves and do not prescribe antibiotics to our patients. Of course, we need to optimize the PK/PD parameters for all antibiotic prescription. And we need to reevaluate our patients daily for any new source of infection. So COVID-19 pneumonia does not mean that patient will have only pneumonia. Patient can have CLEP-C, central line associated bloodstream infection, patient can have CORT, patient can have acalculous cholecystitis, patient can have skin and soft tissue infection related to the long stay in the ICU of pressure sore, and can have non-infectious causes like DVT as the cause of fever. We need to, once the antibiogram is available, we need to consider the possibility of escalation or de-escalation of antibiotic, preferably a de-escalation. And ladies and gentlemen, we must discontinue our antibiotic treatment in a timely manner. And we believe that in patients who has got COVID-19 pneumonia and you started the antibiotic very early, we can stop the antibiotic safely after 5 days as per the international guideline. And if the patient is prescribed antibiotic in the subsequent days in the hospital, a PCT guidance to individualize therapy is probably desirable. So if the PCT value, in my practice, what I send the PCT at day 0, at the day of prescription. I send the PCT at day 3, and I repeat the PCT again at day 7. If the PCT values drop by more than 80% of the peak value of the initial value, then we can stop our antibiotic prescription. Thank you very much for your kind attention, and thank you for your patient hearing. And I'll be happy to answer any question if you have.
Thank you, Dr. Supradeep. And now we'll open the panel. We'll open the panel for question and answers. And I don't see any questions in the chat box. So if there are any questions, we can. The panelists will be. The speakers will be able to take them up.
Since there are no questions among the panelists, so I would like here I would like to take time to thank all our respected chairpersons and speakers who have provided us with so much time of their valuable time and such informative and educative sessions. So I would like to thank you all. And with this, we will now conclude with this session of international sessions. Thank you to all.
Thank you.
Aditya, Dr. Aditya, please start the next session, please.
Good evening to all the delegates and the faculty members. Now we proceed to our next session, that is our rapid fire session. The chairpersons for the same are Dr. Suresh Kumar Bhargav, Senior Consultant Critical Care, Shelby Multispecialty Hospital, Jaipur. Dr. Tejas Parmata, Senior Consultant Intensivist, Director Gokul Hospital, Rajkot, Gujarat. Dr. Vatsal Kothari, Director Critical Care Medicine and Consulting Physician. Dr. Chetri Shah, Additional Medical Superintendent, Dr. M.K. Shah Medical College and Research Center, Dr. Akshay Chalani, Consultant Physician and Intensivist, Shehjot Specialty Clinic, Navi Mumbai. Now I would like Dr. Tejas Kalmata to introduce our speakers.
Next slide.
Hello.
Yes, sir.
Yeah, I welcome Dr. Raman Chhatral. He is a consultant intensivist at KD Hospital, Amritsar, Punjab. And special mention is ex-president of ISCC Amritsar and founder of each one community of CPR initiative. I welcome Dr. Raman. Please, Dr. Raman, start your role.
Hi, it's Dr. Raman Chatur from Amritsar. Let's discuss the COVID management protocols in small private hospital in Northern India. I'd like to thank Dr. Runta and team for inviting us to be part of this show. COVID has been declared a public health emergency, as we all know, and patients who were hospitalized had respiratory insufficiency, multiple system involvement, and required oxygen administration. And most of them progressed to ARDS, often associated with multiple organ failure and different types of shocks, and eventually had some psychological outcomes which needed different levels of support. Hospitalized patients required multidisciplinary approach as infection can lead to a plethora of clinical scenarios. EDs had played a pivotal role in providing adequate response to healthcare demand during COVID-19, and there have been structural and logistic changes in the ED due to COVID. We have been segregating the patients into two, the clean as well as the infectious ones. As recommended by the WHO, we had been taking nasopharyngeal swabs, going over the different profile of tests, as you all have been doing. And the CD chest did come at the last, depending on the severity of the patient. With the investigations, together with the history as well as the physical examination, the physicians stratified the patients into 4 categories. The green one were the normal ones who were maintaining the saturations with no oxygen. The red one a little more severe, requiring oxygen. The orange ones required higher support with the high flow nasal devices, CPAP and NIV. The red ones were the patients who were in the ICU, and they had to be subjected to elective intubation and full ventilator support. What we did was oxygen saturation and respiration was monitored. Cloning of the patient was done with promising results. High flow nasal oxygen has been used as a bridge between CPAP trial. So we have been using the non-vented mask with a PEEP of 10 to 15. And then we have also used the pressure support of 10 with FiO2 from 60 to 100. Low dose opioids were used as to improve the patient's comfort as per the hospital protocols. Early intubation and necessary in some cases we were not responding to the CPAP or NIV, and with the worsening hypoxemia. And the patients with the refractory hypoxemia were given cloning sessions on mechanical ventilator with the wonderful results. The pharmacological therapy, as we all know, the remdesivir was the drug of choice. Nexa, as per the recovery trial, has been shown to have a good reduction in the mortality data, and we have been using other drugs like tocilizumab, azithromycin, but the results were not very conclusive. Prevention of complications, we used to take care of VAP while regular suctioning with the closed cannulas. New circuits were used, semi-recumbent position, global gravity heparin as per the thromboembolic protocols. Pressure ulcers as were prevented by changing the position every too early. Stress ulcers were with the use of PPI. Isolated weakness was taken care of by mobilizing the patients early, and opportunity infections were handled by the use of steroids and immunosuppressive agents. Mild symptoms of the patients who were for the home care, so we won't discuss these. The moderates landed with us in the hospital with this falling saturations, and first of all, we used a non-breathing face mask, gradually increasing oxygen support as it deteriorated. Methylprednisolone was added to counter the anti-inflammatory, the immunomodulatory therapy. The anticoagulation was used judiciously, and the monitoring of all the vitals was done with the CL test done on the daily basis. Then when the patients were a little severe, they required the level 3 support. We often used NAV devices at our disposal. High flow nasal oxygen was a wonderful thing that was not used much initially, but in the second wave, it was the device of choice. We can say we had been using all the conventional therapies in the severe patients, and the routine CRP, D-dimers, and IL-6 were all done as the hospital protocols. So when the patients got cared of, we used to discharge them up when the tests were negative, and they had a significant clinical recovery. And often these patients need oxygen concentrators when we discharge them from home. And there was a serious advice for them to be in loop with the hospital authorities, often taking care of their health, taking adequate amounts of fluids, doing breathing exercises, using the COVID appropriate behavior at home also. And when the health permitted, they used to go in for the household work and maybe later on joining the professional jobs. So they were advised for the doing all sort of breathing exercises. If they wanted to do yoga, they were even encouraged to do that. Anything which helped them was welcome. In the follow-up, there was a telephonic loop with the patients, and in case there was a deterioration, they were asked to come back to the hospital. And in case they had any complaint, it was dealt with the 24/7 helpline. Thank you very much.
Thank you, Dr. Raman. Now I would like Dr. Tejas Karmata to introduce our next speaker, Dr. Pradyum.
Yeah, Dr. Pradyuman Sharma is a consultant in allergy, asthma, and immunology, managing director at Gopinath Hospital Private Limited, Jaipur, Rajasthan. I welcome Dr. Pradyuman Sharma and request to start your talk.
Next question.
Yeah.
What are the similarities and where we differ? So coming to the picture, let me have it to the full screen is allergy. It's a reaction by your immune system to the something that doesn't bother to the most of the other people. And it's an immediate immune reaction in the body to the allergens and mostly mediated by IgE antibodies. May occur in certain individuals with genetic susceptibility under certain environmental influences. The meaning is that everyone doesn't react, and environment has a big role to play. He or she is underlying allergic, but environment has a big role to play for the triggers. Coming to the history is allergy is known to the mankind since the early days. While coming to the COVID-19, which just December 2019, as WHO said, coronavirus disease, or what we had as SARS-1 in 2002, followed by the MERS. So it's a very recent disease, and significance, the global presence almost the 9 digits, what we call is 24 million people, one or other time has suffered from coronavirus infection. While in allergies, it's a seasonal variation and can range from the 10 to 35 to 40% incidence of allergies. Now you've seen is a beautiful picture. What the cause of allergies are, it could be pollens, which is a seasonal presence, latex, perennial presence, food allergy recent last 20 years has come up with a very significance. And the 8 foods are most allergic in nature, like the milk, fish, nuts, tree nuts, egg. They are significant hazard. Household dust has a permanent feature. Dust mite significantly affecting most of the countries, the danders, insect bite, and the fungus. And now on this side, what you see is a solar corona picture presence of a single strand messenger RNA. This is RNA virus, which is just 80 nanometer in size. And what are you seeing moving? These are the spikes. And the spikes, they are very dangerous. And this time, what we have spike in SARS-2 or the COVID has a 70 or 80% more stronger than what it was in SARS-1. And each time when mutation takes place, these spike proteins become stronger and stronger. Coming to pathophysiology, in a COVID, the SARS-CoV-2 virus, this is an RNA virus coming to the lungs through the nasopharynx, and they are affecting to the cells. The macrophages are being engulfed, and they enter through the ACE2 receptors. And these spikes, they attach to ACE2 receptors, and they keep on multiplying inside the cell macrophage and just release, resulting in the clinical picture. There's a bombard. While in this picture, allergy, these are the APC cells. APC cells got attached to the pollens and they're sensitized now. And these are the mast cells. These are sensitized antigen presenting cells. And once they come in contact with the allergens, they releases different kinds of interleukins, molecules, chemicals, serotonin, histamine, resulting in various clinical presentation of the allergies. And what we see, the symptoms is a fever, which is more than almost 100.4, as a recent cough, which is a dry, hectic cough, and there's a shortness of breath is very significant. A man never had a shortness of breath, but this time, this fever is associated with a shortness of breath and having many times severe chills. Now, the most significant is new muscle pain, and there's a loss of taste and smell. Patient just says, "Look, doc, I just don't find taste. I'm just lost taste." And there's associated with nausea, vomiting. Some people, 10 to 15% may have a diarrhea, the headache, and there's a URI is very, very common symptom like in allergies. And by allergic patient, in allergic rhinitis, there has a running nose, cough, associated post-nasal itch, and block, sneezing. These are pictures in asthma. There's a coughs, and atopic dermatitis keeps on itching. There are various kinds of allergy symptoms, but the significant part in allergy symptoms, they're recurring in nature. They are recurring in nature. They had a definite history past, they had it. And again, with the re-exposure to same kind of allergens, like dusting in Diwali or doing some brooming work or exposure to the smoke, are recurring, reproducing same classical clinical picture, which is not with the COVID, because the COVID, the subsequent second attack is almost patient carries immunity and he or she doesn't normally get a second COVID attack. And now how the allergy progresses. The allergy progresses from the allergic disease starts with eczema, progresses to food allergies and hay fever and asthma. That's called what we call as allergy march. And why the eczema is? Because at the early time, at the time of the delivery, food allergens penetrate through the skin and leads abnormal in the allergic response. So right at the birth, what you find is that initially is a skin allergy. That's what we call as atopic dermatitis, followed by food allergies, rhinitis, and the bronchial asthma. This is a clinical presentation of a patient of COVID. He or she may not be at all symptomatic, what we call normally at 60 to 70% patients. They just have a little cough, fever, body ache, headache, loss of taste or smell, but then no shortness of the breath. Now this time, when you do RT-PCR test, there's a viral replication is high, and you get a gold standard RT-PCR test is positive. And that's time, this is the window for antiviral therapy because the viral is multiplying. So antiviral therapy is very significantly important. And now some of the 20% patients enters into the moderate to severe illness where they start desaturating, But respiratory rate is more than 30, lung infiltrates are more than almost 50%. What we call as a count, HRCT count is plus 15. That's he is going to have a big trouble. And so these such are the patients are going into long COVID or COVID haulers or post-COVID syndrome. And now the patient is critically sick, and 3% to 10% patients they die. Now, in a pregnancy, the allergy does not make a much of the difference. In asthma, you have to continue inhalers. 30% may deteriorate, 30% improve, and 30% do not make any difference. That's a 30% formula. But in the COVID, half of the hospitalized pregnant women, COVID had the symptoms, and they really have high ICU admission, mechanical ventilation, and death reported to the child and to the mother is very important and very significant, which is not been observed in allergies. And you can prevent by COVID adequate behavior. So now coming to the death mortality. Allergies are almost nil mortality unless the asthma is not managed properly. But in COVID, the allergies, the death may result from 1 to 12%, depending on different countries, depending on the strain. That's if now you have a Delta plus strain, which is 70% more infective than Alpha strain. So the strain has a high mortality, and the patient who does not been vaccinated, they have high chances of resulting in death. And now we have a post-COVID syndrome. A person who has been discharged suffering from the COVID, resulting continue to have some problems. Most important psychological problems, depression, anxiety, post-trauma, neurological problems, cognitive impairment, sleep disorders are very important, and dizziness, forgetfulness. Patient will just fail to remember very small common numbers, his phone numbers, mobile numbers at the time of what he had as his meal. There's a myocarditis is very significantly important, and patient is advised not to do any exercise. This is a very significant respiratory symptoms, which are 8 to 12 weeks, continue to have it, and other main times body ache, muscle, lethargy, weaknesses, they are the prey. So the post-COVID syndrome is a significantly very important, especially in patients who have a high incidence of long stay in ICU, who are while they were discharged, they were desaturating. 6-minute walk test was not good. It was a positive 6-minute walk test, and there was history of associated underlying brittle diabetes, because COVID does bind to the beta cells and resulting in a new fresh diabetic patients, or what the existing patient who are diabetic, they have a high bad blood sugar control. They just do not get a control, and they put on insulin. So that's the basically picture. Post-COVID results in many of the complications. Now what we're talking is a heart and lungs. Heart is a myocarditis because directly resulting to the lung injury to the heart, myocardium. Besides, there's a immune dysregulation. Again, these chemicals they injure to the heart and to the lungs also, and post-lung COVID fibrosis, though we call it a reversible fibrosis, but some of the patients, they continue to have progressed fibrosis, and this fibrosis continue to have resulting in more problems. Now, so what I'm talking to is this is basically a picture where you find honeycombing, where you find traction bronchiectasis, and this is GGOs, which are initially as GGOs, but later on become traction bronchitis, and there are cavity formations. You can find traction bronchitis. This is the base, and there is a honeycombing appearance is also there. This is a very bad time. Few of the patients continue to progress, but 90% patients reverses from COVID fibrosis. Now, how do you diagnose allergies? Allergies you diagnose by skin prick test or by doing ELISA test. That's a specific IG testing. And now this is a vaccine for allergy. Initially you have orders, and this allergen immunotherapy is known to and it's been approved by WHO also, and most of the countries also with the nice guidelines also. Here, basically the management of asthma here written a patient who has a controlled FE1 is 70 or 70%, more than 70%, with triggers are controlled. One should advise allergen immunotherapy as has been designed by the GINA guidelines. And there's a history of allergen immunotherapy. The learned are known more than 100 years ago. He diagnosed and it was presented in Lancet, Journal Lancet, and it was carried out by Freeman also. What I'm talking is in 111, it was progressing, and thus allergen immunotherapy has come up in a big way. In the subcutaneous immunotherapy, sublingual immunotherapy, subcutaneous immunotherapy is receiving the shots, while sublingual immunotherapy taking oral vaccines. And now this is a antibody therapy. What I told you is in case when you have a mild symptoms and but you've had a diabetic, you had angioplasty or some renal disorder, don't go for a combination cocktail antibody therapy is a very successful management of the COVID-19. And if case otherwise the vaccine has a big say, the patient who had a recurrent two dose of vaccine, their fairly chances of entering to a serious COVID is almost 94% less. They are more immune for the seriousness disease. While what I'm talking is the seasonal allergic rhinitis, the SCIT, subcutaneous immunotherapy, where you're giving injection the deltoid over a period of time, that patient becomes immune, which could be seasonal, could be perennial, and sublingual immunotherapy, again, taking the vaccine under the tongue. Now, in the COVID-19, that's basically precaution. COVID-19 is there, and these are triggers are there. These are allergen triggers. Be careful, beware of this. And new normal life, wear a face mask, social distancing, and wash, be hygiene. That's my message. COVID can kill you. Allergy may not kill you, but allergy keeps on lingering. So be careful. Take COVID behavior, adequate behavior, new normal, and at the same time, they definitely take a vaccine. Thank you. Thank you very much.
Thank you, Dr. Pradyaman Sharma. Now I would request Dr. Tejas to introduce our next speaker, Dr. Chaitri Shah.
Dr. Kothari, may I request you to please introduce?
Hello, can you hear me?
Yes, sir. Yes, sir.
Yeah, the topic is preventing polypharmacy in COVID. Our speaker is Dr. Chaitri Tejas Shah, who is an additional medical superintendent at the M.K. Shah Medical College in Ahmedabad. And she is a intensivist, also anesthetist, and also an instructor for BLS, ACLS, and has published articles, case reports, and is quite a well-known intensivist in Ahmedabad. So Dr. Chaitri, over to you. Her topic is preventing polypharmacy in COVID.
Namaste. My topic is preventing polypharmacy in COVID-19. So what polypharmacy means? Polypharmacy is generally defined as use of 5 or more prescribed or over-the-counter drug therapies, while the terms excessive polypharmacy and hyperpolypharmacy have been used for people taking 10 or more prescription or over-the-drug counter therapies. Polypharmacy could be appropriate or problematic. Polypharmacy recognizes that the patient might require multiple drug therapies to manage their complex medical conditions, while problematic polypharmacy refers to use of the drug of multiple drug therapies in a way that is not appropriate. Majority of the drugs are vitamin supplements or trace elements or any such herbal remedies along with the drugs which are used or which are taken by the patient to treat their comorbid conditions. Polypharmacy is known phenomenon in COVID because majority of the time those patients who are having comorbid conditions are at risk of development of COVID or acquired COVID illness. So they are already on their regular medicines. Top of that, we are treating COVID, and this patient, when they develops complication, we need to treat those complications and we need to add certain drugs. Majority of the time, antifungals, antibiotics, vasopressor, fibrinolytics, and anticoagulation. So combination, while the patient is already on medicines, we are treating COVID, and now patient has acquired another complications. So to treat all these three at a simultaneously, we need to add certain drugs, which leads to polypharmacy in COVID. So how we can prevent this? So drug steps. This has been published in Lancet and the reference has been mentioned in end of the slide. Discuss the goals of care, what matters the most, review the medications, use tools and frameworks, geriatric medicine approach, and stop medications. Discuss the goal. Define mild, moderate, or severe disease, which stage of the patient is in COVID. If the patient is in mild stage, you can monitor clinical sign and you emphasize use of non-pharmacological approach if possible. And if required, only symptomatic treatment to be added. As the disease progresses, you add the medications, or from you use the medication from prevention from mild to moderate or moderate to severe disease. No excessive drug to be added at any given point of time. When you are adding this any of the drug, you review the medication, what the patient is already taking and what you are adding. Some of the time patient has already taken the azithromycin and you are adding clarithromycin for ICU acquired infection, or patient has already taken doxycycline and you are adding tigecycline. Even though culture report are suggesting the same sensitivity, but you have to keep background or review medicine on the mind to continue or to add another antibiotic or any such therapy. How we can come to know? So use tools and frameworks for the same. Tools to identify inappropriate prescription. And these tools and frameworks also guide you to limit drug-drug interaction or adverse drug reaction related to polypharmacy. So next step is de-prescribing process. Any of the drug when you want, ideally at any appropriate stage, you have to discontinue steroids or you have to de-escalate antibiotics according to culture report. So such steps will limit the polypharmacy and limit the drug-drug interaction. So this is very important de-prescribing process. But always when you are de-prescribing, you have to keep risk versus benefit ratio in back of your mind. So take home message, use appropriate polypharmacy. Polypharmacy increases the chance of drug-drug interaction and adverse drug reaction. Review prescription daily. Stop or discontinue drugs according to the clinical condition and upgrade the knowledge of management of the COVID. Thank you very much.
Thank you, Dr. Chaitri. That was a good comprehensive approach to the same. I think there have been some controversies about the medications like ivermectin, azithromycin, etc. So obviously, medications now which are not really recommended either by the the Indian Council or even by the experts abroad. I think we should avoid those medications so that we can reduce the number of drugs that the patients are receiving and also the drug interactions that come therefore. Okay, so I would like to introduce the next speaker is Dr. Arun Sampath, who is the consultant pulmonologist at MIOT International, Chennai, Tamil Nadu. And his topic is sterilization in the COVID ICU. So over to Dr. Arun Sampath.
I would like to thank the conference organizers and the scientific committee for giving this opportunity to deliver a presentation about sterilization in COVID ICU. Myself, Dr. Arun Sampath, Senior Consultant Pulmonologist from Chennai. As we all know, the primary mode of transmission of severe acute respiratory syndrome coronavirus 2 is by close contact and droplet transmission, and it has very high infectivity. Still debate is going on about the other modes of transmission such as airborne by the aerosol and small droplet nuclei and by fomite contacts. The irony is the incidence of healthcare related cross transmission of this virus is as high up to the tune of 40%. Hence, in order to reduce the hospital related transmission to the healthcare workers, there is need for careful ICU designing, optimization of the staff resources, implementation of vigorous infection control practices, environmental disinfection, meticulous sample collection and criteria for staff quarantine. I will discuss about certain of the parameters briefly. If we take in this respiratory virus pandemic, it is very important that to know some of the ICU designs may be harmful to the working staff and therefore may require redesigning to minimize the exposure risk to the healthcare providers. This is a simple model for ICU postulated in the Indian Journal of Critical Care Medicine in 2020, wherein they have postulated that there should be separate entry and exit for the patients and for the staff. There should be a doffing area and donning area separately. Similarly, the utility area should be separately for the patients and for the staff workers. There should be separate waiting area for the suspect patients, and the ICU bed should be adequately spaced. Preferably, there should be a glass window panel as in number 7, and the doctors or the healthcare providers can monitor directly with some of the latest technologies such as Wi-Fi or Bluetooth. In this way, they can reduce the close contacts with each of these patients. Very important to note that there should be proper ventilation and adequate air exchange both in the ICU settings and in the COVID wards also. Coming to the decontamination in ICU, as far as possible, single-use or disposable equipment must be used. The non-disposable equipment can be disinfected with either 70% ethyl alcohol or quaternary ammonium compounds. Usually, sodium hypochlorite at 0.5 to 1% is used. High-touch surfaces such as those with the frequent hand contacts like doorknob, bed rails, light switches, wall area around the toilet and edges of the privacy curtains need to be cleaned and sanitized more frequently. Low-touch surfaces such as floor, ceilings, walls, curtains and blinds require cleaning less frequently, about 2 times a day, and the damp mopping is preferred over dry. Curtains in patients' care areas need to be changed when visibly soiled or after each patient discharge, while blinds must be changed when visibly soiled. The terminal cleaning is complete environmental decontamination of the patient care area after patient's discharge and includes cleaning for removal of any organic or non-organic matter, followed by disinfectant process. The housekeeping staff should wear the full PPE, clean all surfaces of the bed and mattress with the 1% sodium hypochlorite, wash the floor with the wet mop, followed by disinfection with 1% sodium hypochlorite. This is as per the WHO guideline. There should be separate color-coded bins, bags, containers in ICU should be kept for proper segregation of the biomedical waste. The bags, preferably with the 2 bags, should be covered in double layers for collection of waste in ICU to provide adequate strength and to prevent any leaks. If the ICU or the ward settings are also managing separately for the non-COVID patients, then the COVID waste should be labeled for those collection from the ICU from the COVID patients. Maintain separate record of waste generated from the COVID-19 isolation wards. The healthcare workers are highly vulnerable to cross-infection. All of the ICU staff must be follow procedures as per the infection prevention and control completely. There should be an infection control coordinator must monitor the compliance of all policies and procedures of IPC. A buddy system has been promoted wherein a team of 2 or more staff is formed with the shared responsibility of each other's safety and well-being. This system approach is used for various critical measures of IPC like safe donning and doffing of PPE kits, compliance of hand hygiene, and observation and reporting of any breach of PPEs among each others. Very important, the training of the staff on infection control practices reduces the infection rate among healthcare workers significantly. It has been published in previous studies. Adequate staffing not only helps in infection control but also prevents burnout of the staff. In case of infection to healthcare worker, the staff must be assessed systematically, and institutions infection control committee should guide for isolation period as well as return to work based upon the standard recommendations. Last but not the least, the hospital should ensure that all the staff are medically insured and should address their and family needs in case of any disturbances to the family due to the COVID pandemic, or if they are facing any consequences because of the COVID pandemic. With this, I conclude my short presentation and thank you all for your active listening.
Now, hello, thank you, Dr. Arun Sampath. Moving to the next lecture now, the topic is admission criteria to COVID ICU. Both admission and discharge criteria will be discussed, and by Dr. Tejas Karmata, who is Senior Consultant Intensivist, Gokul Hospital, Rajkot. Over to Dr. Tejas.
Good morning, friends. I am very much thankful to organizing team of W4C World Conference on COVID-19 to give me opportunity to speak on admission and discharge criteria for ICU admission of COVID-19 patient. We all know that since last more than 2 years, world is suffering from COVID pandemic, and not a single country over the globe is spared from pandemic. The pathophysiology of COVID-19 infection is very much complex, and it may result in multi-organ failure, ARDS, cardiomyopathy, coronary artery disease, venous and arterial thromboembolic events, and may end up with many complications. We all know that such patient may require ICU admission in severe stages. So which are the indications which are required for ICU admission of such patient? It includes hypoxemia, in which SpO2 should be less than 90, with O2 requirement of at least 6 liters per minute, or PaO2 less than 40 mm of SD, with or without respiratory distress. Respiratory rate should be more than 25 per minute with respiratory distress. Hemodynamically, systolic blood pressure should be less than 90 mm of SD with persistent hypotension and need resuscitation. Patient may need vasopressor to manage the hypotension. Need of high flow nasal cannula, need of mechanical ventilator, either invasive or non-invasive. These are all clinical criteria which are required for patient getting ICU admission. If we look radiologically, then CT severity score should be more than 15 out of 25 with respiratory distress, with multilobal infiltrating X-ray chest. Neurologically, patient should be confused and in delirium with either acute kidney disease or uremia. Sometimes patient may present with leukopenia and thrombocytopenia also. Hypothermia and quick SOFA score should be more than 2. Out of this, at least 2 or 3 clinical or radiological findings must be there for patient getting ICU admission. Now, who are the high-risk COVID-19 patients with moderate illness requiring ICU admission? This includes patient age more than 60 years, patient with cardiovascular diseases, hypertension, coronary artery disease, patient
with diabetes and other immunocompromised tests like malignancy, HIV positive, which may require ICU admission. Patients with chronic lung disease, chronic liver disease, and kidney diseases also require ICU admission in moderate category also. Patients with cerebrovascular accident and obesity may require ICU admission earlier. Which are the extra pulmonary complications of COVID-19 infection requiring ICU admission? This includes acute coronary syndrome, carditis, severe stroke, Guillain-Barré syndrome, encephalitis, mesenteric ischemia, and acute pancreatitis. If we look on the discharge policy or discharge criteria for severely infected COVID-19 patient and admitted in ICU, there must be clinical recovery of all clinical presentations during severe phases, which was the earlier indication for ICU admission. Moreover, for immunocompromised patient, RT-PCR report must be negative from discharge from the hospital. If we look in detail, when patient physiologically and hemodynamically stabilized and no longer ICU monitoring required and no more care needed, we can shift the patient from ICU. In that, heart rate should be stabilized and should be less than 90 per minute. Systolic blood pressure should be 120 per minute. Without vasopressor, respiratory rate must be less than 20 per minute, and oxygen level, oxygen saturation must be 90 or more without very minimal support or without any oxygen support without respiratory distress. Patients should be conscious and oriented clinically. He should tolerate feed well, and there is no longer requirement of organ support in form of either CRRT or SLAD or liver support. With such criteria, we can shift the patient out of the ICU. Thank you. Thank you so much.
Thank you, Dr. Tejas. That was a comprehensive overview of the admission and discharge criteria. Our next speaker is Dr. Neeru Gaur. She's going to be talking on Fast Hugs Revisited, Rapid Fire. Dr. Neeru is a senior consultant in the Department of Anesthesia and Critical Care at Medipulse Hospital, Jodhpur. And she has areas of interest in ethics and communication, pain and palliative care, besides general critical care. So, Dr. Neeru.
My greetings to everyone. This is a very good topic, the Fast Hug Revisited in COVID-19, and it really helped a lot in managing these patients. Fast Hug is a well-known mnemonic, which since 2005 we are using in ICUs and managing the critically ill patients. It is the most effective mental checklist, a well-known, well-structured and systematic method of the rapid bedside clinical assessment for managing these patients to reduce the burden of ICU acquired for every patient and to ensure the completion of the elements of routine care. There were various modifications seen in last few years. The basic component were feeding, analgesia, sedation from prophylaxis, head-up, and the ulcer prophylaxis and glycemic control. And the few modifications were spontaneous breathing trial, supplemental oxygenation, bowel care, and indwelling catheter care, and need assessment and removal at the time, and dyselectrolytemia management, and drug de-escalation and delirium. Fast Hugs made and describe the basic medicine prescription. What are the early medication the patient is taking, or the indication, drug dosing, basic interactions, and the start and stop dates to be mentioned on the prescription. And this specific Fast Hug in bed, please add special concerns about the environment and the psychological support. This is an important aspect while treating the COVID patient in ICUs. Above all, coming to the oral care, nasal care, and eye care, and the ear care as seen by one mnemonic here. The COVID patients are on nasal prongs, sometimes on high frequency nasal cannula, some on face masks, some on non-breathing masks, some mechanical ventilators. So a basic special care of the facial structures and ET2 fixation care, treatment of the throat pain, looking for the oral thrush and timely treatment, and special concerns in prone position like lip swelling and discoloration. Similarly, as the nasal care also, assessment daily for excessive dryness, irritation, nasal bleeding, nasal bridge trauma, and excoriation related to NIV. Eye care and ear care to be taken care, especially in a prone ventilated patient to avoid excessive pressure injury, and the lubricants to be used. In the F component of the FAST-X, focused nutritional assessment, feeding, fluid assessment, and the fluid balance, mainly targeted for the negative fluid balance, and the face mask. An important component is the adequately fitting, properly sized face mask is important. And analgesia, antibiotics, awake proning of the lateral position, sensorium, and assessment of the sedation need for sedation, and the treatment of the neurological and neuropsychiatric issues, early identification of delirium, depression, anxiety, and insomnia to be treated. And above all, prophylaxis, the drug doses and days of the LMWH to be discussed and given in moderate to severely COVID illness patient. Again, in the H component, high flow mask and HFNC to be used, and in G component, the need for insulin and the glycemic control to be there, as the risk of hyperglycemia is more in these patients. That's why the baseline HbA1c to be noted in almost every patient. And the weaning to be done slowly and gradually, while spontaneous breathing trial and steroids to be discussed on daily rounds. And bowel movement, best for prevention, indwelling catheter care and the removal, and family discussion, and the palliative care or the de-escalation to be done whenever needed. Basic COVID-19 care therapy and the comorbid illness optimization is that most important, with oxygen therapy charts and organ impairment assessment plans, and off-label COVID-19 therapies whenever needed, like antivirals to be given early in the course of illness, and the consideration of TOSI, TOLI, elastin, fluorescent plasma based on the clinical condition and inflammatory markers trend and institutional protocols. And among the need for the ventilations in severe ARDS and the decreasing PF ratio of clinical worsening patients, clinically worsening patient needs elective planned ventilation with all equipment and the PPE. Prone ventilation to improve oxygenation is also encouraged for 5 to 6 cycles. Inflammatory markers are serially monitored, and above all, the discussion and documentation are at most important part. The advantages of the daily goal settings, the decreased VAP rates in the ICU stay, to ensure the complete workup of critically sick patient on daily rounds and summarize the patient's status, to improve the quality of the care. The chances of error are also minimized and encourages the teamwork with improved interprofessional communication and education to ICU staff, and above all, maintain the good patient-doctor related communications. Coming to the practice points, there is no emergency in pandemic, and ensure appropriate safety for the self and surroundings with the help of proper body approach in the donning and doffing, and remember our universal ABCDEF approach, including airway, breathing, circulation, definite proning, and ECMO and fast drugs in these patients. The important in all the components are the assessment, monitoring, and maintenance is most important. The fast track evolved and revisited in COVID. Surely it is, with complete assessment of moderate to severe COVID illness, treatment modifications plans, goal settings, and its execution. Thanks a lot for W4C conference, the organizing committee, and the patients listening. Thanks a lot.
Excellent talk, Dr. Nero. Very comprehensive. Now, we are on to the next topic, that is personal and family protection during the COVID pandemic, a very important topic. The speaker is Dr. Ajit Kumar, who is a consultant pulmonologist at MIOT International, Chennai, Tamil Nadu, India. His field of expertise, he's been an expert in general critical care, use of extracorporeal devices, and over to Dr. Ajit Kumar.
Hi, good day. The topic is personal and family protection during COVID pandemic. So before we go to the details how we protect ourselves, I just want to go through the roots of spread of COVID. We know that droplet spread is the most common thing. Droplets are particles which are more than 5 micrometer in size. Usually they won't travel from a longer distance than 2 meters or 6 feet. And this is the predominant mode of transmission as of now. And obviously there has been some kind of some evidence where there is some kind of a airborne transmission also happening during COVID pandemic, because some of the studies, imaging studies, have shown that the viral particle can travel via aerosols or gas clouds in a horizontal trajectory for more than 2 meters. Though the predominant spread, even at this point of time, is droplet spread. And because of the possibility for airborne spread, we all know that it's been advised that all the healthcare workers who is dealing with any kind of a aerosol producing any procedures and interventions, we need to take the airborne precautions. And physical contact is said to be very rare, though it is theoretically possible. Some of the recent studies have shown that the possibility is 1 in 10,000. The virus has been isolated from the stools, but the fecal-oral route is said to be uncommon route of transmission. Vertical transmission from the mother to the fetus is possible, but is rare. The waiting studies have shown any occurrence or incidence of around 1 to 3%. And obviously, the virus has been isolated from the blood, semen, even by in the ocular secretions. But transmission via them is, even at this point, is believed to be very rare. And when it comes to the protection, again, we should know who are to be really cautious about their health. I mean, the COVID-19, the age group more than 60 years, obesity, diabetes, pre-existing lung disease, CKDs, chronic liver disease, heart failure. These patients, whenever they get the disease, the symptoms and signs could be, signs could be very severe. The disease could be very severe. Immunocompromised and immunosuppressed are supposed to be very high risk for COVID as well. And there has been some kind of increased, occurrence of COVID in Down syndrome patients, severe COVID. And most important thing is at this point of time, we have to highlight that the unvaccinated people are definitely at risk than obviously the vaccinated persons. And coming to the protection for everybody in general, whether you are healthcare workers or whether you are non-healthcare workers, the most important thing is that you need to wear mask in almost almost all the situations as much as possible. For the general public, I will say that it is better to wear the 3-layer surgical mask, which I have just shown here. And obviously it is better to avoid men. It is just this mnemonic like that. See, the mouth, eyes, and nose are the portal of entry of the virus. It's better that whenever no one touches the mouth, eyes, and nose at any time as much as possible, so that you cannot transmit the virus from one source to another source. And I will say that for the mnemonics again, always follow women. Women means W4, wash your hands with soap under running water. If you have an alcohol rub, it is well and good. Obey directives. Aim for masking appropriately. Move away from crowded places. Encourage self-isolation if exposed to affected person unprotected. Even at this point of time, there is a CDC guideline suggestion is telling that it is even if you are vaccinated, if you are exposed to an individual who is COVID positive individual, it is better that you isolate at least for 3 to 5 days. No handshaking, that is very important. And obviously, because these things, what I mentioned is not confined to those. Obviously, we need to add a lot of common sense to the day-to-day life. Obviously, you try to avoid the overcrowding as much as possible. So you try to do online, mobile messages, purchases, meetings, greetings, etc., etc. Travel only if necessary. Store essential adequately, avoid crowding, drugs, etc. Food and all. If you can stock in advance, that'll be the best thing to do. Avoid marriage gathering, religious gatherings, conferences, virtual, etc. Virtual conference. This should be the way to do it. We are currently doing. And common sense is not so uncommon. We know from all in our own experience. And, I just want to again stress, the distancing socially is very, very important. And there is no need to, overemphasize that. And obviously, namaste is the way to go. No handshaking, which I already mentioned. And coming to the healthcare workers, all the healthcare workers in the healthcare settings need to wear a 3-layer mask. I will say that these healthcare workers who are in the NOI, non-COVID setting, need to wear the 3-layer surgical mask. But even if they are working in non-COVID, non-COVID settings, whenever dealing with the aerosol generating procedures, like, the big list which I mentioned here, bronchoscopy, CPR, chest physiotherapy, high flow oxygen, non-invasive, all these big list of things, tracheostomy, tracheal intubation, extubation, etc. You need to wear, the N95 mask, higher level, respirators. So this N95 mask, And obviously, the healthcare workers who are working in the COVID area, definitely at this point of time, they need to wear the mask, the proper respirators, along with the proper PPEs, appropriate PPEs need to be worn. The all healthcare workers, and obviously, the most and the foremost thing for not only for the healthcare workers, for the entire community is the vaccination. Not only that you get vaccinated, you need dear and near ones to get vaccinated. So my message is very simple. The COVID appropriate behavior need to be followed always. Avoid men and follow women. The mnemonic which I already mentioned. And finally, vaccinate. Thank you very much for a patient listen.
Dr. Ajit, thank you. Excellent talk. We will avoid the men and follow the women.
Thank you. Thank you.
I like to mention one thing. Dr. Ajit Kumar is from Manipal Hospital, Bangalore. Sorry for the typing mistake, sir.
Yes, I did notice, but that is immaterial. No worries. Thank you.
May I request Dr. Aditya to please conclude?
So with this, we conclude our day 1. Rest sessions time will be taking place in Hall A, and further sessions of Hall C will initiate tomorrow morning from 11:40 a.m. Thank you all for your precious time and knowledge. Thank you.
Thank you, everyone.
Thank you. Thank you.